So good morning, friends. We are going to start the second day's scientific program with very interesting and important topic of stress management for doctors. So this is really important given the scenario of increasing violence against doctors as well as stress related to patient, legal implications, breaking the news. So that is decreasing the faith in doctors by the people. So we need to stress and manage the stress. So for that, I invite Srishti and Khushi for the day's scientific proceedings. So they are going to start with the formal scientific sessions. Thank you very much.
Good morning, everyone. I hope you all had a productive and insightful first day at the conference. Welcome to the second day. We are thrilled to have you with us for another engaging and enlightening series of discussion. This morning, we are diving deep into a topic that resonates deeply with every healthcare professional: stress management for doctors. Being a doctor is a profession of passion, empathy, and service, but it also comes with its unique set of challenges. Balancing long hours, emotionally taxing situations, and the pressure to provide the best care while managing personal life can be overwhelming. We often overlook the fact that behind every stethoscope beats a human heart filled with emotions, fear, and drama.
So, to remind you all, we have a panel discussion on stress management for doctors. A panel discussion is an engaging format where a group of experts come together to share their insights, experiences, and perspectives on a specific topic. This encourages a dynamic exchange of ideas and allow us to delve deeper into complex issues. Today, we have a fantastic lineup of panelists who will be sharing their knowledge and answering your questions. I encourage everyone to actively engage your thoughts and questions what make this discussion valuable. So, don't hesitate to participate during question and answer session.
Without further ado, let's invite our esteemed panelists on the stage with a huge round of applause. Dr. Jaiwal sir, Dr. K.K. Nohria sir, Dr. Gurvinder Pal sir, Dr. Rakesh Kakkar sir, and Dr. Archana ma'am. And we have our moderator, Dr. Akhilesh Pathak sir.
Okay, before proceeding further, we would like to share brief introduction of our respected panelists and moderator. Our first panelist, Dr. Jaiwal sir, Associate Professor and Head of Department of Psychology at School of Social Sciences at Central University of Punjab. He is an annual member in American Psychology Association and also in American Education Research Association USA. He had been a coordinator of Department of Public Administration for 2 years in Central University of Karnataka. With more than 10 years of experience, he will share insights on how mental health care and therapy can help doctors cope with stress in their professional lives.
Our second panelist is Dr. K.K. Nohria sir, consultant physician at Nohria Hospital, Bathinda. He is a member of General Medicine Committee on MediSage. He has always been a strong advocate for physical wellness and has led several initiatives to incorporate mindfulness, self-care, and resilience-building practices into the lives of healthcare professionals.
And then we have our third panelist, Dr. Gurvinder Pal Singh Sir. He is professor and head of Department of Psychiatry at AIIMS Bathinda. He is a life member of Indian Medical Association with over more than 25 years of experience. He has been awarded with 4 National Conference Awards and 4 North Zonal Conference Awards. He will share his first-hand experience and offer practical tips on balancing a demanding career with personal well-being.
Our fourth panelist is Dr. Rakesh Kakkar sir, who is a leading figure in the field of public health and community medicine. He serves as the professor and head of community and family medicine at AIIMS Bathinda. He has a remarkable career dedicated to public health and medical education. His contributions have been widely recognized, earning him several prestigious honors, including the IAPCM Presidential Appreciation Award, IPHA Fellowship in 2023, and many more. We are honored to have Sir with us today to share his valuable insights on stress in medical profession.
Our next panelist is Dr. Archana Nimesh Ma'am, Assistant Professor in Department of Biochemistry at AIIMS Bathinda. Ma'am have been a part of many research projects related to postpartum depression, diabetes, fetal-maternal metabolism, and medical education. Ma'am is also a coordinator in yoga and medication at AIIMS Bathinda.
As our moderator, we have our own Dean Academics, Dr. Akhilesh Pathak Sir, Professor and Head of Department of Forensic Medicine with a distinguished career spanning over 23 years. He has not only made significant contribution to medical advancement of forensic medicine, he has been honored with numerous prestigious awards, including the Eminent Scientist Award in Forensic Medicine, the Iconic Professor and Researcher Award. It's clear Pathak Sir is not only a leader in his field, but also a mentor and guide for many medical professions. Please join us in welcoming Dr. Akhilesh Pathak Sir to take over and lead us through today's discussion. Sir, the stage is yours.
Today we are having a good panelist with us. And as we all know that this is the topic which is recently more and more talked all over the nation regarding the stress, especially amongst the medical professionals. And in many of the news articles and all that we have seen that some of the students they are taking the suicidal step, or they are committing suicide, or some of the medical professionals because of the stress they are doing such kind of the thing. So recently a meeting was conducted by the National Medical Commission with the directors and VCs in Delhi, and I was the part of that also. I raised this question. I raised this question in that meeting. The sir was asking that what are the issues in your institution. So that, because I am working as a dean academics from last 1 year, and I have observed that the some of our students, they are having this kind of the problem. we are getting the students in AIIMS but India from all over India, from the different cultural background with different languages and all things. And some of the students succumb due to the various problems, and they are not able to cope up the stress because of the many reasons. When I noticed this, then I requested to NMC chairman sir in the meeting that sir, there is only my one concern that this issues should be addressed in medical colleges. And after that, immediately after this, a note down and a survey was conducted by the Medical Council of India. And we all know that the results of the survey were very shocking. And around 38,000 doctors responded in that survey. And surprisingly, 80% of the students and the medical professional accepted that they are under the stress of moderate to severe degree. So the results were shocking. And after that, again, we all know that the NMC has prepared a task force regarding the same, and they are doing the trainings and all that in various parts of the country. And definitely, we in AIIMS Bathinda, we are also trying to address this issue by the various means. And we are having the regular yoga classes, meditation classes, and various support system, as well as the other systems in our AIIMS Bathinda. And with this, I'm very thankful for accepting our invitation and giving us the opportunity by Dr. Bitul Gupta and MAPICON organizing team for choosing this topic and giving us the opportunity to discuss this topic as a for this panel discussion. So I'm glad that we are having the experts with us, the department, the HOD of the Department of Psychiatry in AIIMS Bathinda, Dr. Gurvinder Pal Singh sir. So a big round of applause for Gurvinder Pal Singh sir. So he is the key person. So whenever our students need, so he's guiding us. The whole department is helping us in various form, and even when the treatment is required, it is always done or offered by the sir. Then again, we are having one more expert in the same field, that is Dr. Jaiwal sir. He is head of the department in Central University of the Punjab in the psychology department. So again, we are having the one more good addition in this panel who can give the expert advice. And you know, all these things, what kind of support system we are having. So we are having one more important person with us who is providing the different meditation, counseling, yoga classes to our students who are under stressed. And we have received means wonderful results with that. So after attending these classes, the students who were in stress, they did extraordinary. So with that, the person who is helping us in AIIMS Bathinda, Dr. Archana. So Dr. Archana Nimesh, she is doing wonderful job behind the curtains in AIIMS Bathinda and helping our students. And you know, all these things cannot be completed without the community services. So if you are not providing the services to the community, then it doesn't mean anything. And we are again having the one of the best expert with us from the community and for family medicine, Professor Dr. Rakesh Kakkad sir. Thank you, sir. And after that, in the panel, we are having our Dr. K.K. Noria sir, who will tell us regarding that what kind of the stress are there amongst the practicing doctors in Malwa region. Sir is very senior and working and practicing since long, and he know actually the what kind of the problem comes. So we are having a good combination of the panelists here, and now we can start the panel discussion. So I would like to request to the audience to participate actively, and they can ask the questions from the our panelists. So I will require one of the person who can help in providing the mic to the to the audience, and they can ask the questions.
Good morning, sir. My question is, what can be done to encourage doctor to seek mental health support without the fear of professional repercussions?
So, Dr. Gurvinder Pal, sir.
Very nice question. Question is because psychiatry branch has a lot of stigma. मेरे पास बहुत आते हैं पेशेंट कहते हैं डॉक्टर सर नहीं आपकी ओपीडी में नहीं आना प्लीज सिट डाउन तो इसमें स्टिग्मा बहुत है तो इसका सबसे बड़ा एक ही सलूशन है कि इसमें हम कोई ऐसा एक ओपीडी में रजिस्टर लगाएं जिसमें वो खुद आके अपना नाम लिख ले और वो उसको पर्ची ना बनानी पड़े उसको जैसे हम पहले थे ना तो वो एक रजिस्टर लगाया हुआ था तो आराम से आए अपना नाम लिखें बायोडाटा लिखें सिग्नेचर करें स्लिप ना लेनी पड़े क्योंकि जब स्लिप बनाते हैं तो उनको लिखना पड़ता है साइकियाट्री तो उसमें बहुत स्टिग्मा होता है नंबर 1 नंबर 2 जैसे अब आप देख रहे हैं कि हमारे डीन सर बहुत अच्छे हैं मतलब हमारी सारी साइकियाट्री जो है अब साइकियाट्रिस्ट के हाथ में नहीं रही है इतनी प्रॉब्लम ज़्यादा है जब अभी फिगर दे रहे थे सर फिगर बहुत अच्छा हाई है सभी को रल मिल के करना पड़ेगा तो हमारी बहुत खुशकिस्मत है कि वितुल गुप्ता सर अखिलेश पाठक सर अगर ऐसे पैनल डिस्कशन होंगे जहाँ पे आपके क्वेश्चंस होंगे अगर आप देखेंगे स्ट्रेस क्या होता है स्ट्रेस जो है ना इकट्ठा होता जाता है मतलब एक देखेंगे ना भरता जाता है तो वो एकदम ब्लास्ट करता है अगर आप उसको जैसे आपको इसकी नॉलेज होगी तो ये बहुत अच्छा होगा जितने भी मेंटल इश्यूज हैं उसमें अगर आप देखोगे कि किसी को 97 डिग्री टेम्परेचर होता है 98 होता है देयर आर साइकोलॉजिकल प्रॉब्लम सर भी यहाँ पे बैठे हुए हैं जैसे 99 डिग्री होता है तब फीवर होता है so there is psychological problem then there is a fever 100 होगा 102 that is a problem जो psychological problem है उनको आप solve कर सकते हैं various coping techniques है simple techniques है फॉर्चुनेटली हमने एम्स बठिंडा में एक टेक्निक डेवलप की है मैं बाद में बताऊंगा वो बहुत एक्सेप्ट की गई है तो उसके ये करके ये डिस्टिग्मेटाइज कर देगा इसमें हमें एडमिनिस्ट्रेटर का रोल है हमारे डीन सर बहुत अच्छे हैं देखो इन्होंने ये रखवाया ये मेरी चॉइस नहीं थी इन्होंने इतनी मेहनत की है सबसे पहले इस हाल में हमारे डीन सर थे अगर सारे लोग मैं आपको बिल्कुल ये एक्सपीरियंस से बता रहा हूँ अगर आप टाइम पे जाएंगे ड्यूटी पे 9 o'clock मीन 9 o'clock नहीं है 10 मिनट पहले जाओ अगर आप टाइम पे जाएंगे अगर आपकी ट्रेन 4 बजे है अगर आप 30-50 में जाएंगे कोई भी काम अगर आप 5-10 मिनट पहले जाएंगे तो आपको स्ट्रेस होने का कोई चांस नहीं है तो सर पहले आगे थे तो इससे करके डिस्टिग्मेटाइज हो सकता है तो ऐसे पैनल डिस्कशन और चाहिए थैंक यू सर
Any other question?
Good morning, sir. So I would like to ask what advice you would like to give to young medical students or young doctors as they enter this profession. Advice regarding their mental health to young doctors and medical students.
Hello. First of all, you please sit down. First of all, thank you, sir, for this wonderful opportunity to talk to medical professionals. It is very important today for all of us because it is a very important concern for everyone, the stress. Actually, few minutes before when we were sitting, sir came. So, sir came with the important trouble which he has gone through in the recent time. Oh, it happened like this yesterday. I was about to go late for my office because of that trouble which was there on road. There was a farmer's some protest, so he was not able to go. Likely, there are different contexts in which we are getting into stress. It is important for all of us to understand first what is this stress, where does it come from, what are the different sources through which we are getting into stress. This topic is becoming very complex because it is not universal to all of us. It is very specific to one individual. Probably the boy who was asking the question may be having a unique stressor which gives him stress. Other person may not be having that stress for that particular stressor. This is very important for all of us to know what is stressful for me need not to be stressful for other person. So in that case, our understanding about what is stress first gives you some alarm. Oh, what can I do in order to cope up with that? Actually, the 50 years of medical researchers and psychology researchers has seen stress as bad. If I ask you the question, we were using this term stress and distress quite alternatively, right? How many of you would feel stress is bad? Please raise your hands. Okay. But recent research has taken a turnaround in that idea of seeing stress as bad. They have started having a different connotation which is known as stress mindset. Stress mindset is something what we have as a belief whether stress is good or stress is bad. Actually, when we look into the consequences, what we see out of stress is more dense or more focused on people who believe stress is bad than those who believe stress is good. So we call it in psychology like stress enhancing mindset and stress debilitating mindset. Actually, this belief is the reason for creating the consequences for the person. It is not that stress as such. If stress is having ability to create the consequences, it has to give the trouble to all people uniformly. Whereas it is not having the strength to give the consequences uniformly, it troubles to the person who see that stress is going to affect him. So in the biological explorations, whatever has been done at Sun now, there are certain combinations which is getting a unique difference in the person who is believing stress is good for me to the another person who is feeling stress is bad for me. Probably on one stressor you may be having more impact, whereas for another stressor you would be saying, oh, this is okay, fine, I can able to handle it easily, right? So the consequences would be there for the first one differently than for the second one. So as a medical professional, I would request all of you to have the right understanding about what is that giving you stress to you. And once you have the right understanding, there are steps you can take in order to manage or in order to reduce or in order to modify that so that you would be having a better outcome rather than getting into any wrong consequences. Thank you.
Thank you, sir. Now, I would like to request Dr. Archana to put some light on this, that how can mindfulness and meditation help in reducing this stress related things, especially in medical profession.
Good morning to you all. Thank you, sir. First, as sir told that you should be knowing what is stress. तो स्ट्रेस के बारे में मुझे आपको ये बताना है, एनीथिंग विच इज़ रिलेटेड टू यू, जिसको आप डील नहीं कर पा रहे हो उसी को आप स्ट्रेस लेबल करते हैं, है ना. आप उसको हैंडल नहीं कर पा रहे, आप उसमें खुशी फील नहीं कर रहे, ठीक है, आपको रिजल्ट्स नहीं मिल रहे आपके अनुकूल. सो ऑल दीज थिंग्स यू स्टार्ट लेबलिंग एज स्ट्रेस. ओके, सो ऑल दिस स्टार्ट्स विद the overthinking or the negative thoughts that come into your mind. Okay, and at that time you are not able to get to a solution. So एक समाधान आपको मिल नहीं रहा होता है कि ये मेरी समस्या है और अभी मैं क्या करूँ, ठीक है. your inner power or the way of thinking to deal with that you are not clear about. Okay, so at that time you need help. तो इस स्टेज पे जब आप स्टूडेंट के स्टेज पे हैं और हमारे पास हैं, तो आपकी वेरियस टाइप की सिचुएशंस हैं जो फ़िलहाल एडल्ट से थोड़ी डिफरेंट हैं. तो उसके लिए मेरी आपको एडवाइस यही है कि आप हो सके तो अपने मेंटर को अप्रोच करिए, जो भी आपके अलॉटेड असाइन मेंटर्स हैं. अगर आपको वहाँ पे अपनी प्रॉब्लम्स डिस्कस करने से, जो एकेडमिक से रिलेटेड भी हो सकती हैं, आपके अपने पर्सनल जीवन से रिलेटेड भी हो सकती हैं, ठीक है, रिज़ल्ट, एग्जामिनेशन, ये सारी आपकी कॉमन समस्याएं हैं जो मैंने फ़ील किया जब स्टूडेंट्स मेरे पास आए और इनके आप हल चाहते थे. अगर आपको लगता है कि वहाँ पे मेंटर के पास पहुँचने से आपकी हेल्प नहीं हो रही है एंड देयर कुड बी मेडिकल रेपरकशंस टू दैट, कि आपको कोई पेनलाइज करेगा अगर आपने कोई बात सामने रखी, तो ऐसी बात नहीं है. फिर आप योगा एंड मेडिटेशन कमेटी के पास आ सकते हैं. तो यहाँ पे हमारा एक संगठन है, एक ग्रुप है जिसमें हम आपकी मदद कर सकते हैं, जिसमें हम आपको पॉजिटिव चीज़ें जो थॉट्स हैं आपके जो नेगेटिव है, सो इमीडिएटली आपकी हो सकता है सर्कमस्टांसेस ऐसे होंगे जिसका आपके ऊपर कोई कंट्रोल नहीं है, यू वुड वांट टू चेंज देम इमीडिएटली, ओके, बिकॉज यू आर नॉट एबल टू डील विद दैट। सो वो हो सकता है कि संभव ना हो, लेकिन आपको फ़िलहाल के लिए तो उन बातों से डिस्कनेक्ट करना होगा, अपने मन को शांत करना होगा। So how does that happen? So there is in the role of this mindfulness and the meditation. Okay, so these are the techniques wherein we teach you how to calm yourself down. Okay, आप breathing exercises कर सकते हैं, positive thoughts हम आपको सिखाते हैं उसके अंदर। So ये सारी चीज़ें करने से जब आपका मन शांत होता है, तब आप उस शांत मन के अंदर आपको ऐसा फील होता है कि हाँ, ये समस्या इतनी बड़ी तो नहीं है जिसके लिए मैं इतना परेशान हो रहा हूँ, और जो ट्रांसलेट हो रही है इनटू माय एकेडमिक परफॉर्मेंसेस, या फिर मेरे कुछ हेल्थ इश्यूज़ होने लगे हैं जिसके लिए मुझे एक दवाई सीख करनी पड़ रही है। तो ये सारी चीज़ें हैंडल हो सकती हैं, क्योंकि ये इनिशियली जो स्ट्रेस होता है एकदम से नहीं होता, इट्स अ ग्रेजुअल प्रोसेस स्टार्टिंग फ्रॉम नेगेटिव थिंकिंग, and then when you start transforming that into positive thoughts, and then you repeatedly practice these thoughts, initially it may require some time and effort, but slowly and slowly it becomes a very natural way of living your life. Okay, तो आप इन सारी चीज़ों को, इन अभ्यासों को आप प्रैक्टिस कर सकते हैं, ठीक है। माइंडफुलनेस और मेडिटेशन के टेक्निक्स, ब्रीदिंग एक्सरसाइजेज या और कोई लाइफस्टाइल एक्सरसाइजेज, हेल्दी लाइफस्टाइल एक्टिविटीज़ जो हम अक्सर कराते रहते हैं, सो आप इसको अपने जीवन शैली के अंदर शामिल करें, और मुझे ऐसा लगता है कि ज़रूर लाभ मिलेगा। ऐसे काफ़ी सारे स्टूडेंट्स हैं जो मुझसे पर्सनली आके कांटेक्ट किया, जिन्होंने और अपनी समस्या हमें बताई, और हमने उनको कॉन्फिडेंशियल भी रखा। तो आप निश्चिंत रहिए कि आपको मदद नहीं मिलेगी और ऐसी कोई परेशानी आपको आएगी। सो वी आर देयर टू हेल्प यू। सो मेडिटेशन के जो साइंटिफिक प्रमाण हैं वो सारे के सारे आप इंटरनेट पे देख सकते हैं, पबमेड स्टडीज़ हैं जिनके ऊपर ये सारे साइंटिफिकली प्रूवन है कि हाउ दीज हेल्प यू एक्चुअली। सो पहले आप इन चीज़ों को स्टार्ट तो करें, थोड़ा थोड़ा अपने जीवन में डिसिप्लिन लाएं, संयम लाएं, नेगेटिव थिंकिंग को कर्टेल करें, गुड कंपनी में रहें, ठीक है, हेल्दी खाना खाने की कोशिश करें, ठीक है, ये सारी चीज़ें अपने जीवन शैली में अपनाएं। उसके लिए डेफिनेटली एक फैसिलिटेटर चाहिए होता है, जिसके लिए यहाँ पे कमेटी है, आप उसके लिए अप्रोच करें। डीन सर अवेलेबल रहते हैं, काफ़ी इनकरेजिंग हैं इन समस्याओं को डील करने के लिए। सो मुझे ऐसा लगता है आप अच्छी जगह पे हैं जहाँ पे आपको मदद ज़रूर मिलेगी। थैंक यू सर।
Thank you, Dr. Archana. So basically, whenever you want to try this meditation or yoga, the important thing in this is the regularity. So you have to be regular, and remember, all these exercises are work in a group. So these are the basically group therapy. So whenever you will join in a group, definitely it will work. The group will encourage you to join. Your colleagues will be there. So thank you, Dr. Archana, for enlightening the importance of the meditation in the stress management. Now I would like to address that there are very important things that a doctor has to incorporate the self-care to manage the stress management. I would like to request to Dr. Rakesh Kakkal sir that how can doctor incorporate self-care into their daily routine to manage the stress. Kakkal sir.
थैंक यू सर। तो कुछ चीज़ें तो डॉक्टर अर्चना ने ऑलरेडी बता दी कि माइंडफुल एक्सरसाइजेस कर सकते हैं। सो वन इज़ मेडिटेशन, अनदर इज़ ब्रीदिंग एक्सरसाइज। योगा हैज़ मैनी ऑप्शंस फॉर दैट, एंड इट इज़ नॉट नेसेसरी कि आपको अगर ये नहीं ठीक लगता यही ट्रीटमेंट है। देयर आर अदर ऑप्शंस आल्सो, लाइक वॉट एवर इज़ योर लाइकिंग। इफ़ यू enjoy gardening, if you enjoy playing some musical instrument, आपको जो अच्छा लगता है जिससे mental peace मिलती है, that is the best thing for you. तो try to identify what is your hobby. अगर आपने छोड़ दिया तो उसको अपनाइए। आप अपना फ्रेंड सर्कल, एक peer group डेवलप होना चाहिए। शुरू से आप आइडेंटिफाई करिए कि मेरे बैच में कौन अच्छा है, या मेरे से सीनियर कौन अच्छा गाइड कर सकता है, कौन मेरे जूनियर उसमें जो गाइड कर सकता है। तो इस तरीके का आपको सेल्फ केयर के लिए एक डेवलप करना पड़ेगा। आप आइडेंटिफाई कर सकते हैं कि कोई ऐसा बंदा होगा जो हमेशा नेगेटिव ही होगा, तो ट्राई टू स्टे अवे फ्रॉम दोज पर्सन जो हमेशा आपको नेगेटिव थॉट्स ही दे रहे हैं। तो एक तो ये चीज़ हो गई। फिर आपको एक्सरसाइज 30 मिनट्स की एक्सरसाइज डेली करनी चाहिए। जिससे कि आपको एक कॉन्फिडेंस आता है लाइफ में और एक पॉजिटिव ये बनता रहता है। हमेशा हम लोग को बचपन में हमारे पेरेंट्स और एल्डर्स बताते थे कि आपकी टंग में एक बार सरस्वती माँ बैठती है, तो अगर आप नेगेटिव बोलोगे तो नेगेटिव होगा, इसलिए हमेशा पॉजिटिव सोचो, पॉजिटिव बोलो। तो इस तरीके का अगर आप एटीट्यूड रखोगे तो यू विल बी, हमेशा पॉजिटिव सोचोगे और आप पॉजिटिव साइड ही बढ़ोगे आप हमेशा। फिर कई बार आपको होता है कि हमने अपने लाइफ में देखे कि कुछ यस मैन होते हैं, हमेशा यस बोलेंगे, कुछ अपोजिट होते हैं, हमेशा स्टार्ट नो से ही करते हैं। तो देयर इज़ अ नीड ऑफ बैलेंसिंग, मतलब जब आपको लगता है कि ये मेरे से ज़्यादा हो जाएगा, इसको मैं हैंडल नहीं कर सकता, तो ट्राई टू से नो समटाइम्स बट बी रीजनेबल, कि हमेशा नो बोलना भी ठीक नहीं है। तो उस तरीके की हैबिट एक पालनी चाहिए। बाकी आपको अपनी जो हॉबीज़ हैं उसको अगर आप करेंगे और पॉजिटिव इनकलकेट करते जाएंगे, सो किसी की हेल्प करेंगे तभी आप वापस भी कभी ले पाएंगे पॉजिटिव भी। एक अभी पिछले दिनों में हम लोग ने एक स्ट्रेस मैनेजमेंट पे वो अटेंड किया, तो उसमें क्या कि अगर आपको कंटिन्यूस ऐसा लगता है कि स्ट्रेस है, तो 48 मिनट का रूल बनाया उन्होंने कि हर 48 मिनट में 1 मिनट का आप ब्रेक लीजिए, और जो भी आपको भगवान को याद करना है या कुछ म्यूज़िक सुनना है, या 1 मिनट थोड़ा सा स्ट्रेस अवे करके फिर से आप अपने, जैसे पेशेंट देख रहे हैं और काफ़ी ज़्यादा ओपीडी है, तो 1 मिनट का 48 मिनट्स में अगर ले लेंगे, हो सकता है ये बिल्कुल ऐसा प्रैक्टिकल ना हो कि एग्जैक्टली 48 मिनट नहीं, बट थोड़ा थोड़ा सा एक ब्रेक लेना। जैसे ऑप्थेल्मोलॉजिस्ट भी बताते हैं कि लगातार अगर आपका आई का वो है तो आपको थोड़ी देर आंखें बंद करनी चाहिए। तो इस तरीके के ब्रेक्स लेने से भी आप रिजुविनेट होते हो। और कई बार अपने, अगर आपका कंटिन्यूस स्ट्रेसफुल है तो कहीं पे घूमने जाइए, कुछ करिए, जहाँ पे अपनी फैमिली के साथ जाइए, अपने फ्रेंड्स, अपने पेरेंट्स से बात करिए, तो वो भी एक पॉजिटिव सोशल एक्टिविटी है जिसको प्रमोट कर सकते हैं। थैंक यू।
Thank you, sir. Now I would like to ask Dr. K.K. Noria, sir. K.K. Noria, sir, is a senior physician working here with so many patients in this Bathinda and Malabar region. Sir, what kind of common causes you think that these are the common causes of the stress in professional or general physicians they are having?
Thank you, Dr. Pathak. First of all, thanks to be a part of this panel today. And he has really touched the topic, you see, which is very close to my heart, to see what are the causes of stress. And if we start counting the causes, probably I don't think, you see, there's any limit to the causes of stress. Because the cause for everybody may be different, you see, may not be same for everybody. So when we talk about, बात कर ही रहे हैं, तो मैं अभी पहले भी बात कर रहा था कि almost more than 50 years ago, when I took the admission into the medical college, that was the first time I learned the word tension. I mean, you see the difference in the last 50 years, how the things have grown. You see, we are today discussing this topic, stress in general and stress particularly in our profession. And over the years, you see, it has increased so much, you see, that we have now trying to devise various systems to how to protect our students, how to take care of those students, you see, from increasing stress of life. So that now I feel personally, मेरी अपनी ये मानना है कि अब तो जो stress है medical college की तो बात छोड़ो, probably it starts from the vitro only. You see, the moment you see the lady gets pregnant, you see, you go for the ultrasound, you go for this, and you for all these things, you see. Probably all these things, they do add to your stress in life. And the moment then you are born, you see, then it all starts from there onwards. And then you see probably the peer pressure. The second important thing is sharing the responsibility. Unfortunately, because the system today is of the nuclear family, we used to have a very sort of big families, you see, and out of that, you see, people used to share their responsibilities. मैं आपको इसकी छोटी सी examples बताता हूँ, personal है. My son, you see, before going to the medical college, He has never ever, even if I have to ask him to buy a piece of bread, you see, a loaf of bread, you see, he couldn't do that. Simple reason, because we never ever tried to put this responsibility on him, you see. And the moment he went to the medical college, he found, every time he was ringing, "Maine bread leke aani hai, kahan se leke aun?" You see, this is sort of a thing, you see, which puts a stress on it. So I personally feel we must, as a parent, try to give responsibility and share sort of whatever their feelings are, you see, we must share with them, you see. That is important, very important. The other thing is why we are increasing is, again, as you told, the nuclear families. There was a data that in general population and in doctors, before going to the medical college, the stress level was the same. The moment the boy enters into the medical college from the first year onward, the level of stress is much more than in the general population. Again, the academic pressure, maybe financial pressure, all these things, you see, they add to the stress in life. That's why, you see, the other thing I keep on telling everybody, it is the duty of our teachers also, that he is not only your teacher, he should act like a guardian also. That he should try to pick up out of the class, you see, if anybody is not interested, somebody is not. So that means he is the one, you see, who can choose if somebody is having stress or not. The other thing is, even among your friend circle, you see, a lot of people, you see, they are living, you see, in the sort of a common sort of roommates हैं, तो अगर वो एक दूसरे से शेयर करेंगे, क्योंकि most of the time people think, you see, psychiatry or tension or depression is a stigma. They don't come out with it, you see. Most of the time, even in my practice, you see, if I only ask few questions, then they start crying, weeping, and then I suddenly realize that they are depressed. So that is very important, you see, questioning, listening, and answering. If you just take 10, 15 minutes and spend on the patient, on the students, and you immediately come to know that the person is stressed. The last thing I want to add is that in all medical colleges, there should be once a week, in the afternoon, maybe for 2-3 hours, there should be a class where the students should be brought in groups and it should be discussed among them, you see. Then we can pick up if anybody is depressed, then how we can treat and how we can help him. That's all. Thank you.
Thank you, sir. So one of the important thing what the sir is trying to say, that communicate. Communicate with your colleagues, communicate with your parents, whatever the problems if you are having or if anyone is having, please communicate to your near ones, dear ones, or your colleagues. So at least you can release some of the stress in that way. Now I would like to request some of the, can we have some of the questions from the audience? Yes, Mike, please.
Good morning, sirs and ma'am. So basically coming from school life and coaching, where we know it's highly competitive, we are only focused on ourselves. And then we are here in college where it's a more holistic approach. We require a more holistic approach. We require to step out of ourselves, right? But we still have that competitive mindset, right? And the pressure, academics, all of a sudden we're required to, look up Guyton, Grays, all these terms, all these words, so new to us. And it's all of a sudden, right? Because what did we learn in 11th, 12th? What are we learning here? Same competitive mindset. And we are, we have that thing. We need to get the most marks. We need to get the highest marks. But I feel that's not really necessarily. A lot of people keep saying you just need to pass, right? But is there a way to encourage students to keep that thought process that you just need to pass the exams? These do not impact your career as a doctor. These do not impact how you are or you will be in the future as a doctor. These are not that important. These professional exams, you just need to pass so that you can carry on. Is there a way to encourage this thought process?
Dr. Jayawal, sir.
Yeah, please sit down. So as I was telling earlier, the role of stress on individual is very specific to that individual. How you are going to see that is going to have the impact for you. Probably other person who is not having that type of high aspiration in terms of getting a top ranking, he may not be bothering for that, whereas you would be having much botheration for that, right? It is right time for all of us to know the medical students are the creamy layer of the community, right? So since it is a creamy layer of the community, it doesn't mean that medical students all need to have only highest level of mental health, right? For that, we need to understand what is mental health as such, right? Even though when we were talking about mental health, we were talking about the serious issue which the particular individual is facing. It is not that mental health mean. Mental health mean what is that potential you have if you could able to execute that to the maximum possible way. That is what we call as mental health, right? If somebody is having a very high potential, probably if they could able to execute that to that best possible way, and if that is not reaching to the top person, but even if it is reaching second or third or even 10th, that doesn't have any role, that doesn't have any meaning. What is best in you, if you could able to give that correctly, that is what we call like mental health. In that case, mental health is common to all of us. At times, I may also need certain assistance in terms of handling my mental health, and each one of us may need to have that assistance when we feel, am I doing things correctly? If I have any question on that, there is nothing wrong in taking assistance from the psychologist or the psychiatrist, right? If we are getting into fever is there for 2 days, we go to doctor and we get treatment very easily with the help of doctor. What is the problem in coming out with the services available for taking help for the psyche, right? So body and psyche is having a very tight bondage, right? But we are not worrying, or we are not having any bad effect for going for medication or going for assistance for our body. What is the problem in worrying for taking assistance for the psyche? There is no need for having a difference, because how your body is having trouble, similar way your mind is also having a possibility to get into trouble. The trouble can be like temporary, or the trouble can be little longer or little bigger. If it is bigger, you need to take little longer time care. If it is temporary, you can get the assistance so that you will be felt free very easily, right? So if a person faces such type of condition, definitely they need to cross check with the professional whether the condition which I am going through is correct, or the trouble which I am facing is okay to handle, or I need to have certain modification in me. With the help of counseling, it is possible to get remedy. Thank you.
I want to add, just 1 minute, bas. To your question, beta. Actually, what we need is confidence. Stress always is not bad. You see, अगर स्ट्रेस होगा तभी आप सोचोगे कुछ करने लायक हो गए. अगर स्ट्रेस ही नहीं होगा तो फिर आगे सोचोगे कैसे? तो स्ट्रेस इज नॉट ऑलवेज बैड. स्ट्रेस अच्छा भी होता है. मैं डॉक्टर वितुल गुप्ता वाली एक बात हम कई बार डिस्कस करते हैं कि कॉन्फिडेंस लेवल होना चाहिए. जब भी हम बैठते हैं, आप समझो कि सामने वाले सब बेवकूफ़ हैं. अगर आप उस कॉन्फिडेंस से बात करो तो देन यू विल बी सक्सेसफुल. अगर आपको समझोगे कि मेरे पास कम्प्लेक्स है, मैं इन्फीरियर हूँ, फिर आप कभी बाहर नहीं आ पाओगे. तो एटलीस्ट यू नीड गुड कॉन्फिडेंस प्लस superiority complex. That will help you to come out of this situation. Thank you.
Thank you.
I think there is a difference between theory and practice. Madam was telling about the counseling session. So if some boss is troubling a junior resident or senior resident under stress, system is like that. If you are going in for duty for 36 hours or 12 hours, you don't have a good room, and how can the counseling is going to help you? Nobody can help you. You cannot say, go to the madam and stress relieving counselor कि मेरा boss ही मेरे को तंग कर रहा है यार, कैसे बोलोगे आप? The incidents happened in Kolkata that has exposed the condition of medical students like never before. जो बात छुपी हुई थी वो सामने आ रही है. जो पढ़ने की बात कर रहे हो, that is definitely good, because our education system is that. जितना आप खाते हो उतनी उल्टी करते हो, वो इंटेलिजेंट आदमी है. अगर आप 3 क्वेश्चन पूछ ले, लोड ही नहीं यार, 3 क्वेश्चन पूछ लेते हो तो योर टीचर इज गोइंग टू स्ट्रेस यू कि मेरे से ज्यादा अकलमंदी है, मेरे को तंग कर रहे हो. सो हाउ यू कैन डील विद दोस स्ट्रेसेस? यू कैनॉट. आप गंदे पानी एक साल कौन स्ट्रेस में रहा? आप लोग रोड पे जाते हो, कहना बहुत आसान है कि स्ट्रेस मैनेजमेंट कर लो। आपको स्ट्रेस क्या होता है कि मेरी स्कूटी पे ना मार दे कोई। रोज आप इंटरनेट पे देखते हो, इंस्टाग्राम पे देखते हो, बंदा जा रहा है सड़क पे, पीछे से आगे उड़ा गया कोई। तो जब आप देखोगे यू आर वॉकिंग ऑन दी रोड, यू विल बी स्ट्रेसफुल। So only thing is understand the system and raise your voice in the debate that doesn't harm you. अगर आप जाके काउंसलर को बोलोगे कि मेरा बॉस तंग कर रहा है, वो बॉस को बता देगा और बॉस में भी हैपन टू स्पाउस ऑफ दैट काउंसलर, आप तो फंस गए। I was talking to NMC chief yesterday that these colleges are having कि 40,000 पे साइन करवाते हैं, 15,000 पे देते हैं। How PGs will not be stressful? अगर वो NMC में शिकायत करेंगे, NMC कुछ नहीं करेगी। Were deprived of their exams because some college got extra money. मैंने NMC को लिखा, उनका 6 महीने एग्जाम लेट हो गया, और NMC बोर्ड that is a private university. कैसे स्ट्रेस दूर करोगे? कहाँ पे जाओगे स्ट्रेस दूर करने? So system is like that. Try to understand the system. If you understand the system, automatically you will कि ये तो होना ही है यार, ये तो खराब नहीं होना। ठीक है? So try to understand the situation. That will decrease your automatic stress. And what Dr. Maurya has told you, stress is sometimes good. और कई बार मेरा अपने से दूं, if I cannot go for a criticism of someone and don't talk and come back home, I am more stressful कि यार वहाँ पे बोला क्यों नहीं तू? Rather than expressing their whatever the case may be. But only thing is थोड़ा सा आपको ध्यान रखना कि आपका कैरियर ना कोई कॉम्प्रोमाइज हो यार। शॉर्ट में कदम शॉर्ट में। ठीक है? So there is a great disconnect between practice and
एक सेकंड
thank you.
तो उसमें सिर्फ एक ही बात है कि यू हैव टू कोप विद द सिचुएशन विद सिंपल रीजन कि ये अब क्या कि पार्ट एंड पार्सल हो गया, उसे हमें अपने आप को बीमार नहीं करना। अगेन बार बार मैं यही कह रहा हूँ कि कॉन्फिडेंस लेवल अपना ज़्यादा करो। ये चीज़ें हैं ना जो एग्जेक्टिव की यूज़ की, इसको मेरा मतलब हम इतने सालों से कर रहे हैं, ये बढ़ ही रही हैं, कम नहीं हो रही हैं। दे आर क्रिएटिंग मोर एंड मोर स्ट्रेस डे बाई डे। अल्टीमेटली व्हाट यू हैव टू समवेयर यू हैव टू कॉम्प्रोमाइज, ये सोच के कि मेरा अपना ठीक है, मतलब मैं अपने आप को बीमार नहीं करना, जो है वो ठीक है। तो अगर ऐसा एटीट्यूड रखेंगे फिर आपको स्ट्रेस नहीं आएगा। अगर आप स्ट्रेस लेंगे फिर तो बाहर अंदर जाना आना, फिर तो स्ट्रेस को कभी ख़त्म होएगा ही नहीं है। थैंक यू वेरी मच।
थैंक यू सर। सर गुरविंदर पाल सर कुछ कहना चाह रहे हैं, और मैं सर से एक और रिक्वेस्ट करूंगा कि नाउ दिस डेज वी आर हैविंग लॉट्स ऑफ द स्ट्रेस बिकॉज ऑफ द सोशल मीडिया। कि मैंने व्हाट्सएप पे ग्रुप पे मैसेज डाला, यार उसने थम्स अप नहीं किया, और ये थम्स अप उसका तो करता है, मेरे पे नहीं किया, ठीक है, और उसके पे तो 10 लाइक आए थे, मेरे पे नहीं आए, तो उस पर भी एड्रेस करें सर प्लीज़।
So may I take a moment? I think you were taking
Yes.
questions from the audience first. So I would like to say that us thinking that somehow stress लेने से हम अपने आप को affect ना होने दें is like saying that depression is in our control. I'm sorry, I completely disagree with that. Depression हमारे control में नहीं है. So if you're getting stressed, you cannot avoid stress 100% of the times. Situations that have been said, half of the times what I have gone through in my UG and PG were for no fault of mine. Then if I get stressed because of that and maybe I have anxiety or depression and saying that positive thoughts and stress से मुझे depression नहीं होना चाहिए is like saying everything is in your control, which it is not. So if you come to that situation कि तुम्हें कोई psychiatric disorder हो रहा है, it's not in your control. ठीक है, तो I think we should all keep that in mind, that stress lena is not always an option. So it's something that just happens and then you should go in for treatment.
We welcome Dr. Meghna. She's was senior resident in our department, now is assistant professor. She's also a psychiatrist. So इसीलिए मैं कह रहा था कि जब मैंने आप स्टार्ट किया कि हम डॉक्टर पाठक और डॉक्टर वितुल गुप्ता के बहुत थैंक्स हैं कि ये डिस्कशन हो रहा है। अभी अभी एक स्टूडेंट ने बड़ी अच्छी गाइटन की बात की, गेनोंग की बात की। अगर आपने हमारे जो प्रेसिडेंट सर आए थे रिवाड़ी से, उनका लेक्चर सुना होगा, तो मैं 2 बातें कहना चाहूँगा। आजकल लाइफ में ना रेस लगी हुई है, हर बंदा दौड़ना चाह रहा है। तो ये जो ज़िंदगी है ये रेस नहीं है, ये इंजॉयमेंट के लिए। तो ये ज़िंदगी हमें दोबारा नहीं मिलनी, ये आपको क्लियर होना चाहिए। डॉक्टर को दूसरा भगवान कहते थे पहले, कभी कहते थे ना, तो वो चेंज हो रहा है। इसका 2 चीज़ें हैं। WHO ने कहा है कि आप में लाइफ स्किल होनी चाहिए। उन्होंने एक लिस्ट दी है लाइफ स्किल, हमारी थिंकिंग स्किल, हमारी रिलेशंस की स्किल, उसको हमें डेवलप करना चाहिए। तो लाइफ स्किल हमारी खत्म हो गई है। आज से 50 साल पहले क्या होता था, एक फादर होता था, बच्चे होते थे, पूछ के जाते थे और पूछ के शाम को आते थे, कोई कोर्ट केस नहीं होता था। मकान भी कच्चे होते थे पर दिल उनके बड़े होते थे। अब लोगों के दिल छोटे हो गए हैं। तो ये जो स्टूडेंट की बात करें तो लाइफ स्किल बहुत है। एक सर ने बड़ी अच्छी बात की थी, मैं डॉक्टर पाठक को भी याद कराऊंगा, उन्होंने इमोशनल इंटेलिजेंस की बात की थी। अगर उसमें एक स्केल दिखाया था कि डॉक्टर्स का उन्होंने सर्वे किया, IQ इज वेरी हाई 120, दो बोथ एक्सट्रीम IQs आर वेरी, पर उनका EQ या इमोशनल इंटेलिजेंस वो 90 था। हमारे डॉक्टर्स की सबसे बड़ी, क्योंकि हमें डेथ और लाइफ से काम करना है, हमारी इमोशनल कॉम्पिटेंस बहुत अच्छी होनी चाहिए। जैसे अब सर कह रहे थे कि सिस्टम को एडजस्ट करना पड़ेगा, उसके लिए आपको मेंटली फिजिकली एडजस्ट करना, इसको इमोशनल कॉम्पिटेंस कहते हैं। वो हमारे डॉक्टर्स की बहुत कम है, ना ही इसमें कोई काम हुआ है। तो ये बहुत जरूरी है। मैं डॉक्टर पाठक को कहूँगा कि ये बहुत अच्छा काम कर रहे हैं, पर एक इमोशनल इंटेलिजेंस पे भी काम करना चाहिए। भी ये जो डॉक्टर्स हैं, दे आर गोल्ड मेडल, नीट टॉपर है। अभी आपने सुना होगा मुक्तसर में एक डॉक्टर नवदीप हुए हैं, मैं उनको जानता भी हूँ। उन्होंने भी अपनी लाइफ को इसलिए खत्म कर लिया क्योंकि हमारी इमोशनल इंटेलिजेंस बहुत लो है। 2 चीजें, एक लाइफ स्किल होनी चाहिए, एक इमोशनल इंटेलिजेंस होनी चाहिए। एक कभी भी डॉक्टर कक्कड़ ने बड़ी अच्छी बात की थी, हमें बीच में कुछ ब्रेक लेना चाहिए, चाहे वो ब्रीथिंग एक्सरसाइज करें या कुछ करें। तो मैं आपको 1 मिनट की ब्रीथिंग एक्सरसाइज सिखा रहा हूं। ये मैं पिछले 30 साल से खुद करता हूं। जब भी मेरी कोई इंटरव्यू होती है तो मेरे को बहुत बेनिफिट रिजल्ट होते हैं। जब भी मेरे को डायरेक्टर सर बुलाते हैं या डीन सर बुलाते हैं तो मैं कमरे से बाहर करके अंदर जाता हूँ, तो वो बहुत अच्छा होता है। पहले आप सोच के जाओ कि हाँ मेरे को डांट पड़ेगी, तो अगर जाके वो चाय पिला देंगे तो आपके लिए बहुत अच्छा होगा। तो वो एक एक्सरसाइज मैं आपको करवा रहा हूँ, आपको जिंदगी, आपकी सारी जिंदगी बदल जाएगी। हाँ, एक सर ने अभी ना हाँ हाँ, तो एक सर का हाँ, एक सर का ना बड़ा सोशल मीडिया का क्वेश्चन था, मैं उसका आंसर करके फिर वो आपको टेक्निक सिखाता हूँ। सर, जितनी भी प्रॉब्लम्स आ रही हैं, सोशल मीडिया का एटम बम से भी ज़्यादा पावरफुल है। ये सोशल मीडिया का बहुत नुकसान है। अभी मैं यहाँ पे हूँ तो मेरे फ़ोन बज रहा है तो मेरे को मैसेज आई जा रहे हैं, तो मेरा ध्यान वहाँ हो जाता है। इसको डिस्ट्रैक्शन कहते हैं। तो अगर आप इसमें जितनी भी स्टडी है, अगर आप स्क्रीन टाइम को एक उसको लिमिट बना लो, लिमिट सेटिंग कर लो, तो इसके बहुत बुरे रिजल्ट हैं। आप इसको घंटा बना लो, 2 घंटे बना लो, तो जितना ज़्यादा सोशल मीडिया में जाएंगे, क्योंकि सोशल मीडिया सच नहीं होता। अगर आप देखोगे तो जो हमारी लाइब्रेरी है, कभी आप हमारी लाइब्रेरी में जाना, 10 करोड़ की बुक्स पड़ी हुई है। वो बुक्स पढ़ना और सोशल मीडिया में बहुत अंतर है। तो आप जितने भी स्टूडेंट हैं, मैं आपको कहूँगा आप सिर्फ लाइब्रेरी में जाना शुरू करो, तो आपके स्ट्रेस वैसे ही कम हो जाएगा। तो मैं अब 1 मिनट की वो एक्सरसाइज करवा रहा हूँ, तो मैं चाहूँगा कि सारे प्लीज़ क्लोज योर आइज, कृपया आंखें बंद कीजिए। एक लंबी गहरी सांस लीजिए, सांस को रोकिए, मुंह से धीरे धीरे छोड़िए। एक लंबी गहरी सांस नाक से लीजिए। आप 4 सेकंड लेंगे, 4 सेकंड टोकेंगे और 6 सेकंड इसको बाहर निकालेंगे। लंबा सांस लीजिए, सांस को रोकिए, मुंह से धीरे धीरे छोड़िए। मन में काउंटिंग कीजिए, लंबा सांस लीजिए, 1 2 3 4 4 3 2 1। लंबा सांस लीजिए, सांस को रोकिए, मुंह से धीरे धीरे छोड़िए। शरीर में आए आराम को महसूस कीजिए, पैरों में आए आराम को महसूस कीजिए। लंबा सांस लीजिए, सांस को रोकिए, मुंह से धीरे धीरे छोड़िए। सब ठीक हो जाएगा। धीरे धीरे आंखें खोलिए, धीरे धीरे आंखें खोलिए। थैंक यू सर।
Can we have some more questions from the audience?
If there's any question.
Clarification. I'll add one more clarification in this. The idea which I was talking about stress and the way we look into stress is quite common to everyone. I do not reflect on the people, those who are having any type of diagnosable psychiatric illness which is having a biological component in it. I am talking about the group which is not coming under that category, but the other category, who are all considered like normal people, right? Every day we face all such stress. What sir was describing, like on the road you are going and somebody is coming and hitting. But when such things happen accidentally, how do you look into that gives you the opportunity, how are you going to handle this? The way you are going to cope with that particular situation is depending on what is that you tell to yourself, right? So try to see that in the right lens, and then accordingly you can able to cope well.
Any last question before we close this sort of session?
Do you think that overwhelming workload, including lectures, practical sessions, internal and professional examination, clinical postings, etc., increases anxiety in our students?
So actually, our students are having basically lots of the academic pressure in the different classes, practical, clinical, board attendance and all that. And even the junior agents, they are working means round the clock in the hospitals, dealing with such many of the problems. So how they should deal with that, because it is causing the stress among these students. Gurvinder sir.
मैं आपको ना बहुत अच्छा टेक्निक बताता हूँ जो मैं खुद करता हूँ। आपको ना टाइम मैनेजमेंट सीखना पड़ेगा। मैं एक कैलेंडर, मेरे आप रूम में आना, रोज कैलेंडर में एक दिन मैं काट देता हूँ। ये मैंने डॉक्टर मेघना से सीखा है। ये एक रोज दिन काट देते हैं। तो वी शुड गो मोमेंट बाय मोमेंट। जब आप क्लास में जाते हैं तो ध्यान से सुनो। जब आप वो 40 मिनट में सुनोगे तो आपकी सारी प्रॉब्लम सॉल्व हो जाएगी। आप ट्यूटोरियल में जाते हैं तो ध्यान सुनो। इसको प्रेजेंट मोमेंट कहते हैं। एक होता है पास्ट, एक होता है फ्यूचर। जैसे अब यहाँ पे आप सुन रहे हैं ना, बड़े अटेंटिव लग रहा है, आप बड़े ध्यान से सुन रहे हैं। जब मैं क्लास लेने जाता हूँ तो वहाँ नहीं सुनते आप। तो ये फर्क है। तो जैसे ही आप सुनेंगे तो आपको लगेगा कि आपको दूसरे भगवान कहा जाता है। हमारे ना क्वेश्चन कोई भी आ सकता है, हम उसको छोड़ नहीं सकते, कैसा भी पेशेंट आ सकता है। तो ये करिकुलम जो बनाया ना, बड़े बड़े महारथी लोगों ने बुलाया। जैसे डीन सर हैं, बड़ी मदद करते हैं। अटेंडेंस का होता है तो स्पेशल क्लास लगाते हैं। तो आप पढ़ाई को सेवा समझो। विद्या विचारी तब पर उपकारी। अगर आप इसको जॉब समझेंगे तो आप नहीं काम। आप ये सोचो कि हम सेवा के लिए आए हैं। जब आप में सेवा भावना आ जाएगी तो आपको क्लास अच्छी लगेगी। ये विद्या का मंदिर है जो हमारा एम्स बठिंडा, ये गोल्डन टेम्पल है। आप इसको समझा करो। जब आप इसको विद्या समझेंगे फिर आपको ये बर्डन नहीं होगा। सेकंड, तो इसको टाइम मैनेज करने से आपकी बहुत मदद होगी। मैंने स्लिप लगाता हूँ। आज मैंने स्लिप लगाई है कि 11 बजे तक यहाँ आऊँ, 12 बजे तक वहाँ आऊँगा। मैं एक पूरा टाइम करता हूँ, उससे मेरे को बहुत फायदा होता है। तो उसको काम रुकता भी नहीं है। थैंक यू सर।
Now I request small comments from all panelists. We will start from Dr. Archana.
देखिए, some of the students, again what I'm perceiving is that you all are troubled because of the peer pressure कि पास होना ही काफ़ी नहीं है, ये दूसरा क्यों नहीं समझता। ठीक है, ये ऐसा आप समझते हैं, लेकिन दूसरों को कंट्रोल करना आपके बस में नहीं है। ठीक है, जो सर्कमस्टांसेस या सिचुएशंस आगे जाके भी आपके जीवन में आने वाले हैं वो आपके कंट्रोल में कभी होंगे नहीं। सो आई वुड से learn to let go things। ठीक है, आप अपना वॉचफुल रहिए, जो आपके लिए पॉसिबल है आप वो करिए। जब हम कहते हैं कि हम पॉजिटिव थॉट्स, तो हम पॉजिटिव थॉट्स भी कब ला पाएंगे? जब आप अपने मन को पहले शांत करेंगे। ठीक है, मन को जब आपने शांत कर लिया, आपने लेट गो कर लिया, आपने डिस्कनेक्ट कर लिया फ्रॉम द नेगेटिव सिचुएशंस। अरे आपके मार्क्स नहीं आ रहे, ठीक है, आपसे कोई ऐसा व्यक्ति टकर गया, वो काफ़ी एडमेंट है, आपकी बात नहीं मान रहा। अगेन आप यही चाहते हैं कि अगला चेंज हो जाए, मेरी सिचुएशन ही चेंज हो जाए, मेरे मार्क्स आ ही जाए। दिस इज़ लाइक बीइंग टू रिजिड। सो यू हैव टू जस्ट लेट गो थिंग्स। सो ऑल दीज थिंग्स विल कम जब आप थोड़े से अभ्यास करेंगे, अपने अंदर पॉजिटिविटी लाएंगे, आप अपनी वैल्यू को समझेंगे। ठीक है, अपना कॉन्फिडेंस बिल्ड करेंगे, तो आपको फिर दूसरे लगेंगे कि शायद वो इतने शक्तिशाली नहीं हैं, इतना एम्पावर्ड नहीं है अंदर कि इस तरह की भाषा यूज़ करते हैं जो आपको स्ट्रेस देते हैं, तो आप स्ट्रेस लेंगे तो आपको स्ट्रेस फील होगा। तो अपनी इनर पावर को आप डेवलप करिए, और इसमें एक रोल रहता है ये सोशल मीडिया का, द कंटेंट आप वॉच करते हैं उसके ऊपर आप अटेंशन नहीं देते, ठीक है। तो अगर आप नेगेटिव कंटेंट आप देखते हैं, जस्ट फॉर एग्जांपल अगर आपने ऐसी कोई मूवी देखी, फिल्म्स देखे, ड्रामा सीरियल्स देखे जिसके अंदर काफ़ी वायलेंस चल रहा है, ठीक है, हीरो ने विलन को पीट दिया सपोज, तो आपको लगता है बड़ा जस्टिफाइड है, ठीक है, लेकिन कहीं ना कहीं आपको उसमें एन्जॉयमेंट मिल रही होती है, आपको हंसी आ रही होती है, अच्छा लग रहा होता है, ये तो जस्टिफाइड है कि हीरो तो विलन को पीटेगा, बट समवेयर यू हैव इन योर सबकॉन्शियस माइंड यू हैव ऑब्जर्व्ड टू एन्जॉय द वायलेंस, ओके। सो ऐसे, हाँ जी, सो इस तरह की चीज़ें जो है आप अपने कंटेंट के ऊपर थोड़ा सा अटेंशन रखें कि इसको आप मिनिमाइज़ करें, अच्छी चीज़ें देखें आप, ठीक है। और सोने से पहले आप ये सोशल मीडिया से डिस्कनेक्ट होने की कोशिश करिए, क्योंकि जो इन्फॉर्मेशन आपकी चले जाएगी दैन नेक्स्ट मॉर्निंग अगेन यू वुड वेक अप विद दिस नेगेटिव थॉट्स ओनली। सो इस चीज़ पे थोड़ा ध्यान दें।
मैं तो बस यही कहूँगा कि मैं बहुत शुक्रगुजार हूँ कि इतना अच्छा हुआ, ऐसे सेशन और होने चाहिए।
जैसे अभी कुछ ने क्वेश्चन पूछा था, तो जो भी चीज़ कर रहे हो उसको अच्छे से करो, पढ़ने के टाइम पढ़ाई करो, क्योंकि आपका एक पीरियड चल रहा होता है, आप दूसरा सब्जेक्ट कई बार पढ़ रहे होते हो, तो जब खेलने जाते हो तो अच्छे से खेलो, एनुअल फंक्शन है अच्छे से एंजॉय करो, जो भी चीज़ को उसको वो करोगे, हमेशा बैक दूसरी चीज़ मत करते रहो, यहाँ बैठ के कुछ और कर रहे हो, वहाँ बैठ के कुछ और, तो लिव विथ इन प्रेजेंट सिचुएशन, उसको एंजॉय करो और अपनी कुछ पॉजिटिव चीज़ें डेवलप करो, डेली एक्सरसाइज, और जो आपकी हॉबी है उसको करो, पॉजिटिव सोचो हमेशा, और अगर ज़रूरत हो तो कंसल्ट ज़रूर करो आके, वो ज़रूरी है।
So, what we see, the world is very small. It is from our own perspective. We need to know, or we need to embrace to see the world from the other perspective also, right? If we talk in the name of the discipline where you are expert in, or what you have known more of, you are similarly ignorant of the other discipline, which is good for the other person, right? So in order to get the better benefit, it is needed to have the collaborative effect to embrace the available knowledge together so that we can able to get the benefit for both of us equally. Thank you.
So thank you all our panelists, Dr. Archana, Professor Gurvinder sir, Professor Kakkar sir, Dr. Jaivel sir, Dr. Nohria sir, and the students and the other faculty members here present. Thank you all for participating in this meaningful panel discussion. So now I am moving, we are already running late and short of time. So we are moving towards the closing of this panel discussion now. Thank you all. And we will have some of the photographs outside, sir. Thank you.
सर यहीं पे कर लो जी, इतने ये थैंक्स करेगी. Please be on stage for a while. Yes, चल भी बोल.
I hope everyone found the conversation enlightening and thought-provoking. The diverse perspectives shared today, from psychological resilience to institutional support, remind us of importance of self-care and the role of a healthcare professional to enjoy their journey. Thank you to our esteemed panelists. Your expertise and perspectives have greatly enriched our understanding how we can navigate through the immense stress that comes to our profession.
As we come close to today's event, I would like to thank our audience for their active participation and thoughtful questions. Your engagement is what makes events like this truly meaningful. Lastly, I want to recognize the efforts of the organizing team who worked tirelessly behind the scenes to make this event possible. We have Arzu Qureshi, Taj Kochar as our IT team members and Saloni Manisha Diksha as our backstage coordination team. Thank you for your hard work and dedication.
Let's continue the conversation beyond today and work together to ensure that those who care for others are cared too. Thank you.
Thank you, Dr. Pathak. It was really very fruitful, and I think time was less. We did not anticipate the importance of this, panel discussion. So I think in next MAPICON, you will moderate 2 hours of panel discussion with the same panelists. So I extend invitation. We will fix the date on which day, and for 2 hours, you will be heading the panel discussion, same, and we can add 1 or 2 more depending upon the situation. Excellent organization, questions, and I must congratulate each and every panelist that they have deliberated on this important topic of stress management for doctors, and we need to, understand the system that will decrease our stress. Thank you very much. And please note, 18 to 21st September 2025, date and time we will discuss with Dr. Pathak, because he is a very, busy man. So we want to get his 2 hours for this panel discussion. Excellent deliberation.
Thank you, sir. Thanks a lot for the words of the appreciation. It means a lot for all of us. Thank you very much.
It was an amazing panel discussion. Now we'll start with the presentations for the today. Without further ado, let's call upon our first speaker for the day, Dr. Soumya Sengupta, Director and Consultant Diabetologist, Jharkhand, to present his presentation on clinical approach to diabetic foot in primary care.
Thank you, Dr. Soumya Sen, for coming all the way from Jharkhand to Bathinda, a remote place. So we are really thankful to you for visiting us and delivering a guest lecture on important topic, which is really great, but it is most neglected topic also. Thank you very much.
इधर आ जाएगा, थोड़ा सा इधर आ जाएगा, ये माइक No, it's okay. It's okay. Thank you. A very good morning to all of you. First of all, I would like to thank Professor Vitul Gupta and his entire team of this MAPICON for giving me this opportunity. So my topic is today, clinical approach to diabetic foot in a primary healthcare setting. Professor Gupta rightly said, though it's a very important, but it's a neglected subject in our day-to-day clinical practice. So if you look upon the overview and the magnitude of the problem, among patients with diabetes, 15% develop a foot ulcer, among them about 12 to 24% require a non-traumatic amputation. Diabetic neuropathy usually tends to occur 10 years after the onset of the disease, which leads to foot deformity, ulceration in the later course of the disease. All diabetic patients have an increased risk to develop foot infection and ulceration thereafter. Repeated trauma leads to collapse of the midfoot, which is also known as Charcot neuroarthropathy. Every 20 seconds a foot is lost due to complication of diabetes globally. Diabetic foot infection usually superficial, may be a little bit a small ulceration at the beginning, which can be easily overlooked by a clinician. And diabetic foot lesions are responsible for more hospitalization than any other complication of diabetes, and it has higher mortality than many cancers. Now the risk of the ulcer of amputation is increased 2 to 4-fold with the age as well as the duration of the diabetes. As the age advances, as the duration of the diabetes increase, the complications and the chances, the prevalence are more, like poor glycemic control, peripheral neuropathy, cigarette smoking, foot deformities, pre-ulcerative callus, corns, peripheral artery disease, and of course, previous history of foot ulcer. Even after successful management, the recurrence rate is about 66% and the amputation rate may rises up to 12%. Visual impairment, CKD, etc. So why do you perform a foot assessment? To identify foot at risk. Remember, whenever a patient comes to your clinic, from the day one, he is diagnosed as a diabetes, his or her foot has at risk of developing infection from the day one itself. So to prevent foot ulceration, gangrene, amputation, and to assist the maintenance of mobility, independence and healthy active lifestyle. Regarding etiopathogenesis, it must be determined before deciding the treatment plan. Multifactorial causes of ulcerations like osteolysis related fractures, dislocation and deformities, repetitive trauma, improper foot loading, microtrauma, metabolic abnormalities of the bone, etc. all leads to diabetic foot. In most patients, peripheral neuropathy, peripheral arterial disease, or sometimes both may play a major role. Therefore, commonly classified as neuropathic, ischemic, and neuroischemic. So, early detection and appropriate management can prevent this type of these complications. And this is a problem triad: neuropathy, ischemia, deformity, always associated with infection. Now, the clinical features, 3, like neuropathic, ischemic ulcer, and neuroischemic ulcer. Sensation wise, if you see, there is a sensory loss in neuropathic ulcer. In ischemic, usually is painful, and there is some degree of loss of sensation in case of neuroischemic ulcer. Wound bed pink and granulating, surrounded by callus in case of neuropathic ulcer. In ischemic ulcer, plain and sloughy with poor granulation. Foot temperature and pulse is very important. Warm with bounding pulses we see in neuropathic ulcer. In case of ischemic ulcer, cool with absent pulses because of peripheral arterial disease. Location is also very important. As you see in the picture, the weight bearing areas of the foot such as metatarsal heads, heel and over the dorsum of the claws, toes in case of neuropathic. In case of ischemic, tips of the toes, nail edges in between the toes and the lateral borders of the foot. And in case of neuroischemic, margins of the foot and toes are usually affected. Prevalence wise, neuropathic ulcer are mostly common. It's about 46.1% prevalent in India. So diabetic foot examination is the cornerstone of diabetic foot health. This is a very important test, a gait balance. While judging a gait of a patient in your clinic, you can assess the foot. You can assess, you can anticipate, you can diagnose a foot problem hidden inside. So this is the timed up and go test, very reliable. Patient arise from a chair with their using arm, walk 3 meters, turn and return to their chair and sit down. They are allowed to use their own walking aids. If it is less than 10 seconds, normal. If it is more than 14, abnormal. If it is more than 20 seconds, severe gait impairment. So in that case, you look carefully, examine carefully the foot of the patient. Musculoskeletal examination, like look for the range, strength of the motion. Look for the different kind of deformities we come across in the clinic. Bunion, Charcot changes, hammer toe, pes cavus, claw toe, pes planus, hallux valgus, etc. Neurological examination, 5 simple tests. 10 gram monofilament, 128 Hz tuning fork, ankle reflex, pin prick, bathymetry if you have this tool, and tactile sensation. 10 gram monofilament test, I am not going in details. In a study, it has been seen that loss of sensation of this 10 gram monofilament was associated with 10-fold risk of foot ulceration and a 17-fold risk of amputation over a 32-month follow-up period. There are 6 sites at which the monofilament is touched and assessed. This is another very useful tool. If you don't have monofilament, this is a very useful tool, and specificity, sensitivity wise, it's at par to the monofilament. Ask the patient to close his or her eyes during the test. Test is performed by touching the tip of the first, third and the fifth toes, very gentle. If they don't feel, do not to repeat. register, yes, that is sensory loss. If the patient does not have a sensory response in more than 2 toes. In one limb patient, if there is no sensory response in more than 1 toe, it is considered to be yes, that means sensory loss. In vascular assessment, look for the absent weak pulse, mottling, dusky color of the skin, cold foot, shiny with dry skin, atrophic nails, loss of hairs in lower limb. Taking temperature is also very important by the infrared thermometer, very ordinary tool. Palpate the pulses, dorsal speed, posterior tibial, it's of utmost importance. Check the ABI if you have a peripheral Doppler. Normal index is 0.9 to 1.2. If it is between 0.6 to 0.9, risk of ulceration is moderate. And if it is less than 0.6, severe vascular disease and there is a chances of developing foot ulcer. Check the Doe brachial index, that is, if you have that cuff, 0.5, then it's peripheral vascular disease. Dermatological assessment, look for callus, ulcer, and with the size, periphery, depth, adjacent skin environments, etc. Swelling, redness, warmth, tenderness or pain which can be absent in peripheral neuropathy. Take a note of the slow, necrotic gangrenous tissue, foul odor. Look for the dry exposed tendon, ligaments, fascia, etc. Look for the sinus tract. That is the evidence of osteomyelitis, evidence of abscess. And look for the ulcer base, necrotic, it's black, yellow means slow, pink means ulcer is healthy, the granulation tissue is coming up. Diagnosis of osteomyelitis, usually there is a sausage-like appearance of the toe. Probe to bone test, the clinical testing with the help of the blunt probe. When you introduce, you have that gritty feeling. And of course, X-ray. There's a plain radiograph. If you have any suspicion, go for a plain radiograph. It will tell you the diagnosis of osteomyelitis. And MRI, CT, this is the other modality usually not done in the primary healthcare setting. Now, this is a very important part. This is often and regularly ignored. Examination of the footwear. Insist on removal of the shoes and the socks. Inspect footwear from all sides. Look for shoes that are worn out, too small, too narrow, toe box too low, have high heels. Inspect socks also. The staging, Wagner's classification, one of the validated staging, grade 0 to grade 4 till grade 3, it is reversible if it is managed properly and timely. Beyond that, if one gangrene sets in, amputation is inevitable. MAT test, it detects high pressure points, arches of the foot, Charcot foot, etc. If you have this facility, it will be help you to evaluate the proper footwear, offloading footwear. Biothesimeter, vibrometer. If you don't have a biothesimeter, at least this vibrometer, the smaller one, can give you idea about the vibration perception threshold. Handle Doppler, if you have, it's a very useful tool. Non-invasive vascular assessment utilized for diagnosis for monitoring of peripheral arterial disease. It is the ratio of the highest systolic blood pressure at the ankle, that is dorsal pedis, as well as posterior tibial artery, to the systolic blood pressure at the arm by handle Doppler. These are the other models like duplex scan and other acute transcutaneous oxygen measurement not usually done in the primary healthcare center. Laboratory investigation wise, glycemia, fasting sugar, PP sugar, A1C, CGMS, infection wise, hemoglobin, CBC, procalcitonin, ESR, culture, etc. and systemic investigation by LFT, RFT, lipid profile, retinal examination, ECG, etc. Now, this is a very important slide. Risk categorization. The frequency of follow-up, 0. Category 0, no sensory neuropathy once a year. Sensory neuropathy once in every 6 months. Sensory neuropathy and signs of peripheral vascular disease or foot deformities, then once in every 3 months. If there is any history of previous ulceration or amputation, I personally feel every month. Good wound care treatment is largely determined by offloading, debridement, moist dressing, control of infection. These 4. Excuse me. So, tight blood glucose control and achieving A1C target to the guideline is mandatory throughout the course of the disease. Now, offloading, meaning avoidance of all mechanical stress on the injured extremity while maintaining the necessary ambulation. Why necessary ambulation? Usually these patients come from the very low socioeconomic strata, and आप अगर पैर ही उसको कर दोगे तो बेचारा खा कमाएगा क्या. So purposes: preventing pressure ulcers, promote healing by redistributing weight, offloading devices reduces trauma to the ulcerated area, allowing to the heal. Gold standard is TCC, that is total contact cast. It is considered for the best for treating the plantar ulcer. It distributes pressure evenly over the entire plantar surface of the foot. But there are some contraindications like infected diabetic foot ulcer or osteomyelitis, because the wound cannot be inspected on the regular basis. In this patient, other modalities are Scotch-Guard boots, healing sandals, crutches, walkers, and even wheelchairs also can be given. So proper footwear is a mandatory for primary as well as secondary prevention of diabetic foot ulcer. Now debridement, a removal of the necrotic and senescent tissue as well as the foreign and infected material from the wound. It is mandatory. Sharp debridement is essential for management of the foot ulcer. Now there are different kinds of dressing, different kinds of guideline, but remember the ideal dressing feature should be to remove excess of exudate and toxic component, to maintain high humidity in the wound, to allow gaseous exchange, to provide thermal insulation, to provide protection from secondary infection, to allow removal of dressing without traumatizing the healthy granulation tissue, and dressing material should be free from particulate and toxic components, and it should not be associated with less pain. Control of infection. Infection in diabetic foot is limb threatening sometimes. Superficial infection usually caused by gram positive, and deep infection usually is polymicrobial. Surgical debridement is essential in acute deep infection osteomyelitis. Empirical therapy sometimes often started before culture results are available. Choices may be coamoxiclav, clindamycin, linezolid, sometimes injectables also. But once that the culture and sensitivity report are obtained, appropriate antibiotics to be started. And topical antibiotics sometimes can be used in case of milder infection. And duration of therapy may be 1 to 2 weeks in the milder infection. In case of osteomyelitis and more severe infection, it may prolong up to 6 weeks or more. So treatment modalities would be microbiological control, wound control, vascular control, mechanical control by offloading, metabolic control of hypercalcemia, and of course health education, that is educational control. Now, amputation should not be considered unless a detailed vascular assessment has been performed by a vascular staff. Indications are ischemic rest pain that cannot be managed by analgesia or revascularization, a life-threatening foot infection that cannot be managed by other measures, a non-healing ulcer cannot be managed with conservative management. In these circumstances, you should go for amputation. Otherwise, please reevaluate before going for such a drastic step to a patient. So early warning signs in order to identify the foot at risk and timely refer to the tertiary center. Swelling of the foot or ankle, very cold feet or legs, color changes red, blue, black, discoloration, pain in the legs or while walking. A patient with acute limb ischemia is characterized by 6 P's: pulselessness, pain, pallor, perishing cold, paresthesia, and paralysis. This poses a clinical emergency if not managed timely and effectively. Tachycardia, hypotension like hemodynamic instability, open sores, non-healing wounds, ingrowing toenails, loss of hair in leg and feet. So take home message would be this condition, this diabetic foot complications are totally preventable. Remember, totally preventable. So proper patient education, good glycemic control, regular foot assessment including vascular stuff and neurological assessment, removal of chronic pressure by offloading whenever necessary. Diabetic foot ulcer need multidisciplinary approach. Multidisciplinary foot care team should be acted upon. Thank you for your patient sharing. Thanks, sir.
Thank you, sir, for your informative presentation. Now, I would like to invite Dr. Parvinder Kaur, MDAs, PGI, MER, Chandigarh, Consultant Dental Specialist, Bathinda. She is going to present on the topic Oral Health and Heart Health, Importance of Interlink. Welcome, ma'am.
Thank you so much. I must take this opportunity to thank Dr. Vitul to give me such a platform to address this topic. It is most neglected but very important. How to scroll it? Well, let's have a quick poll. How many of us feel there is little or no correlation, no link between oral health and cardiovascular health? Please put your hands up. Please put your hands up who feel there's no correlation. I presume all of us feel that there is some correlation. So let's see what research has to say. See, I haven't quoted many papers, but I have picked up 3 which I found are covering vastly the parameters which will make us think that there is a link and we have to address that. Here the author used a population for over a period of 3.7 years. This was a median study. The group was divided into 5. Those having no teeth, people having teeth up to 14, 1 to 14, 15 to 20, 20 to 25, or more than 25. And it was found a 6% increased risk of MACE, that is major adverse cardiac event, could happen with just one single tooth loss. And 27% increase where there was no tooth in the mouth as compared to people who had 25 teeth. Individuals with another study, it says individuals with periodontal disease have 2 to 3 times the risk of experiencing a heart attack, stroke, or a severe cardiovascular event. Another study suggests that simple behavioral change in oral hygiene may help prevent future cardiovascular event, and benefit was notable. 19% reduction in people who were just brushing once a day or more as compared to who were not brushing. And regular professional care once a year or more decreased the risk by 14%. That is quite amount. So this is just a diagrammatic correlation tree, but I will first want to discuss with you the structure of the gingiva, because it is here, from here, that the link will start. On one side it is the gums, and on the other side it will be the heart, right? So let's see what the gums are. Most prevalently we feel we have teeth in our mouth which crush, and the tongue helps to gulp it down. We totally ignore gums. Gums are the structure which forms a pink layer in our mouth around the teeth. It can be divided into free gingiva and attached. Free gingiva forms a cuff around the teeth of different size. That is, on the incisors it's different depth, on the canines it is different, and then molars it is different. It is here that the microbes, bacteria, aerobic and anaerobic, which are housed there normally, and they react with the food left unattended in these areas, which leads to formation of plaque. Plaque is nothing but a soft white layer initially if we see it. It is just food and the bacteria. These bacteria, they start acting on it, and if this plaque is left unattended in the mouth, it turns into hard tartar. So this would be the hard tartar picture. It leads to periodontitis, and this is gingivitis. Gingivitis is reversible and periodontitis is irreversible but can be controlled. There's a difference. We can't reverse it, but we can stop it. And it is from here that the bacteria that infect the gums and cause gingivitis and periodontitis also travel to blood vessels elsewhere in the body, where they cause blood vessel inflammation and damage. Consequently, infectious bacteria travel through the bloodstream and reach the heart, where they can multiply and produce toxins that can cause life-threatening endocarditis. The infection and inflammation may lead to death of cardiac tissue, which in turn can cause a fatal heart attack. Now, this is the graphic correlation tree. Periodontal plaque causes bacteremia, which affect the platelet activation, oxidative stress, leads to endothelial dysfunction. Another way is it causes inflammation, increase these levels, IL-1, IL-6, TNF-alpha, CRP, again leading to endothelial dysfunction. It can have an immune response also and have molecular mimicry, which again affect the endothelial dysfunction, and ultimately it is the end result is CVD and the heart is affected. So adjuncts required for good oral hygiene. I will cut short the cardiac part because you guys are more aware and more conversant with that. Presuming this, I will just lay more stress on the dental portion. So what are the adjuncts required for good oral hygiene? Now that we have established that there is a link, I can go in details about the link also, but now I presume you have enough knowledge that there is a link. Bacteria increase the permeability of the gums, blood vessels. From there, they travel, common soil theory, they travel to the heart, and their CVD and all the sequelae are affected. So let's see. What are the adjuncts required for good oral hygiene which can prevent CVD? It is home care and professional care. Home care में क्या आता है? Brush, floss and mouthwash. Professional care requires scaling, polishing, gum recontouring and alveolar bone remodeling. Home care, brush again can be a long topic. A full seminar can be taken. You guys must not be laying that much of stress on this, but kindly remember, always use flat bristled brush with short head. Why the short head? Because short head can reach all the nooks and corners of your mouth, and all the contours of the teeth can be clean. And what should be the technique of brushing? Single surface, multiple technique. It is simple to understand and simple to perform. Each surface of the tooth should be cleaned 5 times. Give a rotatory motion. This is the demo. But I want to open the link. I want to open this link. I would have loved to make my own video, but kindly bear with me and we will see this. Voice bhi de do bachche.
Scrubbing back and forth, which can actually cause tooth wear, gum recession, and sensitivity over time.
You have to scrub the surface.
There's also making wide circles.
I don't agree with the zigzag thing of the bristles. Remember that, please. Always use a flat bristle brush. Place your brush on the surface of the tooth at 45 degrees and go in a circular direction. Give 5 circular motion on one surface. It is to be placed like this at the 45 degrees and round you go. Press a bit, not much. Don't give very much pressure. Just with the light hand, scrub and rotatory motion. Scrub and rotatory motion. If you see, the gum line is round, semicircular. If we are giving this motion, then we clean all the surfaces. There is no possibility of bacteria or no possibility of food remaining on the surface. So we clean all the nooks and corners. This is very important, guys. Please have a close look and clean all the surfaces, all the teeth, all the surfaces, anteriors as well as posteriors. Sometimes we just concentrate on the anteriors thinking that this is the only part visible, but the bacteria are present in the whole of our mouth. So we have to concentrate on all surfaces, lower as well as the upper. So only disagreement with this video here is the type of brush being used. I would not recommend zigzag because as you see, all the bristles are not touching. If you have a flat brush, it will definitely touch all the surfaces. So kindly pick a short-headed, flat-bristled brush. Paste can be any. As we keep changing the soap, the function of the paste is as good as soap. As we keep changing the soaps, we can keep changing the brush. Medicated pastes are only recommended when it is indicated, when you have some dental problem. So mouthwash. Mouthwash is another factor. Mouthwash is never to be used as an adjunct. It is in addition. It should not be the sole thing to control the oral hygiene. It has to be in addition to the brushing, always. And if the spaces are there between the teeth, the flossing is recommended. Don't push the floss with force. Let it glide wherever it goes easily. And the action should be shoe shine. Like we put this piece of cloth and shine our shoes. This is the shoe shine motion which you should give to the floss. In, shoe shine and out. In, shoe shine and out. This is the method with which you should be flossing. So after all this, I would say gum disease is one of the diseases where body is in a continual state of inflammation, and this is a powerful predictor of CVD. My cardiovascular surgeons will agree with this. Gum disease worsens blood pressure and interferes with medication to treat hypertension also. See, it interferes, it increases the blood pressure and interferes with the medication also. So it is very important that we treat all this. Now, coming to the end, whether link is direct, indirect or coincidence, a healthy mouth and regime to keep it that way should be our priority. It is good reminder that mouth is an important part of person's entire health. This is reason enough to do what you can to make oral hygiene a priority. That's a regular visit to dentist is a low risk, low cost venture as compared to cardiac surgery option and has other benefits even beyond the scope of this seminar. So maintaining oral hygiene is very low cost. There is no reason not to recommend someone to do this. Proper dental hygiene is just one way to lower risk for developing CVD. Stand by for more studies on oral hygiene and overall health. Until then, keep brushing, flossing, and seeing your dentist. Thank you very much. Yes, it is. And I must thank you, Dr. Vitul, for giving me this opportunity to put across to everybody that oral hygiene is the priority. Yes. Thank you. Thank you.
Thank you for the insights in your presentation, ma'am. Now let's turn our attention to Dr. Sushil Gupta, Additional Director, Department of Pulmonary and Critical Care Medicine, Fortis Hospital, Ludhiana, for his presentation on COPD Clinical Practice Guidelines 2024.
Good morning, everybody. I am Dr. Sushil Gupta from working as pulmonologist in Fortis Hospital, Ludhiana. First of all, I would like to thank Dr. Vitul and organizing committee for giving me the opportunity to talk on the core pulmonology topic, that is COPD. And the topic for today's discussion is COPD Clinical Practice Guidelines 2024. So I have made this presentation from the GOLD guidelines, which is internationally well accepted guidelines for COPD. And since we all see many patients of COPD and it's very common disease, so I don't think so that COPD needs any introduction. So just as a definition, it's the heterogeneous group of lung diseases which causes chronic respiratory symptoms like cough and breathlessness due to abnormalities in the airways and the alveoli, and it is persistent and often progressive due to airflow obstruction. And it is classified based on the etiology. It is genetically determined COPD due to alpha-1 antitrypsin deficiency. It could be due to abnormal lung development, like in low birth weight babies or premature births or any other cause. Environmental COPD due to smoking or pollution. COPD due to infections like tuberculosis, necrotizing pneumonia, or infections during the childhood. COPD due to overlap with the asthma, or COPD due to unknown cause. So the clinical indicator of COPD is first and most common is the dyspnea, which is persistent, often progressive, and it could be associated with wheezing, cough, which could be dry or associated with sputum, recurrent chest infections, and there is history of some underlying risk factor. Various other causes of cough, mainly the intrathoracic, are the asthma, lung cancer, interstitial lung disease, bronchiectasis, pulmonary edema due to any cause, cystic fibrosis, lung infection, or tuberculosis. Various extrathoracic causes of cough are chronic allergic cough, postnasal drip, upper airway cough syndrome, gastroesophageal reflux, various drugs like ACE inhibitors or ARBs. So once we have made the suspicion of COPD on clinical basis, then we confirm it with the help of spirometry. We do it as a post-bronchodilator spirometry, which is done 10 to 15 minutes of giving 400 micrograms of short-acting beta-agonistics, or 30 to 45 minutes after the 160 microgram of short-acting antimuscarinic agents. And this, the values which we look is first the ratio of FEV1 to FVC ratio, which is generally less than 0.7. And then we look at the FEV1 values for the severity. And then we also look for the reversibility, in which it is irreversible in COPD, whereas in asthma, it's the reversible disease. And at the end, we also need to look at the quality of spirometry so that we can interpret it in a correct way. So this is the graph which we look at the spirometry. The left-hand side is the normal in which FeV1 to FVC ratio is 0.8. And on the right side, there is the spirometry of the COPD, in which we can look at the FeV1 to FVC ratio is 0.56. And if we look at the curve in the COPD, it is slow rising, flat, and prolonged as compared to the left-sided normal curve. Then COPD is grade with on the basis of FeV1 from gold 1 to gold 4 as a mild if FeV1 is more than 80%, moderate if FeV1 is 50 to 80%, severe if FeV1 is between 30 to 49%, and very severe if it is less than 30%. So there is another new concept coming into this COPD is the PRISM. This is the preserved ratio impaired spirometry, in which the ratio of FeV1 to FVC is more than 70.7, but FeV1 is less than 80%. It is seen both in smokers and non-smokers, and it is associated with increased risk of cardiovascular events, hospitalization, and all-cause mortality. But there is no evidence of best treatment in the category of PRISM patients. So it has also been seen that the decline in lung function is significantly more than normal persons or mild severity of COPD patients. The role of spirometry is COPD is limited to diagnosis, to assess the severity, then to check the response to treatment or any other intervention, or identification of rapid decline in the lung functions. So there is a new concept of blood eosinophil count in COPDs. The routine blood eosinophil count is recommended. It has prognostic value in lung function decline. Higher count is associated with higher exacerbation risk, and we need to add inhaled corticosteroid when eosinophil count is higher in the blood picture. So clinically, we look at the severity by modified MRC dyspnea scale. In this, it is graded from 0 to 4. MMRC grade 0 is when patient is getting breathlessness only on strenuous exercises. Grade 1, when patient is breathless when walking fast or going upstairs or walking uphill. Grade 2, when person walks slowly of the same age because of breathlessness. And grade 3, when patient can walk only up to 100 meters. And grade 4, when patient is having breathlessness and cannot move out of the house or having problem in doing the daily routine activities. There is another score, that is CAT assessment score, in which it assesses also the cough, sputum, energy levels, psychologically, and sleep levels, and from it is all parameters are graded from 0 to 5, and ultimately all scores are added, and then we classify the severity according to the previous score of the patient. Then assessment of the risk of the exacerbations. Once we have diagnosed this COPD and the assessment of air flow obstruction and severity by the spirometry, based on the spirometry from grade 1 to grade 4. Then exacerbation, on the basis of exacerbation, we assess the risk of exacerbation or hospitalization as A, B, and E. A and B are when there is patient having history of only one moderate exacerbation not leading to hospitalization. In category A, the MMRC scale is 0 to 1 and CAT score is less than 10. In B, the symptoms are more, but there is only history of one exacerbation in 1 year. In grade E, it is the more than 2 exacerbation in a year or even 1 hospitalization. Patient is always at high risk of getting the exacerbations. So role of CT in COPD, it is limited only for diagnosis of the differential diagnosis like bronchiectasis, ILD, or any other infection, screening of lung cancer, or it has value while doing the lung volume reduction surgeries. The screening of lung cancer is also very important in COPD because of common risk factor for COPD and the lung cancer. And it also helps in early diagnosis of lung cancer. The goal of treatment of COPD is to reduce the symptoms of breathlessness, cough, improve exercise tolerance, improve the health status, and also at the same time we also want to reduce the risk factor of exacerbation, hospitalization, and all-cause mortality. The management of COPD, first is the diagnosis, then initial assessment based on the spirometry or MMRC scale or the CAT scale, then looking at the various risk factor of the COPD. Then amongst the treatment, it's the pharmacotherapy along with this smoking cessation or pulmonary rehabilitation, any need of oxygen or non-positive pressure ventilation, then any vaccination required for the patient. And after the initial management, we review the patient on the follow-up with all the parameters, and then we adjust the treatment or stress wherever patient is lacking the having any the problem. So among the pharmacological therapy in group A, it's the bronchodilator, either antimuscarinic agents or LABA. And group B, where symptoms are more, then we add LABA, long-acting beta-agonistics or long-acting antimuscarinic agents. In group E, wherever there is high risk of exacerbation or patient has having previous history of exacerbation or hospitalization, there we add both, and we also consider adding inhaled corticosteroids if blood eosinophil levels are high. So in follow-up pharmacological treatment, if patient has responded to the treatment, then we maintain it, but if not, then first we check the inhaler technique and we check for the compliance of the patient, then consider any inciting agent or continuous exposure to the risk factor, or if patient is still having problem and everything has been checked, then we add the treatment. If patient is on one drug, then we add the second drug. If patient is already on two drugs, then we always check the technique of inhaler or we change the device. In case of exacerbation, if patient is taking LABA or LAMA, then we add the another drug, or if the eosinophil count is high, then we add the inhaled corticosteroid. But if patient is already on LABA or LAMA 2 drugs and blood eosinophil levels is between 100 to 300, even then we can consider adding the inhaled corticosteroid. But even after adding all 3 drugs, patient is not symptomatic. If patient is not getting benefit, then we can all add roflumilast or azithromycin. Coming to the main treatment, bronchodilators in stable COPD. Inhaled bronchodilators are central to symptom management on regular basis. Inhaled bronchodilators are always preferred over the oral one. Regular or as needed, SABA or SAMA improves FEV1 and symptoms. Combination of short-acting antimuscarinic or short-acting beta-agonistic are superior as compared to single agent. And LABA or LAMA are always preferred over the short-acting until or unless patient require only SOS treatment. And long-acting antimuscarinic agent has greater effect in reducing the exacerbation and hospitalization than LABA. Combination of long-acting agents is always better in symptom control, prevention of exacerbation and mortality. Single inhaler is always preferred over the multiple inhalers because of the compliance or the cost issue. Theophylline exerts small bronchodilator effect on stable COPD. Factors which are considered before initiating the inhaled corticosteroids are, it is strongly recommended whenever patient is having history of hospitalization or exacerbation, more than equal to 2 exacerbation of COPD per year, or blood eosinophil level is more than 300, or patient is having concomitant history of asthma. And inhaled corticosteroids is favorable use if patient is having 1 moderate exacerbation of COPD per year, or blood eosinophil level is between 100 to 300. The use is not recommended if patient is experiencing recurrent chest infections, blood eosinophil level is less than 100, or patient is having history of tuberculosis. The another part is the anti-inflammatory therapy. It is regular treatment with inhaled corticosteroids increases risk of pneumonia, especially those with severe diseases. So inhaled corticosteroids should be combined with long-acting beta-agonistic in more effective way than individual components in improving lung functions and health status. We do not encourage the use of LABA or ICS combination in COPD. If there is an indication, inhaled corticosteroids should be combined with LABA and LAMA as a 3-drug combination, preferably in a single inhaler. And if patient with COPD have features of asthma, then treatment should always contain the inhaled corticosteroids. And independent inhaled corticosteroids have lot of risk factor of increases the risk of recurrent chest infections. And long-term use of oral corticosteroids have various side effects with no evidence of significant benefit overall on decreasing the risk of exacerbation and mortality. Then PDE4 inhibitors, that has proved some role. Antibiotics like azithromycin can have some role in reducing the exacerbation over the 1 year. And the regular use of mucoregulators or antioxidants have shown to reduce the risk factor of the exacerbation. However, there is no role of statins in reducing the exacerbations. Then we need to identify and reduce the risk factor also, like we should stress on smoking cessation, efficient ventilation in workplaces wherever there is a pollution, or in the homes where there is burning of biomass fuels. And we also need to stress to avoid the continuous exposure of irritants wherever possible. Then another important topic in COPD is the vaccination. The patient should be encouraged to get annual influenza vaccine. Pneumococcal vaccine, initially it's the polyconjugate vaccine followed by 23-valent polysaccharide vaccine. Then DTaP vaccine, especially to prevent the pertussis whenever person has not get vaccinated in the adolescent age or in the childhood. And newer vaccine, zoster, it protects against the shingles in age more than 50 years of age. Then new RSV vaccine, it is also been recommended over the age of 60, especially with patients of chronic heart and lung disease. Coming to oxygen therapy, long-term oxygen therapy increases survival only in patients with severe resting hypoxia, and if PO2 is less than 55 or saturation is less than 88%, there we recommend the patient to get the oxygen therapy. But if PO2 is between 55 to 60, only then we give oxygen if patient is having right heart failure or hemoglobin is high or erythrocytosis. And we need to titrate the oxygen so that saturation should be around 90%, and we need to recheck repeatedly after 2 to 3 months whether there is any need of oxygen subsequently or we need to reduce the oxygen. One very much important point is that resting oxygenation at sea level does not exclude hypoxemia when traveling by air, because many patients ask that if patient is stable here, whether they can fly on the fly to the overseas or any other place, then we need to check and we need to warn them. Then in severe COPD patient, they may need oxygen while traveling by air. Then ventilatory support and non-positive pressure ventilation improve hospitalization-free survival, and it is recommended especially if PCO2 level is more than 53%. Chronic hypercapnia or history of hospitalization for acute respiratory failure and long-term positive pressure ventilation may be considered. And then pulmonary rehabilitation, it is indicated in all patients. It helps to improve health status of the patient, decreases dyspnea, and improves exercise tolerance. It reduces the anxiety of the patient, and it also been seen that it has reduced the hospitalization. Then various potential indicators for hospitalization is sudden worsening of dyspnea, patient is having drowsiness, confusion, onset of cyanosis, if patient is hypoxia, hypercapnia, failure to respond to initial treatment at home, or if there is any significant comorbidities or insufficient home support. Then management of severe but not life-threatening situation is that we increase the doses of bronchodilators. Then we give the increased frequency of short-acting beta-agonistics or the antimuscarinic agents. Then we can also consider adding the oral corticosteroids, antibiotics wherever required, or we think that it is the infective process. Then we may need the non-invasive ventilation. And all time we need to monitor the fluids, and we need to give subcutaneous heparin or low molecular heparin for thromboprophylaxis. And we also need to identify other associated problems like heart failure, arrhythmias, pulmonary embolism, etc. Then indications for ICU is sudden severe dyspnea, change in mental status, worsening of hypoxia, any need of invasive ventilation, or if person is having hemodynamically instability. Indication of non-invasive ventilation is when pH is less than 7.35 and PCO2 is more than 45 on ABG, if patient is having persistent hypoxia despite supplemental oxygen, or if there is severe dyspnea with clinical signs of respiratory muscle fatigue. Then coming to various differential diagnoses of COPD are bronchial asthma which is reversible disease, interstitial lung disease, bronchiectasis, lung cancer, or congestive heart failure. These are the diseases which mimic as COPD, but we need to make the exact diagnosis. So just to conclude, COPD is a common preventable and treatable disease. It is often under or misdiagnosed, and there are many other factors apart from smoking. If person is not smoking, then we cannot rule it out as COPD. Then we need to focus on pre-COPD or the PRISM, that is preserved ratio and Beard spirometry. And then we need to focus on the inhaler techniques, which should be written or prescribed after discussion with the patient. Thank you very much.
You have taken from it, that should be the most important criteria that we must follow in our life. So how do I scroll through this? It's a touch screen. How do I scroll through this? Okay. So what I'll be presenting is post-exposure prophylaxis after unprotected intercourse. What happens is, let me take everyone back to 1996. Now, I got a call. उस time अगर सबको याद हो STD booths होते थे. तो I got this message from the STD booth owner कि आपके बड़े dear friend का call आ रहा है शिमला से and he wants to talk to you very urgently. And I was at the peak of my prowess, 1996-97, heading for my MD exams at DMC. So I sat at the STD booth. Dr. Naveen Mittal was sitting with me next to me. मैं कहा पता नहीं क्या हो गया शिमला में. And my friend called me up. He just had this one message. यार सूद ऐसे है, कल रात को मैंने बहुत दारू पी ली, आज सवेरे मैं उठा हूँ and there's a woman sleeping next to me. What do I do about it? And at the peak of my prowess, 1996-97, I was at a loss to give him an answer कि क्या बोलूँ इसको मैं. तो पहले तो मैंने फट्टे मारे इधर उधर के, जब तूने किया है तो भुगतान कर, फलाना ढमकाना, बड़ा कुछ उसको सुनाया. Then out of the blue I just said, ऐसे कर, प्रोकेन पेनिसिलिन के इंजेक्शन लगा ले. उस समय if everybody remembers 96-97 सिफिलिस के लिए हम PPF देते थे सबको, प्रोकेन पेनिसिलिन. तो इंजेक्शन लगा ले रोज़ का 1 लगा और 10 इंजेक्शन लगा ले। जाते जाते उसको मैंने गलती से बोल दिया टेट्रासाइक्लिन खाली पेट तू खा ले QID for 10 days, no harm. I don't know what made me say it, but it has worked wonders. So as we go along, I will be introducing everyone what goes on. So as we know, the world is a game of hormones. हमारे दो endocrinologists बैठे हैं, Dr. Rohit and Dr. Naveen Mittal in the auditorium. The world is a game of hormones, and this is the outline of my lecture. Demographic data, HIV PEP, bacterial STIs, doxypep, and take-home message. There are only 14 slides I'll torture you with. Now, what happened was, in 2020, a very, very important news came out in the Times of India on January 6. There's a huge hullabaloo in India, and such a study has not come out ever since. The MOHW woke up one day कि ये क्या type कर दिया, क्या छाप दिया इन्होंने. So, what they pointed out was that an estimated 30 to 35 million episodes of STI RTI occur in India every year, which is a very, very big number. ये हुआ क्या, कैसे हुआ? Everybody was very bothered. And as we see the graph on the right side, though I don't have a cursor with me, on the right side, if you go up towards the upper quadrant, say 12 o'clock से लेके 3 o'clock के बीच में, look at the number 36,326. See the pink line. See the 47,797. See the 46,802. How they are going up, how the STIs are rising, and suddenly there's a decline. What happened was that this had a huge impact on the society, and there was a huge hue and cry. So what was done was a survey was carried out after that by the MOHFW, Ministry of Health and Family Welfare, कि हो क्या रहा है? So the discovery was age 25 to 35, we had the maximum STI rate. See the 30% at the second column. Then males were more affected by females. But the difference is only 1%, which was proved to be wrong. ऐसे the male genital tract is hanging outside, everything is visible in a flash. Females, everything is internal. It's so difficult to make out what is happening. The next was, it was more in the unmarried as compared to the married, which stands true. That unmarried want to experiment and find out kahani kya hai. Muslims are protected from STIs because the prepuce is not there. The squamous transitional cell epithelium which is present in the prepuce, that is the one which has maximum STI predilection. So Muslims had less of STI compared to the Hindus. The Hindus had the maximum. Christians, as we all know, some are circumcised, some are not. As you know, the Yahudis, the Israelis, they are circumcised. So the Hindus had the maximum STIs, and it was, of course, no doubt the low socioeconomic status people had more, and illiterate were more affected by the STIs. Now, the exposure factor which was seen, look at the part in Asia, Chinese, 108 million people affected by STIs. Look at the Asia factor towards the south, 51 million people. Arab countries being conservative, 34 million. और जहाँ ज़्यादा ठंड पड़ गई ऊपर को, 23 million was the effect rate. So what to do about all these things? Look at the viral STIs which I have pointed out in the list. These are the STIs, and the deadly ones are HIV, herpes genitalis. I put a tick mark against them. Genital warts, molluscum जब भी होंगे या hepatitis या cytomegalovirus होएगी, हम कर देंगे उसको ठीक. Look at monkeypox, which has come in now as a new STI. On the right, I have pointed out a lesion of monkeypox, a vesicular lesion with erythema surrounding it. जैसे हमारे herpes zoster के lesions होते हैं. Something like that is what monkeypox lesions are present. Now, what is the post-exposure prophylaxis which is advised for HIV? Lamivudine, tenofovir. Go in for it immediately. देखो जो HIV है, we have only 72 hours to prevent it. 72 घंटे का टाइम है हमारे पास. अगर 72 घंटे में 3 days के अंदर we have not taken action, it's a very, very serious problem, a lifelong problem. immediately intervene when there's an unwanted exposure. ऐसे है एक concept जो बहुत important है STIs में, which I teach my students is एक ही काफ़ी, बाकी से माफ़ी. Be very careful. This is not a game. This is a very, very dangerous game. Now, what is to be done? Pinprick exposure हो जाए या unwanted exposure हो जाए, suddenly it happened one fine day. Lamivudine and tenofovir are the two drugs which are to be given. जो बाहरली कंट्रीज़ में है उनमें ट्रू वाडा के नाम से आती है मेडिसिन. जो इंडिया है हमारे यहाँ HIV जो ट्रीटमेंट देते हैं, वी गिव लैमिवुडीन, टेनोफोवीर एंड डोलोटेग्रावीर. तो जो आपने करना है, यू हैव टू एडवाइज द पर्सन आफ्टर पिन प्रिक आफ्टर अनवांटेड एक्सपोजर कि जो आपकी HIV की टैबलेट है, टेक इट फॉर 28 days. That is the concept which is very, very important. The bacterial STIs. Now I want everyone to focus on the left hand side, the list of bacterial STIs and the incubation period. The incubation period जो I के नीचे है, 1 day, 3 days, 3 days, 7 days, 8 days, 9 days. This is the time period that we have for preventing the STI from happening. Sexually transmitted infection जो है उसको हमने इतने टाइम के अंदर रोकना है. Look at 12 o'clock position. You see a patient with gonorrhea. He has frank purulent discharge. Look at the patient at 1 o'clock position. Chancroid. Hemophilus ducrei के कारण kissing ulcers हुए पड़े हुए हैं. Very painful condition. The genitals are very, very sensitive. और इसमें अगर कुछ हो जाए, it is very painful. Patient literally राड़ियाँ मारता हुआ आता है, चीखे मारता हुआ आता है. But look, it can be prevented. So, coming back to जो मैंने आई के नीचे लिस्ट किया हुआ था, incubation, इनके पहले पार्ट पे चलो. 24 घंटे, 72 घंटे, 168 घंटे. We are literally talking in hours. We have to prevent these STIs from happening. तो जो मेरा फ्रेंड था जिसने कॉल किया था, I don't know how he saved his life. He is always grateful to me. The thing is, what medicine is to be given कि ये होए ही ना ही होए ये STIs. Doxypep, doxycycline is the wonder drug. It is the secret weapon of the physician. जो उठता है physician doxycycline दे देता है. चाहे respiratory problem है, चाहे STIs है, चाहे RTIs हैं, doxypep is the secret. It does wonders. Doxycycline, अभी मेरे पास कोई पेशेंट आते हैं OPD में, चाहे उनको जेनिटल वॉर्ट्स हैं, चाहे उनको मोलस्कम कंटेजियम है, सेक्सुअली ट्रांसमिटेड, I straight away start them on doxycycline, 100 milligrams, 2 times a day. But the trick is, खाली पेट देनी है. If you have it after food, it has no value. So 1 hour before breakfast, 1 hour before dinner. This is the medicine that will work wonders for you. The main effect of doxycycline, of course, is it's a 30S ribosome inhibitor. But one thing which is not taught about doxycycline is it prevents neutrophil chemotaxis. जो neutrophil chemotaxis का जो prevention factor है, that protects you from many things. What a drug doxycycline is. Must give it for any patient of sexually transmitted infections. 200 milligrams is a dose as recommended by CDC. एक ही टैबलेट देनी है 72 घंटे, ये 24 घंटे के अंदर. वैसे 72 hours they say, but they say that the effect of doxycycline is very major and very important if given within 24 hours. Now, this is the treatment which is listed out by CDC, by WHO and by our NACO, National AIDS Control Organization. ये सारी treatments list out किए हैं. It's a huge list. I'm sorry that the slide is very cluttered. It should not be that way. But मैंने जानबूझ के इसको clutter किया हुआ slide को दिखाने के लिए. See, gonorrhea, cefixime treatment of choice as per India. India really needs to upgrade its STI guidelines. India का काफ़ी जो last STI guideline था वो 2014 में था. They really need to buck up. I hope they upgrade this year, 10 years down the line. Chancroid का azithromycin. But एक चीज़ जो मैं दिखाना चाहता हूँ, look at doxycycline, look at the red ticks which are there. Doxycycline, gonorrhea. Azithromycin is the only one जो chancroid में missing है, but it has been proven that it is effective in chancroid. Lymphogranuloma venereum, look at doxycycline again. NGU, again doxycycline. Donovanosis, doxycycline. Syphilis, doxycycline. Watch where all doxycycline is going. So, pelvic inflammatory disease, again doxycycline. Bacterial vaginosis, watch the blue arrows, metronidazole. This I'll be deliberately taking up later. जब मैं एक प्रोजेक्ट करूंगा कि क्या करना चाहिए. Not scientifically documented, but if there is someone involved जो हमारा बड़ा dear friend है, उसको क्या करना है, कैसे prevent करना है. Cervicitis, again doxycycline. So take home message, we have to protect the people from HIV. We have to protect our patients from STIs which are bacterial. Lamivudine plus tenofovir for 28 days. But हमारे यहाँ जो tablet मिलती है standard India में, उसको 28 दिन के लिए दे दो. See, there can be an unwanted exposure, there can be a wanted exposure. किसी के साथ सडनली हो गया प्रॉब्लम. दिस इज नंबर 1. HIV 72 आवर्स का थिंकिंग टाइम देती है, इससे ज़्यादा नहीं. 3 दिन, इससे ज़्यादा नहीं. डॉक्सीसाइक्लिन within 24 hours 200 milligram single dose. I personally recommend doxycycline hyclate का इंजेक्शन. एक इंजेक्शन 100 मिलीग्राम का है, एक सवेरे लगाओ, एक शाम को लगाओ, and hope for the best. The future research which I recommend is, and which is only between me and the people who are sitting here listening patiently to me, give acyclovir 400 milligrams 3 times a day for 7 days. हमने herpes genitalis को होने ही नहीं देना. इसको होने ही देना herpes genitalis को, कि सारी जिंदगी recurrent herpes होती रहे. Metronidazole, cervicitis, pelvic inflammatory disease, non-gonococcal urethritis, सबको cover करो by giving 400 milligrams 3 times a day. Fluconazole, 150 milligrams once a week for 6 weeks. Candidiasis, fungal infections which are sexually transmitted, prevent it. Azithromycin, single dose ज़रूर रात को दे दो. Again, empty stomach. It has value only given on empty stomach. Cefixime भी दे दो, चलो कुछ नहीं तो कुछ ना कुछ तो करेगी. And doxycycline, the red mark, which is recommended 2 times a day for 21 days. LGV, lymphogranuloma venereum, is a devastating disease. एक बार हो जाए बेड़ा गर्क करके जाती है. Prevent it by giving it for 21 days. अब इतना सारा मैंने सुना दिया. तो is this the future? ये जो कॉकटेल है, सारे परांठे में गूंद के ही खा लें हम इसको, सारी दवाइयाँ सारी मिक्स करके परांठे में ही खा लेते हैं. Give all these medicines, prevent any STI from happening. Can STIs be prevented? Yes. Can STIs be eliminated? No. The world is a game of hormones, as my endocrinologist friends will tell us. No. Can STIs be eradicated? That is impossible. Until the world survives, they can never be eradicated. So STI medical cocktail, I have told you the after component since I was given 15 minutes. मैंने वैसे तैयार किया था pre and post exposure, but this is the after part. So these are my references. CDC, WHO and NACO guidelines. NACO really needs to step up. And thank you very much for patient listening. I'm open for questions if there are any. Yes, sir, absolutely.
So basically this part has never been followed. At least I am in right turn. That whenever I prescribe doxycycline or azithromycin, I will make sure that patient takes it empty stomach.
Very right. So see, doxycycline if it is given after food, it's as good as 28 दिन के लिए दे दी, 2 महीने के लिए दे दी खा दी. Will it work wonders? Time will tell. But I think it should.
So basically हम भी कई बारी आपकी उस पे इंक्रोच कर लेते हैं कि एक्नी में दे देते हैं. So I think in our patient churn is also working. Because we generally don't specify that it should be taken empty stomach and still patient is getting okay. So that means in India churn also works.
That is a 30 years ribosome inhibitor.
Yes.
So आधा काम कर गया, आधा
रह गया. Thank you very much.
Thank you. Any other questions, anybody? Thank you so much for patient listening. Thank you.
Thank you, sir, for your insightful presentation. Now I'd like to call upon Dr. Naveen Mittal, Professor and Head Endocrinology, DMCH Ludhiana, to present his topic, Subclinical Hypothyroidism, When to Treat.
Good morning. मैम कहाँ से स्लाइड कैसे नीचे करना है? Okay. I am going to talk to you about the hypothyroidism, subclinical hypothyroidism, when to treat. Just to understand, there is a thyroid gland. Thyroid gland produces two hormones, T3 and T4. When they are produced less than the normal amount, TSH, which is secreted from the pituitary, it increases in amount. So high TSH, low T3, T4 is hypothyroidism. And what is subclinical hypothyroidism? Subclinical hypothyroidism means T3, T4 are normal limits, but TSH is elevated. It is a biochemical diagnosis. Patient is having minimal symptoms. Only thing is TSH is elevated, T3, T4 are normal. And these patients do come to you, about 3 to 5% of the patient do come to you. And what to do in these patients? Subclinical hypothyroidism has been divided into two parts, mild, severe. Mild means TSH is between 5 to 10. Severe means more severe, means TSH between 5 to 10. But T3, T4 are normal. What are the causes of subclinical hypothyroidism? Same as are the hypothyroidism. Autoimmune diseases are the most common, then is the iodine deficiency. Before I take up this, what should you do? I would like to discuss 3 or 4 cases, just within 1 or 2 minutes each case. 28 years old pregnant lady has come to you, pregnant, with TSH elevated, T3, T4 normal, anti-TPO high. What should you do? 8 weeks pregnancy. Patient पूछता है, should I continue with the pregnancy? What are the problems anticipated? What are the TSH should I maintain? Is the treatment required? Let us see. Pregnancy at 8 weeks with subclinical hypothyroidism. This is the diagnosis. We should allow her to continue the pregnancy. We should not act like a god that you should terminate the pregnancy. Maintain the TSH within the trimester specific range. That is less than 2.5 in the first trimester and less than 3 in the second and third trimester. Start with the thyroxine, absolute indication. How the subclinical hypothyroidism affects the pregnancy? It has got adverse effect on the pregnancy loss. It can lead to premature delivery, or it can have the adverse outcome on the offspring, that is IQ might be low. So, a patient who is pregnant comes to you with elevated TSH, must treat her. And target TSH less than 2.5 in first trimester and less than 3 in second and third trimester. Second, a lady who is planning to get pregnant, TSH is mildly elevated, 6.6, anti-TPO are high, T3, T4 are normal. Should the treatment be started? Diagnosis subclinical hypothyroidism with TPO positive. Yes, one should start with the treatment. Why? Pregnant woman, subclinical hypothyroidism, desiring to get pregnant. T4 has got half-life of 1 week. If you start with the thyroxine, it would take 4 half-lives for the effect to come. So, 1 month. And if the patient becomes pregnant, 1 month he would have to spend his pregnancy with suboptimal control of thyroid. So you should start with the thyroxine when the patient comes to you with elevated TSH and if she wants to become pregnant. Target TSH is less than 2.5. So any patient who wants to get pregnant, TSH elevated, start with thyroxine and keep the TSH less than 2.5. Third case. 16 years old female,
comes to you with menorrhagia, TSH is elevated, T3, T4 are normal. Should you start with the treatment? Here the diagnosis is subclinical hypothyroidism with menorrhagia. Menorrhagia can be the earliest manifestation of subclinical hypothyroidism. This patient should be started on thyroxine and reviewed after 2 months. And it has been seen, if you just give the thyroxine, patient might be cured of the problem, and the periods would become normal, and she would never have the recurrent problem of thyroid, of periods problem. So first we have discussed pregnant lady with subclinical hypothyroidism, then person wants to become pregnant. Third, young girl with menorrhagia with elevated TSH. Now fourth case, 29 years old female comes to you with subclinical hypothyroidism, repeated after 3 months, again TSH is elevated, T3, T4 are normal, but here patient is on oral contraceptives, she doesn't want to become pregnant. She has got family history of hyperthyroidism, thyroid is mildly enlarged. What should you do? Subclinical hypothyroidism, in her case, I would not like to start the treatment for thyroxine. Repeat her TSH after 2 months. If the TSH is less than 5, anti-TPO are normal, just mild goiter, I might not like to start with the treatment. If TSH is between 5 to 10, might be I would start with the treatment within her case. Or might be, if more than 10, I would like to start. Between 5 to 10, I would not like to start the treatment at all. And in further testing, 1/3 of the cases TSH becomes normal on repeating the TSH after 2 months. This is a common query which comes to me. Patient is posted for surgery. TSH is elevated. T3, T4 are normal. Patient is already on thyroxine. TSH is less than 10. Should you take up the patient for surgery? Yes. Here it is. Patient is posted for bypass, already on thyroxine and atorvastatin. Can the patient undergo surgery? Thyroid hormone does affect the cardiovascular system. It leads to impaired diastolic function at rest, impaired systolic function on effort, enhanced risk of atherosclerosis and myocardial infarction. Here, given the treatment, it is more beneficial than the harmful effects. And in symptomatic patient, one should treat. And ideally, patient should be given thyroxine at least 48 hours before surgery. Preoperative evaluation of thyroid function is recommended, and it helps in better outcome of the patient. And furthermore, if the TSH is mildly elevated up to 15, you can take up the patient for surgery without any high risk, without any complication. If TSH is more than 15, there are high risk for bleeding, infection, hyponatremia, and delayed recovery from anesthesia. Even then, emergency surgery is not contraindicated. Elective surgery you might like to postpone if TSH is more than 15. In thyrotoxicosis, one should not take up the surgery unless it is life-saving surgery. Furthermore, a patient comes to you with goiter with mild elevation in TSH. She is symptomatic just because of goiter. Should the treatment be started? Medical treatment, early stage of goiter, soft goiter, TSH is elevated, it helps in reducing the size, but to a limited extent. If the patient is having large goiter, there is dysphagia, dysphonia, the surgery is recommended. Especially if you are suspecting it to be malignancy and medical treatment is not practical. Radioiodine, if the patient is thyrotoxic, subclinical or clinically toxic, you must give radioiodine. It reduces the size of thyroid by 30%, non-invasive. So, giving the thyroxine as subclinical hypothyroid, it normalizes the thyroid, patient feels better. But if the compressive symptoms are there, patient should undergo the surgery. So, If a patient comes to you with subclinical hypothyroidism, TSH mildly elevated, T3, T4, you should repeat the thyroid profile after 2 months, get anti-TPO antibodies, first confirm that is persistent hypothyroidism, not transient. Patient can have transient elevated TSH, especially if the patient is recovering from some non-thyroidal illness, and it becomes normal after 2 months. But if TSH is elevated after 1 to 2 months, get anti-TPO antibodies. If anti-TPO antibodies are positive, it leads to 60% chances of patient would develop hypothyroidism in next 10 years. If anti-TPO are negative, their chances are reduced to 25%. So presence of anti-TPO antibodies gives you an edge that the patient should be treated. If anti-TPO antibodies are not available or you want to get the result immediately, get an ultrasound giving an hypothyroxine. Ultimately, it comes from the aspiration biopsy, but this is not recommended in clinical setup unless you are suspecting it to be malignancy. Few of the patient might be having some symptoms of hypothyroidism like dry skin, poor memory, weaker muscle, poor muscle cramps, more feeling cold, deeper and hoarse voice, puffier eyes and constipation. But they are uncommon and these symptoms might improve with starting with the thyroxine. Screening, all ATA recommends that all the people above the age of 35 should be screened for thyroid function test, with the TSH at least. Pregnant ladies, they say they should give the special consideration, but in our setup, it might not be feasible because of the economic factors. So what are the people who are high risk in which you should screen for them for thyroid dysfunction? Female sex, advancing age, patient who is having other autoimmune disorders like type 1 diabetes, celiac disease. There you must get the TSH. Patient with Down syndrome, they are high risk to develop the hypothyroidism. Patient who is having family history of thyroid disease, goiter or previous hyperthyroidism, must screen for the TSH. Or a patient who has received the external beam radiation to head and neck area. Treatment is oral thyroxine. Dose I would like with 25 microgram if TSH is less than 10, or with 50 microgram if TSH is more than 10. In elderly and a patient is having coronary artery disease, I might like to give only 12.5 microgram starting dose and then titrate the dose according to TSH. Repeat the TSH after 2 months and adjust the dose. Target, keep the TSH, young age, less than 50, between 0.5 to 2.5, above 50, between 2.5 to 4.5. How you follow up these patients? If the patient is untreated, you are just repeat the T3, T4, TSH after 2 months. If it has normalized, not to repeat it further. Let the patient, कि आपको मेरे पास आने की जरूरत नहीं है. If you have started with the treatment, then TSH should be monitored at least annually. This is the second last slide. If TSH is, how you treatment algorithm. If TSH is more than 10, start with the treatment. If the patient TSH is less than 10, up to 5 to 9, if the patient is having symptoms or goiter is there or antibodies are positive, then you start with the treatment. If no goiter, no symptom, anti-TPO are negative, you might like to wait. And treatment should be withheld if the patient is more than 70 years of age. Target, TSH should be within the normal limit. Contraindication, just if there is a hypersensitivity to any of the component. Adverse drug reaction, rare. Benign intracranial hypertension in children, and if you overtreat the patient, TSH gets suppressed. Patient would lead to osteoporosis and angina and arrhythmias. Thank you. I am really thankful to Dr. Vidul for inviting me and giving me this opportunity. Thanks a lot. Thanks. If any question, yeah. Yes, ma'am. Yes, Dr. Anurag. Dr. Anurag has asked a very good question. This is a common question which is asked by every person who comes to the OPD. Sir, I have been started with thyroxine. Is there any cure for the same? So here I tell you, there are some causes not known as transient hypothyroidism or transient thyrotoxicosis. There are some causes which leads to permanent hypothyroidism or permanent disease. Transient, that means the disease is, treatment is required for only 3 to up to 3 months. That is postpartum thyroiditis, subacute thyroiditis, or painless thyroiditis, or patient is recovering from the previous some non-thyroidal illness. Here the treatment is required for few days, or I would say few weeks, and the patient recovers. But common causes of hypothyroidism, I'm talking about hypothyroidism. Hashimoto thyroid disease, if you have diagnosed, you have started with the treatment, patient has come to you with TSH of 30 or 40, it is a progressive disorder. Ultimately, patient has to be on treatment throughout the life. In endocrinology, the person who manifests to have some disease like diabetes or thyroid, 90% of the gland is destroyed, only then the clinical symptoms occur. And you diagnose, mostly if the patient you are diagnosed at the time of symptom, the treatment is required throughout his life. Might be the dose adjustment has to be there, but the treatment has to be throughout the life. But in thyrotoxicosis, yes. Graves' disease, you give the treatment for 1.5 to 2 years, 50% of the patient would not require treatment in their lifetime. Graves' disease, it is reversible. Nodular goiter, you give the radioiodine ablation, patient would recover throughout his life. But hypothyroidism, Hashimoto, patient would require the treatment throughout his life. Yes, ma'am. Would you like to? Yes, ma'am. Ma'am has asked a question. If you have screened the person for once, I have screened myself at the age of 35, it is required, it is not to be repeated after throughout my life. No, once in 3 years. Like diabetes and thyroid, once in 3 years, if you screen it for thyroid, that's sufficient. Good. Sir has asked a very good question. Here is the catch. Sir, most of the people are controlled with 200 microgram maximum dose. It is exceptional that patient requires more than 200 microgram. If the patient is not controlled with 200 microgram, TSH is yet elevated, T3, T4 is low, first thing to be done is look for the compliance. Patient, 90% of the cases it is the compliance which is a problem. If compliance is there, even then the patient is not controlled. Then comes why the patient is not controlled. Here it is. There are some factors. Now हमने देख लिया patient ने मुंह से दवाई खाया है. आगे क्या हो सकता है? Absorption नहीं हो रही. What are the factors which are causing poor absorption? Patient is not taking it empty stomach. Patient is iron and calcium absorbs the thyroxine in the stomach and don't allow it to get absorbed. Patient is taking food immediately. Patient उसी समय चाय पी लेता है. Milk चला गया, उसने absorption रोक दी. और taking iron or calcium tablets within 4 hours of taking the thyroxine. Pregnant lady, उसको बोला गया कि iron calcium खाना है. Taking within 4 hours of taking the thyroxine, it is not being absorbed. चाय, coffee, tea कुछ ले लिया तब भी नहीं हो रहा. Third thing is malabsorption. Look for celiac disease, which can be coexisting with this. Celiac disease तो नहीं है, patient को absorption ही नहीं हो रहा. Then fourth thing is patient is taking the drugs which causes the increase the catabolism of thyroxine, like phenytoin, carbamazepine, rifampicin. Patient is on anti-tubercular drug. Patient is taking anti-epileptics. These drugs increases the catabolism of thyroxine. So the dose has to be increased. You have to give higher dose. Patient would not be controlled. Oral contraceptives, they increase the binding of thyroxine. Patient on oral contraceptive dose has to be more. These are the some of the factors. Yeah. Hypothyroidism can become a cancer. This is a good question. Patient ये पूछता है, sir, I am having a goiter. Is it cancer or it is not? If it is cancer, it would be right from the beginning. Hashimoto thyroiditis leading to cancer is really, really uncommon. It is lymphoma, which is reported in 1 in 1 million cases. If it is cancer, you can diagnose it clinically. There would be changes. It would be hard. There would be obstructive symptoms, or ultrasound would show some evidence that it is not purely Hashimoto. It is something different. Or you can get anti-TPO antibodies. Anti-TPO antibodies negative hypothyroidism. You should suspect it can be malignancy. If anti-TPO is sky high, it is Hashimoto and not malignancy. This is how you can make it out. And ultimately, the result would come from FNAC. If you are still doubtful, get an FNAC. FNAC would show it is Hashimoto or iodine deficiency, or it is malignancy. Thank you. Thank you. Thanks.
Sorry to interrupt, sir. What we have seen in our experience, that if there is long-standing hypothyroidism, patient or even in very old age, then we have seen that. We have seen 60 cases, and my presentation is on same. We have seen 60 cases with extranodal lymphomas, and amongst that, 2 were of thyroid. And there was history, chronic history. There was hypothyroidism not getting treated. So that is there. Development of lymphoma is there. But when it develops, it is diffuse large B-cell lymphoma. That is very aggressive.
Yes, lymphoma can develop.
Regular, sir? Not, sir, actually should be treated. If patients were not on treatment, yes, they were not on treatment, not even get detected at any time during their lifetime. Neglected people, like there was one female, 82-year female, that kind of people. Yes.
Thank you. Thanks for the comments, ma'am. Thank you.
Thank you, sir, for sharing your knowledge with us. Now, I would like to call upon stage Dr. Meghna Gupta, Assistant Professor, Department of Psychiatry, KM Medical College, Mathura. Please, ma'am.
Hello everyone. So my topic is stressed, moody or hormonal. Very often we all see people saying, she's so moody, she's so stressed. So as we delve deeper into the topic, we'll see whether it is stress, mood swings, or something deeper and more complicated than that. So these are the contents. Hormone fluctuations that women have every month, we are all aware of these. Estrogen rise happens pre-ovulatory, leading to ovulation, after which corpus luteum is formed, which releases progesterone. Reproductive steroids have been seen to influence ADHD symptoms. Decreased levels of estradiol in the context of increased levels of either progesterone or testosterone were associated with higher ADHD symptoms, particularly in people who had high trait impulsivity, and phase analysis suggested an early follicular and early luteal or post-ovulatory increase in ADHD symptoms. The role of estrogen also played an impact on binge drinking and mean proportion of alcohol consumption in women, which saw a pre-ovulatory rise in episodes of binge drinking. Furthermore, if the pre-ovulatory rise was seen on weekends, the proportion of women that consumed alcohol to cope with symptoms and anxiety was more. Now, incidence of depression across the male life cycle. In men, the incidence of depression rises in puberty and then is essentially constant throughout life, despite a slowly declining testosterone level from age 25 onwards. Whereas in women, the risk of depression varies across the life cycle. Women's vulnerability to the onset and recurrence of depression is seen first with the onset in puberty and young adulthood. Premenstrual syndrome and menstrual magnification are harbingers of future episodes, or there is incomplete recovery from prior episodes of depression. And there are 2 periods of high vulnerability that a women will have depression, And these two situations in life are the postpartum period and the perimenopausal period. Psychiatric history further predicts a risk of perinatal depression. Women with a history of major depressive disorder or depressive symptoms which are present during pregnancy or postpartum depression are at an increased risk for perinatal depression. History of postpartum depression in previous pregnancies is the greatest risk factor. Estrogen also has major effect on cognitive functions. So the mid of this particular graph indicates the approximate range of optimum executive functioning. Increase in dopamine or norepinephrine concentrations, estrogen level, and stress can shift the prefrontal cortex dependent executive functions to the right of the graph, which indicates a decline. Now a little bit about premenstrual mood syndromes, further to emphasize on the fact whether it is mood swings, it is stress, or something deeper than that. Mild mood changes that occur should not be labeled as a disorder, and they are common. These symptoms are less intense and do not result in significant distress or impairment, as opposed to premenstrual syndrome, which has been defined as American College of Obstetrics and Gynecology as one of the affective or somatic symptoms that are listed, which should be present in 3 prior menstrual cycles. Another category of disorders is mental behavioral and neurodevelopmental disorders, including mood disorders that are exacerbated premenstrually. We have to exclude these things. Premenstrual tension syndrome. This includes women that experience cyclic, emotional, physical, or behavioral symptoms that interfere with their lifestyles during the luteal phase of the menstrual cycle, and they are diagnosed and treated as premenstrual tension syndrome. This is in contrast to premenstrual dysphoric disorder, which is more severe. Again, I want to emphasize on a point that neither PMS nor premenstrual exacerbation of pre-existing psychiatric disorders is a recognized psychiatric disorder. Premenstrual dysphoric disorder, this is a recognized entity. It affects 2 to 8% of women during the reproductive years. It occurs much less frequently than PME or PMS. Risk factors include high potassium diet, metabolic syndromes, increased BMI, nicotine alcohol use, childhood trauma, low socioeconomic status, white race, and family history of premenstrual dysphoric disorder. The required features, that majority of the menstrual cycle within the past year, there should have been a pattern of mood, somatic, or cognitive symptoms. And the symptoms should include one affective symptom like mood lability, irritability, depressed mood, or anxiety, and additional somatic or cognitive symptoms. And the symptoms should not be due to another medical disorder or another mental disorder, and should result in significant distress or impairment. Management for premenstrual dysphoric disorder includes exercise, adoption of a complex carbohydrate diet, CBT, serotonin reuptake inhibitors, or combined hormonal contraceptives. Second line, increasing the dose of hormones or SRIs. And the third line, GnRH analogs. Perinatal psychiatric disorders are further another category of disorders that are not just mood swings or are not due to stress. So postpartum withdrawal of estradiol and progesterone occurs rapidly within the first 2 to 7 days postpartum, inducing depressive relapse in women with a history of postpartum psychiatric disorders. Reproductive hormonal fluctuations are associated with disruptions in CNS corticolimbic connectivity that promotes healthy emotional processing. Dysregulation of allopregnanolone plays a role in the development of perinatal psychiatric disorders. Risk factors include mothers with a personal or family history of depression, sleep deprivation, high social stress, marital discord, minority status, adolescence, that is pregnancy that occurs during adolescence, and neuroticism. So perinatal mental disorders range through a wide array of disorders, but we shall only be covering the 2 or 3 more important ones and the ones that occur more commonly. So baby blues, it is a constellation of mood symptoms experienced by women. It is seen very commonly, occurs in up to 80% of women, and it occurs in the immediate postpartum period. It includes transient symptoms of mood shifts, irritability, anxiety, insomnia, lack of energy, loss of appetite, and the feeling of being overwhelmed, particularly about newborn caregiving tasks. Baby blues are transient. The onset occurs mostly on the 3rd postpartum day, peak by day 5, and resolve by day 10. And it has been estimated that 20 to 25% of women who experience baby blues will experience major depression in the future. Treatment involves psychoeducation, validating the experience, and careful monitoring for worsening or prolongation of symptoms. Perinatal depression, earlier we used to call it as postpartum depression. Now the term is called perinatal depression because perinatal onset recognizes symptom onset anytime in pregnancy till 1 month postpartum. Onset during pregnancy is more likely in women with a history of depression. For women without a history of depression, the onset is more common in the 1st month postpartum, and it also increases the risk for a future diagnosis of bipolar disorder. Depressive episodes that occur postpartum are more likely to have characteristics of obsessive compulsive disorder, which includes intrusive violent thoughts and psychotic symptoms. Postpartum depressive syndromes affect 15% of mothers, and the rates are triple among low socioeconomic, minority status, and adolescent mothers. Risk factors include personal or family history of depression, personal history of previous depressive episodes like we saw in the slide before, and women that face multiple or severe psychosocial problems, patients who have a history of trauma, chronic interpersonal difficulties, and history of childhood sexual abuse. Pharmacological treatment for this is something that is very controversial because if we treat it, we have a lot of risk, and if we don't treat it, still the risk is there for the female. If we treat, there can be cardiac malformations, there can be newborn persistent pulmonary hypertension, which is seen with the use of SSRIs in the 3rd trimester. There can be neonatal withdrawal syndrome. The child can be born prematurely and the birth weight can be low. There can be neurodevelopmental abnormalities. And if we don't treat it, there is risk of relapse of major depression. There's risk of increased suicidality, poor self-care, poor motivation for prenatal care, among other things. So for management, amongst SSRIs, sertraline seems to have the least placental exposure, and most data supports the use of fluoxetine. Brexanolone is a newer compound which has been approved by the US FDA, and zuranolone, but the use is limited due to its availability and high costs. Non-pharmacological treatments include CBT, interpersonal therapy, mindfulness, light therapy, supplements. Supplements can be used as adjunctive therapy. There is not much evidence to support its use as mainstay. And research is too limited on effects of exercise, yoga, massage, and acupuncture. ECT, that is electroconvulsive therapy, it has not shown to cause any harm to the mother, but it is given under general anesthesia, which has its own risks. And ECT can be used for women with severe depression, mixed affective states, mania, catatonia, or when the physical health of the mother or that of the fetus is at serious risk. Postpartum psychosis, it is most severe and very rare as well. It presents within the first few weeks following delivery. The symptoms can be seen, that is depersonalization, delirium, agitation, insomnia, delusions, and affective symptoms predominate, which is why it is an affective psychosis. Women with pre-existing bipolar disorder are at very high risk, and women with new onset postpartum psychosis are eventually diagnosed with bipolar disorder in 50 to 80% of cases. Now, postpartum psychosis is a medical emergency because of the potential risk of infanticide or suicide and requires urgent referral to a psychiatrist, and hospitalization is needed. Mostly lithium is started in such patients. This is the rest of the treatment, which I'll skip. Now, menopausal transition is another such aspect in a woman's life where we often see people saying that one is stressed or moody. Again, we need to see whether it is just a mood swing or it is something more than that. So menopause is the cessation of ovulation and absence of menses for 1 year. It is due to the depletion of responsive ovarian oocytes and generally occurs between 47 to 53 years of age. So perimenopause describes the period of hormonal fluctuation eventually leading to amenorrhea. Women frequently experience somatic and psychological symptoms during this period. Physical symptoms include vasomotor symptoms or hot flushes, which are the hallmark of the postmenopausal transition. It is distressing sequelae and consists of sudden episodes of perspiration, flushing, chills, clamminess, anxiety, and a sense of extreme heat. Symptoms last for 1 to 5 minutes and occur daily in over 85% of women, and in some it can occur up to 10 times daily. Lifestyle alterations mostly help, or hormone therapy with estrogen alone or with progesterone is indicated. If there are contraindications to hormone therapy, SSRIs and SNRIs can be used. Menopausal status and depression. So there is a 2 to 4-fold increased risk of depressive symptoms during perimenopause. And other risk factors for perimenopausal depression include personal history of mood disorder, previous history of reproductive related mood disturbances, and psychosocial stress. Perimenopausal cognitive changes have also been seen. Women struggle with verbal recall, that is immediate and delayed recall is affected, and processing speed is also affected during perimenopause. Some studies have used atomoxetine and lisdexamfetamine, but the limitation remains that it causes hypertension and tachycardia. Antidepressants can also be used for patients who have cognitive symptoms in association with comorbid depression. These are my references. Thank you.
Thanks, ma'am. Thanks for such a nice presentation. Ma'am, you have mentioned that hormonal treatment can be given in the menopausal females. So is there any, for how long can be given, and is there any criteria that?
So since I am a psychiatrist, if a patient would require hormone therapy, I would refer them to an endocrinologist. So instead of initiating it myself and going in for whatever investigations are needed.
Because hormonal therapy will have side effects.
So we will not. We start medication for patients who have contraindications to hormone therapy, or patients who have comorbid depression or have cognitive decline. So for them, we would like to start either SNRIs or SNRIs instead of going in for hormone therapy.
Okay. Thank you.
Thank you.
Thank you for your excellent presentation, ma'am. Now I'd call upon Dr. Manjeet Kaur Rana, Additional Professor and Head, Department of Pathology and Lab Medicine, AIIMS Bathinda, to present her topic, Extranodal Lymphomas, Trends and Presentation.
So, a very good afternoon, everyone. So, I'll start with my topic without any delay. I'll just share my experience what we have seen in this region. So before that, I want to just brief something about the extranodal lymphomas. So these lymphomas are those lymphomas that occur outside the lymphatic system, means not in the lymph nodes, or not involving the marrow. And these lymphomas can arise from the different organs, the extranodal organs. So most common site is the stomach, and followed by skin and intestine. But most common site is the stomach, as we know. So coming on to the patterns of the extranodal lymphoma, so most common pattern is the diffuse large B-cell lymphoma. So very aggressive, will respond to treatment, but this is the most common type, followed by others, slow growing and other lymphomas. So what is the incidence? Why I have chosen this topic that should be discussed? Because the incidence is bit on rise now, and is increasing in India also. As you can see on the screen, the incidence of extranodal lymphoma was more in the Italy. The reasons may be multiple, environmental and viral causes, different causes. But in India, the incidence was only 22%. This is a main elaborated format where we can see that these lymphomas, they have now different kind of incidents, more in Kuwait, lesser in the Thailand, and these incidence of the lymphoma is different with the different organs also. So different organs, they have different kind of incidence in the different regions. Now what is the problem? What problem arises in India? In the North India, a very few studies has been there in the literature that those show that what is the exact incidence of these extranodal lymphomas. So one study shows that there is increasing trend. So they have mentioned that there is 44% 44% incidence of extranodal lymphomas amongst the patients, and they have done this study for the approximately 3 to 4 years. So, but in the South India, the study conducted for the same time has shown the same incidence as it was seen nationally. So it is only 22%. So because of that, what we have observed in our area, because we were receiving patients with extranodal lymphomas, unexpected cases. So we have also tried to elaborate the data, to collect the data, just to analyze what is happening over here. So in our region, in our area, because we are draining patients for Punjab and Haryana and Rajasthan, so in our area, what we have seen that incidence is 31.25%, and let me tell you, this is just within 1 year. Okay, so patient age range you can see starting from 9 to 83 years, and median age is 67. So over here, what the difference is that patients are presenting with extranodal lymphomas in the very early age also, and that is a bit alarming. And more commonly, the patients were more in the cases were more seen in the males. So here we have collected few cases who were, I want to show that these are the cases who were rare, although extranodal lymphoma itself is a rare entity, but we have seen rarest of the rare cases. As in the first row, you can see 9-year female presenting with swelling over the left thigh. And initial diagnosis was given lymphoproliferative neoplasm only, because we were not sure that this diagnosis should be given to this or not. FNAC was done at PGI, and then patient was over here for the treatment. And even on HND, we couldn't make the diagnosis because we're not suspecting that Hodgkin lymphoma can present as a left thigh swelling. So on IHC, the lymphoma was confirmed as Hodgkin lymphoma. And next, GIT is a commonly involved site for the extranodal lymphomas, as I have already shown that stomach is more common, so I'll not discuss that. Liver also, liver itself cannot show like liver itself, most of the times not as a part of extranodal lymphoproliferative disease, but over here also we have seen this case, and it's a very low grade type of lymphoma. And on imaging studies also and clinically also, this patient was diagnosed as metastatic disease in the liver. Next is a nasal septum. This condition is also rising nowadays. On IHC and on imaging studies, the picture was looking like undifferentiated malignant neoplasm only. There's undifferentiated carcinoma of the nasal septum. So it was looking like that on histo also and imaging also. But on IHC, when we applied the markers, primary panel and lymphomas, lymphocytes were found to be positive, and this was diagnosed on IHC as plasmablastic lymphoma. And next is the left orchidectomy patient. Patient presented with a diffuse large swelling in the testis. So patient was diagnosed as lymphoma. I'll discuss about this patient. Rest all the things like in the previous lecture, sir from the DMC has also showing that there is rare development of the lymphoma in the thyroid. And over here we have seen more commonly this thyroid lymphoproliferative disorders, and we have diagnosed these cases as diffuse large B-cell lymphomas. So in all these patients, because large trials are not available, large studies are not available. So over here in our patients, what we have seen was duration was more. These lymphomas were seen in the neglected patients excepting the child age group. Otherwise, like thyroid or any else, like in the spleen and liver, the patient were having this problem from the many years, or duration was more. So some underlying disease may be there for the development of this lymphoma. This was just to show what is happening in the nasal lymphomas. Now, why there is increase in plasmablastic lymphomas? Because EBV infection is more, and Epstein-Barr virus is known for the carcinomas in the nasopharyngeal area, and this is now found to be linked with the plasmablastic lymphomas of the nasal septum. So another case where the testicular biopsy showed lymphoma. In the testes also, there is no association with any virus as seen in the nasal cavity. There is no association with any H. pylori type of thing, and that is seen in the stomach, and no pre-existing celiac disease as in the small intestine. So in the testes, there is no association with any existing disease, and there is some mutation in the signaling pathways during the cell cycle. So that lead on to lymphomas. It's very, very rare. And the one patient presented to our department with the testicular swelling. And on imaging also, there was no link of lymphoma, diagnosis of lymphoma, as the patient was 65-year-old. Obviously, germ cell tumors was not in the mind, but clinical history, imaging studies, and tumor markers were favoring there will be a germ cell tumor. And so that's why left, as we can't perform biopsy on the testes, so without any clinical further exploration of the patient, left high inguinal orchidectomy was performed. And on histopathological examination, what we have seen was uniform cells present on the slide. So those uniform cells can be seen in the seminomas also. Those uniform cells can be seen in the embryonal cell carcinomas also. But we thought, we saw the slides on the multiple reviews. We make a possibility that these are atypical lymphoid cells. There was mitotic brisk activity. But the problem against was these cells were not involving any external part, or the spermatic cord margins were free. Usually in lymphoma, these margins won't be free. So then IHC was applied. In the IHC, primary panel was applied. Primary panel showed positivity for the lymphoid cells. Then secondary panel was applied. And testicular lymphoma, although they are very rare, but they show positivity for the BCL2 and BCL6. We have applied all the markers, CD5, 10, 23, BCL6, cyclin D1, PAN, CK, HMB45 to rule out all the baseline possibilities. But what we have seen that Ki67 was very high. That goes in favor, there will be possibility of lymphoma. So these were the slides. We have seen morphological monomorphic population of the cells, and these I think pathologists can make out if possible. Then these slides look like seminoma testes. So from here we cannot make any clue that this is a patient of non-Hodgkin lymphoma. So then CD45 was applied. So CD45 positivity, the brown color shows the positivity for the lymphoid cell, as CD45 will be positive in the lymphocytes. Then further to classify whether it's T cell lymphoma or B cell lymphoma, CD20 was applied. CD20 showing positivity, so this means lymphoma, and the population is for the B cell type. Now all the markers were applied, all the markers were negative. Unfortunately, BCL6 was negative, 2 was negative, so we couldn't make what kind of lymphoma is this. Then MUM1 was applied. So last marker for the B cell lymphomas, and it turned out to be positive. So the diagnosis of, see, all the markers are negative. This is Ki67. So diagnosis of diffuse large B cell lymphoma was given, activated B cell type was given. So story यही नहीं रुक रही थी patient की. Patient again presented with pleural effusion. This was a rare case. Extranodal lymphomas are itself rare. Then the case was rare. Then further, that patient has atypical presentation. Patient presented with pleural effusion. So in the pleural effusion itself is very less commonly seen in non-Hodgkin lymphomas. Can be seen in the nodal lymphomas, but it's very, very rare in the non-Hodgkin, extranodal non-Hodgkin lymphomas. So this is the relevantly what I could find article just to show that the massive pleural effusion can be seen in the lymphomas. But in this article also I couldn't get that testicular lymphomas can present as pleural effusion. So patient again was in the ICU, and pleural effusion was sent for the diagnosis. So in the pleural effusion we had atypical lymphoid cell on the slides, and as we know the patient, we thought that these cells may be positive for the lymphomatic cells, but pleural effusion is very, very rare in these patients. So we were little again furious and confused what should be done next. So this is the smear with showing lymphoid cells, and these kind of cells can be seen in the pleural effusion of the tuberculosis patients also. So again, the lymphoid cells, again, we have tried to make this cell block of the patient. We have collected the cells, and we have tried to make with the cell block with the new technique, because we had to make the diagnosis, because it's easy to make the routine diagnosis, but when an atypical presentation with the rare cases it presents, it seems difficult. So on this block, further IHC was applied. Obviously, these cells were CD45. So this slide is from the ICC, intracytoplasmic cytochemistry, and I'm very happy to tell that we have good team in the pathology, and this type of technique is not available in any AIIMS except AIIMS New Delhi. So we are trying this. We have tried this technique, and the patient was benefited with the technique. I'm very thankful to my team. So we have applied CD20 also. It's positive for the cells, for the B cells, and again MUM1, that was positive. The only marker positive in the testicular tissue was positive in the pleural fluid also. So diagnosis was given as the testicular lymphoma infiltrating into the pleural area also. So conclusion is simple. Extranodal lymphomas, they can present as a diverse group of hematological malignancies, and they have various type of presentations, different kind of presentation, different kind of histopathological types, and they have different kind of response to the treatment. As far the treatment is concerned, that they are a bit resistant to the normal treatment that has been given for the non-Hodgkin lymphomas. And most commonly involved areas are stomach and skin, and very rare is the brain and testes. So accurate diagnosis with accurate technique and immunophenotyping is a need of our. and the prognosis definitely is affected by the involvement also. Like if the brain is involved, instead of symptoms from the lymphoma, the symptoms of the pressure on the brain will will cause the poor prognosis in the patient. So external lymphomas, they present unique challenges in the diagnosis and management due to their heterogeneous nature and varied clinical behavior nowadays. So ongoing research into the molecular characteristics of these lymphomas should continue for our understanding and improvement of the treatment. Thank you. Thank you very much. Any question, please? Yes, sir.
Not present in nearby or in Punjab.
Yes, sir.
So patients are going to be benefited.
Yes, sir.
And for record, I must thank you for other role
Yes, sir.
as in charge of your guest house.
Thank you, sir.
And we are really thankful that 15 guests are there.
Thank you, sir.
And they are comfortable under your guidance, and we must thank from our organizing committee.
Thank you, sir. Thank you, sir.
Provide accommodation comfortably to all the guests.
Sir, I want to add over here, you have given chance to us that to.
Most of the people don't think like that.
You would have conducted this to somewhere else also, sir. So you would have given chance. If you would have not given chance, so how would I? Thank you, sir. Thank you.
Thank you, Dr. Manjeet ma'am. The presentation was incredibly insightful and helpful. Without wasting much of our time, now I would like to invite Dr. Deepak Bansal, MD DM Gastroenterology, consultant at Wincare Hospital, Bathinda. Sir.
Good afternoon, everyone. First of all, I would like to thank Professor Vitul Gupta and the entire organizing committee for giving me a chance to speak here. I would be speaking on interpretation of liver function test. First of all, the liver function test, the term is both imprecise and misleading. It is because the commonly used biochemical test may be abnormal even in patients with normal liver, healthy liver, and health of the liver are not direct measure of its function. These are the commonly used measured liver function tests in the serum. The commonly used are alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase, serum bilirubin, serum albumin, prothrombin time, and 5-nucleotidase. We further subdivide these liver function tests into two categories. One are the tests of hepatic synthetic function, and the other are the test of liver injury. Serum albumin, bilirubin, and prothrombin time. These three are the markers of hepatic synthetic function, and ALT, AST, alkaline phosphatase, bilirubin, these are the markers of liver injury. Depending upon the duration of the disease onset and illness, the pattern of liver test abnormalities are divided into acute, subacute, and chronic. Acute are other diseases in which the onset of symptoms are less than 6 weeks, subacute are 6 weeks to 6 months, and chronic are more than 6 months. So based on the pattern of elevation, the liver test abnormalities can be hepatocellular, cholestatic, or isolated hyperbilirubinemia. In the hepatocellular pattern, there is a disproportionate elevation of serum aminotransferases as compared to alkaline phosphatase. Serum bilirubin may be elevated, but the test of hepatic synthetic function may be abnormal. In cholestatic pattern, there is a disproportionate elevation of alkaline phosphatase compared with the serum aminotransferase. Serum bilirubin may be elevated, and test of synthetic function may be abnormal. In isolated hyperbilirubinemia, patient usually have an elevated serum bilirubin level with normal serum aminotransferases and alkaline phosphatase. There is a concept of R value which help us to determine the type of liver injury, whether the patient is having hepatocellular type of liver injury or a cholestatic pattern of liver injury, especially in patients who have both elevated aminotransferases and alkaline phosphatase. R value is determined by the ratio of alkaline alanine aminotransferase oblique upper limit of normal of ALT divided by alkaline phosphatase over upper limit of normal of alkaline phosphatase. So R value is interpreted as if it is more than 5, it is a hepatocellular injury. If it is between 2 to 5, it's a mixed pattern. If it is less than 2, it is a cholestatic pattern. These are the commonly encountered clinical problems. We are just describing the ratio of AST and ALT elevations. In alcohol-related liver diseases, the AST is usually less than 8, ALT is less than 5, but the ratio of AST to ALT, if it is more than 2, it is significant, it is suggestive, and if it is more than 3, it is significant. NASH, the AST to ALT ratio is less than 4 times the upper limit of normal. Acute viral hepatitis or toxin-related hepatitis, both AST and ALT are more than 25 times the upper limit of normal. In ischemic hepatitis, this is more than 50 times the upper limit of normal. In chronic hepatitis C virus, there is a wide variability of aminotransferase elevation. Typically in chronic hepatitis C virus, they are usually less than 2 times the upper limit of normal, but rarely it can goes up to more than 10 times the upper limit of normal. In chronic hepatitis B virus, levels of aminotransferases vary. They can be normal in inactive carriers, and they can have mild to moderate elevation that is usually less than 2 times the upper limit of normal, but with exacerbations they can be more than 10 times the upper limit of normal. A brief about AST to ALT elevation. The most cases of hepatocellular injury, we see usually the ALT is more than AST, but in few conditions the AST to ALT ratio is more than 2. These conditions are alcohol-associated liver diseases, NASH, cirrhosis, advanced liver disease means due to viral hepatitis, or acute Wilson disease. So first we will take the topic of aminotransferases. The elevated aminotransferases, they are further subdivided into 3 parts. Aminotransferases elevation in the presence of liver failure, marked elevation of aminotransferases in the absence of liver failure, and mild to moderate elevation of aminotransferases in the absence of liver failure. So what is liver failure? Presence of any encephalopathy or coagulopathy, or both. Coagulopathy means INR of more than 1.5 in the presence of raised aminotransferases. Usually these liver tests are typically more than 10 times the upper limit of normal. So there are conditions in which we have marked elevation without liver failure. What we call as marked elevation, in which the aminotransferases are more than 15 times the upper limit of normal. What we take it as a normal limit, it is 33 for males and 25 for females. The condition in which we get marked elevation are acetaminophen toxicity, idiosyncratic drug reactions, acute viral hepatitis, alcohol-related hepatitis, autoimmune hepatitis, Wilson disease, vascular disorders such as ischemic hepatitis, Budd-Chiari syndrome, sinusoidal obstruction syndrome, and HELP syndrome. In muscle disorders, we can see in polymyositis and rhabdomyolysis. So the initial evaluation of markedly elevated aminotransferases come from these etiologies. We get an acetaminophen levels, toxicology screen, viral markers such as IgM, anti-HAV, HBs antigen, total anti-HBC, anti-HCV, anti-herpes simplex virus, anti-CMV antibodies, heterophile antibodies, autoimmune markers. Ultrasound abdomen with Doppler imaging to look for vascular obstruction such as Budd-Chiari syndrome, and serum pregnancy test in a women of childbearing age. Suppose all these tests are normal. So we have to further pursue this patient. For the additional testing, we have to rule out Wilson disease. For that, we have to check for ceruloplasmin level, 24-hour urinary copper estimation, KF rings, hepatitis D virus antigen, hepatitis E virus antibodies. In case of muscle disorders, we have to look for creatinine kinase or aldolase. Urine analysis, especially to check for HELP syndrome in pregnant patients, And if all the above testing is normal, we may proceed with liver biopsy. Next, etiologies of mild to moderate elevation, what are called as mild to moderate elevation of aminotransferases in the absence of liver failure. These levels are usually less than 15 times the upper limit of normal. Again, the common causes are medication use, viral hepatitis, alcohol-related conditions, metabolic disorders such as hemochromatosis, NASH, autoimmune disorders such as autoimmune hepatitis, Wilson disease, alpha-1 antitrypsin deficiency, vascular disorders such as congestive hepatopathy, adult bile ductopenia, malignant infiltration, muscle disorder, and we have seen many cases of thyroid disorder and celiac diseases initially presenting us with elevated aminotransferases, adrenal insufficiency and anorexia nervosa. Initial elevation of mild to moderate elevation is viral markers for hepatitis B and C. For hemochromatosis, it is transferrin saturation, serum ferritin levels. For NASH, ultrasound abdomen, /CT, MRI. Further testing includes for autoimmune hepatitis, ANA, SMA, anti-LKM1, for Wilson disease, again ceruloplasmin 24-hour urine copper, KF ring evaluation by an ophthalmologist, for alpha-1 antitrypsin deficiency, serum alpha-1 antitrypsin levels or phenotyping, for thyroid disorder, TSH, free T3, T4, for celiac disease, TTG antibodies. Mainly we use IgA anti-TTG. In patient, those who are deficient with IgA, we can use other tissue transmitted glutamine antibodies also. If still the source of liver abnormalities is unclear, we check for adrenal insufficiency, for which we do 8 AM serum cortisol levels, plasma corticotrophin levels, a high dose adrenocorticostimulation test, muscle disorders such as creatine kinase or aldolase. Liver biopsy is again used for patient in whom the above testing is unrevealing. So for practical purposes, what we do? For practical purposes is, suppose if we are still not able to get the exact etiology, we may follow an expectant observation if the AST/ALT levels are less than 5 times the upper limit of normal and no chronic liver disease has been identified. We do a repeat testing after 3 to 6 months of AST/ALT, and if still the etiology is unclear or the levels of AST/ALT has not decreased, we do a liver biopsy in whom the AST/ALT are persistently more than 2 times the upper limit of normal, particularly if the non-imaging testing suggests that advanced liver fibrosis is not present. Biopsy is both reassuring to the clinician as well as the patient by confirming that there is no advanced or serious liver disease. The second liver function test is alkaline phosphatase, which is mainly seen in cholestasis. In liver diseases, cholestasis can be extrahepatic cholestasis or intrahepatic cholestasis. Level of alkaline phosphatase does not differentiate between extra or hepatic, intrahepatic cholestasis, because in both these conditions, the level of alkaline phosphatase is usually more than 4 times the upper limit of normal. Alkaline phosphatase can be seen in can arise from various other tissues such as placenta, bone. So if we have to look for whether this alkaline phosphatase have came specifically from liver, we get an additional test of 5-nucleotidase or GGT. If any of these markers are elevated, presumably the alkaline phosphatase is of liver origin. What are the common extrahepatic causes of cholestasis? CBD stones called as chordocholithiasis, periampullary malignant obstruction such as head of pancreas, gallbladder, ampulla, distal bile duct, metastasis to perihilar lymph node, or it also can be seen with primary sclerosing cholangitis with an extrahepatic bile duct stricture, chronic pancreatitis such as autoimmune pancreatitis which causes stricturing of the distal bile duct, or AIDS cholangiopathy. First of all, we have to look whether this is really extrahepatic cholestasis, for which we get an imaging by an ultrasound abdomen. If it clearly shows a distal CBD stone, it's okay. If still if we are not clear whether the patient is still having what is the etiology of this extrahepatic cholestasis, we may proceed with MRCP, endoscopic ultrasound. Endoscopic ultrasound can be both diagnostic and therapeutic, CT abdomen. and if needed, ERCP can done, which is usually done nowadays only for therapeutic purposes, but it can be diagnostic also. For intrahepatic cholestasis can be caused by drug toxicity, primary biliary cholangitis, PHC, viral hepatitis, or infiltrative diseases of the liver. Other causes are cholestasis of pregnancy, benign postoperative cholestasis, patient on long-standing TPN, or ischemic cholangiopathy. For the evaluation of intrahepatic cholestasis, usually we look for primary biliary cirrhosis AMA test or for autoimmune markers such as ANA and TSMA. If AMA is positive, we do a liver biopsy to confirm primary biliary cirrhosis. If AMA is also absent, we do additional testing such as MRCP, viral hepatitis A, B, C, E, and other viruses such as Epstein-Barr virus and cytomegalovirus, and definitely pregnancy has to be ruled out. What is the role of liver biopsy in intrahepatic cholestasis? If the above tests are negative and the ALP is still present and for more than twice the upper limit of normal, even after 6 months, we obtain a liver biopsy, which may reveal infiltrative conditions such as sarcoidosis, malignancy, vanishing bile duct syndrome, or idiopathic adulthood bile ductopenia. Rule of 6 months is not compulsory. We can get it done early also. Isolated GGT, it can be elevated in many conditions, but the main role in liver disease is just to confirm whether the alkaline phosphatase is of liver origin. Isolated hyperbilirubinemia can be conjugated or unconjugated. Unconjugated is usually from overproduction or impaired conjugation. Conjugated is because of the decrease released from the bile ductules. Unconjugated hyperbilirubinemia can be considered in the absence of hemolysis because of the impaired hepatic intake, which can be caused by drugs or benign conditions such as Gilbert syndrome. There are other conditions such as regular Nazar 1 or 2, which are usually seen in pediatric population, in which there are defective glucuronidase enzymes. Conjugated hyperbilirubinemia, mainly there are 2 references. One is Dubin-Johnson and Rotor syndrome. Distinction is not entirely required because these are benign conditions and the direct fraction of bilirubin is more than 50%. Patient have a normal GGT and ALP. Patient is having asymptomatic jaundice in the 2nd decade of life. In Dubin-Johnson syndrome, there is a altered hepatic excretion of bilirubin into the bile ducts, and in Rotor syndrome, there is defective reuptake of bilirubin by the hepatocytes. A word about test of hepatic synthetic function. First is prothrombin time. Prothrombin time is elevated in acute liver failure, chronic liver diseases such as cirrhosis or vitamin K deficiency. For practical purposes, any patient who comes with raised prothrombin time, we give a vitamin K supplementation. If it is still raised, we look for the other conditions such as chronic liver disease. The second is serum albumin. In liver condition, it is usually decreased in chronic liver diseases, but it can also decrease in many other conditions such as protein losing enteropathy, nephrogenic loss of serum albumin. Thank you. So these are common problems we encounter.
So that is why awareness among healthcare professionals about interpretation is really important so that they can make people aware. So I must thank you for delivering this great awareness talk about interpretation of liver function.
Thank you, sir. Thank you, sir.
Thank you. Now we'll take a few moments for the certificate distribution of the paper and poster presentation sessions. I request Dr. Preeti Singh, Dr. Amandeep Kaur, and the judges for the poster presentation and oral presentation to kindly come on the stage to give away the certificates. And I request the presenters to kindly line up.
Presenters for oral presentation, Ashish Mahajan, Aishwarya, Gurjot Singh, Ishan, all the presenters kindly come and collect your certificates. आशीष महाजन, ऐश्वर्या, गुरजोत सिंह, ईशान, लविश, रोहित, शुभ्रा शुक्ला, वीरेश वर्मा, मोहित गोयल। Presenters for poster presentation, Ashish Mahajan, Arushi Goyal, Isha, Ishan, Karan Garg, Mehak, Rohit, Shubhra Shukla, Uday, Vansh Mahajan, Viresh Verma, Mohit Goyal. Ishan, Karan Garg, Mehak, Rohit, Shubhra, Uday, Vansh, Viresh, Mohit. We thank Dr. Preeti and Dr. Aman for conducting a successful session, and we thank the judges for their deliberation. Now we'll move forward to our next presentation. Dr. Shweta Bhandari, Consultant Endocrinologist, Wincare Hospital, Bathinda, on her topic, Delayed Growth of a Child, What to Do.
Good afternoon, everyone. Today I'll be speaking about delayed growth of a child and then what needs to be done. So let's first discuss what are the determinants of postnatal growth. So the postnatal growth is determined by the hormones, genetic potential of a child, and the various factors which helps in growth regulations like vitamin D. So if we see for the infancy, the major factor which regulates the growth in infancy is the nutritional status of a kid. Later, as the child grows, the prepubertal children, their growth is influenced by the hormonal factors like growth hormone IGF-1 axis, insulin, and the thyroid hormone. Then, most important is the hereditary. The later, when there is a postpubertal spurt, the gonadal steroid hormones plays a very important role in increasing the height of the kid. So before coming on to the short stature, we have to see what is the normal growth pattern of a child during the childhood. So here we can see the two graphs. The above one is the height in centimeter, and the below one is the height velocity. That is the height gain centimeter per year by the children. So when the child is born, the height is generally around 50 centimeter in height, the growth is 50 centimeter. And then during the initial first year of the life, they increase, the growth is, they grow by 25 centimeter, and by second year, by 12 centimeter, and by third year of life, they grow by 8 centimeter. And then there is a slowing of growth by 5 centimeter per year, and then we have the postpubertal growth spurt, which is for the boys, it is 9.5 centimeter per year, and for girls, it is 8.3 centimeter, which accumulates to be around, the boys gains height around about 28 centimeter during their puberty time, and girls gain by 25 centimeter. So now, what is the patients who need to be evaluated for short stature, or how do we define the short stature? So first, it's very important that we measure the height correctly. So the child has to be without footwear, heels and back should be touching the wall, they should be looking straight, and firm pressure should be applied to the mastoids from underneath. So here we can see the growth chart. So the growth charts plays a very important role in determining whether the child is a short stature or not. So any child whose height is below the third centile or 2 standard deviation for age gender in a given population, that we call term as short stature. Or when the height is more than 1.5 standard deviation below the mid-parental height, or when there is a fall in the growth velocity below the 25th centile, that we call the child is having short stature. So how do we calculate the standard deviation? The standard deviation we calculate by subtracting the height at the 50th centile from the third centile and then divide by the 2. That is called the standard deviation. When it is 2 standard deviations below for that age, that is called the patient is having short stature. Then the height velocity, we do not measure the child's height every 1 month, every monthly. We measure them over the 6 months, over the 1 year. If in spite of that, the patient is not gaining the height, or the patient's height velocity is not increasing, then also we term that the patient is having short stature. So these are the tools for monitoring the growth charts. So for the patients of age less than 5 years, we use the WHO growth charts, and when the child is more than 5 years, we use the IAP growth charts. So both the charts for boys and girls are different. Then we have the syndromic charts also for the Turner syndrome, achondroplasia, and Down syndrome. They are different. So very important is to calculate the mid-parental height. So why do we want the mid-parental height? Because it helps in predicting the height of a child according to the genetic potential. So the MPH is, for the boys, we calculate by measure the father's height and mother's height, add it, divide by 2. For the boys, add 6.5, and for the girls, subtract the 6.5. That is the mid-parental height for the kid. And then it is very important that we calculate the height age also, because height age again tells us about what is the genetic potential of the child, and at what point the child was having the disease also. So that we calculate by the height age. So height age is the age of the child at the 50th centile. The growth velocity or the height velocity is the child's height over the period of time. We generally see over the duration of 1 year. So these are the another important for calculating, for predicting the height is the bone age. Then we determine by the atlases which are available online also. We generally use a Grulich pile atlas method, or we use the Tanner Whitehouse method. All the softwares, they are available online. So the bone age also helps in calculating whether what is the genetic potential of the child, or what are the other, like we can sometimes diagnose with the photograph of the wrist joint, like the patients are having rickets or the patients are having Turner stigmata, we can see from the hands x-ray also. After seeing for the bone age, after calculating the bone age, then we have to see whether the child growth, it is proportionate short stature or disproportionate. So generally by 8 to 10 years of age, the upper segment and lower segment ratio is around 0.8 to 1. So if the patient is having the upper segment to lower segment ratio is more than 1, and the patient is having the short limbs, then the differential diagnosis is either the patient can have hypothyroidism, rickets, achondroplasia, or osteogenesis imperfecta. If the upper segment to lower segment ratio is less than 1 and they are having short trunk, then the differential diagnosis is mucopolysaccharidosis and kyphoscoliosis or any kind of skeletal dysplasias. So first we see whether the patient is having short stature by calculating from the bone age, or by seeing for the height velocity and calculating the standard deviation, or the patient is having when they are having less than 3rd centile. So when we have diagnosed that patient is having short stature, look for the dysmorphic features. If the dysmorphic features are present, then they are a separate entity, like either they can be Turner, Down, or Russell-Silver syndrome. If these dysmorphic features, they are absent, then we have to look for whether it is disproportionate short stature or proportionate short stature. So disproportionate we have already discussed. In proportionate short stature, then we check for the height age, weight age also. So whether the weight is more or not. Generally in endocrine disorders, the patients, they have more or they are overweight as compared to their height. So if the height age is more, if the weight age is more, then either they can be growth hormone deficiency or the Cushing syndrome. If they have normal weight for height, then we have the normal variants of the short stature, that is CDGP, that is constitutional delay in growth and development, or FSS, that is familial short stature. Or if the weight is below as compared to the height, then generally the patients are having the chronic systemic illness or malnutrition. So now the short stature, either it can be normal variant. If the bone age is less than chronicle age, check for the weight age. If the weight age is more than height age, mostly it is endocrine problem. If the weight age is more than, if the weight age is less than height age, it is more of a systemic illness. So we will be discussing some few examples for short stature. So we have a 8-year-old female. She was having short stature from past 2 years. No history of any systemic or chronic illness. Her height is 110 centimeter with a height age of 5.5 years. And her bone age was, X-ray was done, and the bone age was found to be 8 years. For her biochemical parameters, all the tests like CBC, RFT, LFTs, thyroid profile, they were all normal. So now we have a healthy child. She is having normal appearance, but the height centile is same as the MPH centile. That what we mean by that is the height age of the height is which is less than 3rd centile, and the mid-parental height is also between 5th to 10th centile. So the child is going to grow at the same level, but ultimately she will be the short stature, but the height will be same as that of the parents, because the bone age is equivalent to chronological age. So when the bone age is equivalent to chronological age, mostly the patient is having the familial short stature, which is a normal variant, because the parents are having short stature. So the mid-parental height is between around about 3rd centile. So ultimately the child is going to have a growth velocity about the curve of the 3rd centile only. The next case, again of normal variant, that is the 14-year-old male complaining of short stature since 10 years of age, and main complaint is delayed development of secondary sexual characters. And when the history was taken, the father also had the delayed development of secondary sexual characters. So on examination, upper segment and lower segment was 0.9, that is proportionate short stature. SMR was, pubic hair staging was 1, testicular volume, which was 4 ml, and the stress penile length was 5 centimeter. So here we can see over the growth chart that the height, because the height of the child was below the 3rd centile, so the child was having short stature, but the mid-parental height, the height age was 11 years. So the patient was having the bone age was equivalent to height age. So there was a family history of delayed puberty. So we diagnosed to have the constitutional delay in growth and puberty. So these are the both where we can compare the growth charts of both the familial short stature and CDGP. So here we can see that during infancy time, both the children, they grow at the similar height, but as they grow, their height velocity slows down, and their height potential is generally less than 3rd centile. But with the familial short stature, at the time of the puberty starts at the normal time, and they reach up to their mid-parental height. But that is not for the CDGP. So there is a delay in puberty. So the child, when there is a delay in growth, there is delay in the puberty. So when the pubertal spurt occurs, the patient will have ultimately the normal height as compared to the parents. Now coming on to the next case, so 15-year-old male with a short stature, which is having the deformity, that's the rickets case. So again here we can see the patient is having short stature. The weightage is again low, whereas the bone age again was 7 years, and the height age was also low. So the patient, the bone age was less than chronological age, and again the patient was underweight for the height. So we got the biochemical test done, in which the calcium phosphorus levels were low, alkaline phosphatase was high, the PTH was level 64.5, and the vitamin D was also low, which again suggests the patient was having secondary hyperparathyroidism. But as we got it done, so because the potassium was 2.9, the pH, on the ABG pH was 7.1, that means there was an acidosis, and the bicarb was also low. So we made the diagnosis of renal tubular acidosis. So now the next question comes, why there is a growth failure in renal tubular acidosis? Because it is a chronic metabolic acidosis state, so there is an alternation in the growth hormone and IGF axis. Because of the decrease, then there is a decreased 1-alpha hydroxylase activity, which has a detrimental effect on epiphyseal growth rate. So the treatment is generally done with the oral alkali. Either we can give as a bicarb or citrate, which is, if the patient is having proximal RTA, and then in that scenario, so we give the dose about 10 to 20 millimoles per kg in divided doses, and for distal RTA it is 1 to 2 millimole per kg daily dose. So the next case is 8-year-old male with short stature and was having diarrhea and easy fatigability. So the patient's bone age was 3 years. The bone age was below the chronological age, and the weightage was again low. So patient was underweight for the weight. We got all the profile done. His hemoglobin was low, and because the patient was having diarrhea, so we got the tissue IgA TTG done, in which it was positive. So celiac disease was diagnosed to have as a cause of short stature for this patient. Then there is another case in which short stature, patient presented, he was a 15-year-old male with a short stature since 15 years. Again, the biochemical profile shows that the patient was having CKD, which was the main cause for the short stature in this case. So the growth failure in children with CKD is basically because of the poor intake, malnutrition, metabolic acidosis, and because of the alteration in growth hormone IGF excess, and there is a growth hormone resistance at the hepatocyte and the growth plate. So majorly we require the optimal nutrition, correction of acidotic part, anemia, and neonormalization of calcium and phosphate levels. If it's still the patient is not gaining the height, then we can use the growth hormone at the higher dosage. So now the next case is the 9-year-old females, which was again presenting for the short stature. Her TSH was found to be more than 100. So the primary juvenile hypothyroidism was diagnosed. As the patient, here we can clearly see the patient was having, the weight was more. So the patient's weightage was more as compared to the height of the patient. So when the weight is more as compared to the height, then we narrow down the diagnosis. The patient might be having endocrine diseases like hypothyroidism, Cushing, or growth hormone deficiency. So the TSH, when the TFT was done, the TSH was found to be more than 100, and the patient was diagnosed to have juvenile hypothyroidism. So the next case is a 7-year-old male. Again, here we can see the weight was more, the height was less than 3rd centile, and so again, it was an endocrine disorder which the patient was having. So the patient's growth hormone was done, and it was again found with the provocation test also the growth hormone deficiency was diagnosed. So the next case again, which is very common in short stature in the females. So we have to, any short stature female, we do have to rule out the Turner syndrome. For all short stature females, when they are less than 3rd centile, we need to rule out the Turner syndrome. So karyotyping should be done for such patients. And again, in this scenario, the FSH was more, karyotyping was done, and the patient was found to have Turner syndrome. So to summarize, so first, diagnose the patient is having short stature. So we need to exclude the systemic causes, any social causes, or SGA. And then we have to see whether dysmorphism is present or not. And if the patient is having dysmorphism, then check for whether the patient is having short limbs or short trunk. And then if the no dysmorphic features are there, then weightage has to be calculated. If the weightage is more affected, then generally it is malnutrition and chronic diseases. If the height is below the 2-3 standard deviation, or the bone age is more than 2 years of the chronological age, it is generally to have the endocrine diseases. If the patient's height is between 2 to 3rd centile and the bone age is within the chronological age, generally it is the familial or the CTGP. So the line of investigations, we have to get all the routine investigations for such patients. That is the CBC, ESR, RFT, LFT, ABG has to be done, calcium, phosphorus, alkaline phosphatase, IPTH levels has to be done. Then we have to screen for thyroid function tests. Celiac disease has to be ruled out in our area. And if in spite of all this, we are not able to see for the patient for we cannot diagnose for the short stature, then the growth hormone IGF-1 levels should be done. If the patient is having malnutrition, then we can do the IGF BP3 levels, and the karyotyping has to be done in all the girls with unexplained short stature. So take home message, in any short child, we have to calculate C for the height and weight, check for the height velocity, height of the parents to calculate the target height, calculate the mid-parental height, height, age, dysmorphic features, check for the systemic examination, and pubertal development staging should be done, bone age has to be calculated, and appropriate investigations should be done. Thank you so much.
Thank you, Dr. Shweta. Your flowchart is very, very informative.
Thank you, sir.
That gives a ready reckoner how should we proceed.
Thank you, sir.
So I would like you to comment on 2 things. The daily encounter in OPD, the chappals with pimples, that will increase height. People ask, generally we refer them to you, but for the reference of the audience. And second is, what is the effect of hanging on height? Because these 2 factors are really important, and parents are very, very, sensitive and curious, and do these things very regularly for their children.
See, so you also know they are not going to help, but definitely we should advise our kids that they should do exercise properly. They should do, their workout should be there, exercise should be there so that the bones, they are strong. But they do not help in increasing the height. It is basically the genetic potential of the patients that that is going to help their increasing in height. But definitely if the short stature is there, we should not neglect them, because most of the time the parents are very concerned about the height of the kid. They want that nobody should have a short stature. So, but we have to guide them properly that that is not the indication for the growth hormone for every children, because some of the kids, they have familial short stature, and some of them they have the CTGP. So all the kids with short stature, they are not the candidates for growth hormone. Thank you.
Thank you, ma'am, for your insightful presentation. Now I call upon Dr. Rohit Agarwal, Consultant Endocrinologist, Agarwal Healthcare Center, Sadbhavna Hospital and Manipal Hospital, Patiala, to present his topic, Gestational Diabetes Mellitus, an overview.
Thank you, Dr. Rohit, for accepting our invitation.
Thank you, sir.
And
Thank
congratulations on being President-elect for RSSDI Punjab chapter, and your assurance to form the CCDSI Punjab chapter. Thank you very much.
Sir, thank you, sir. It's my privilege and honor to be here in the Bathinda. And sir, thank you inviting me to deliver a talk on really a tough topic of gestational diabetes, because it's a topic of dispute most of the times, because still we are in the period, should we screen all the females? What should we do? Should we treat them? For how long we should follow the MNT therapies? What about the metformin, glyburide? So it's a very big topic, I can say. So the time which was given to me or assigned is just 15 minutes, and I will try to put all those things in those 15 minutes. Thank you. And आगे कहाँ से करना बेटा? This. Okay, so the incidence of gestational diabetes is rising, and why it is rising? This is because of the parallel rise in the prevalence of diabetes per se. So during pregnancy, the maternal hyperglycemia must be avoided by all the means. By all means does not mean that you start doing other things which are not being like approved. By all means proper nutrition, physical activity, and the drugs, and mainly the insulins. Aside from the short-term maternal, fetal and neonatal consequences which are associated with the GDM, long-term consequences for both mother and child are there. Now we have got two trials by the name of MITI trial and MIG TOFU trial also. So they followed the children till 9 years, and they have found that those children in like mothers, when they were not fully controlled with the diabetes, and even those children who were put on metformin, mothers put on metformin, the children were slightly obese at that age of 9 years. So pharmacotherapy of GDM for tight glycemic control is needed to reduce the adverse events in the fetus also. So this is how we usually classify. I think the slide is not very much clear. It is the hyperglycemia in pregnancy, which usually dividing into the two parts. That is a pre-existing. If it is already there, that could be the type 1 diabetes, type 2 diabetes, or other variety of diabetes. If it is first time detected during the pregnancy, then it could be either overt diabetes or gestational diabetes mellitus. And all those things we label under one category of DIP, that is diabetes in pregnancy. Now we divided gestational diabetes into two parts, early GDM and the late GDM. Early GDM if it is occurring in less than 20 weeks of pregnancy, late GDM if it is occurring after 20 weeks of the pregnancy. So now in 2019 IDF they say 1 in 6 live births whole of the world, and in Southeast Asian countries 1 in 4 live births, they are being that is a cause for hyperglycemia in the pregnancy. And total 70 to 80 or 80 to 90% of diabetes in pregnancies is because of the GDM per se. So this is what are the metabolic changes which happen during the pregnancy. We know that there is an insulin resistance, and this is going to increase over the period of time. After 20 weeks, there is an exponential rise in the insulin resistance because of increase in the secretion of placental hormones, mainly the HPL, HGH, leptin, prolactin and cortisol. But all the females, they don't become diabetic. So diabetes happens only once the beta cells starts failing and they produce lesser of insulin. because of the excess fuel supply which they are getting. That is the reason once the insulin start decreasing after 24 weeks of the pregnancy, the sugar start increasing and the lady become diabetic. So there is a decreased insulin production which is very common, and this usually happens after 20 or 24 weeks of the pregnancy, and that is the reason 24 weeks of the pregnancy is the ideal time, they say, to be screened for all the females to look for the diabetes. So if you took for the all the things in the parameter, whether they are genetic, whether they are environmental, whether they are using ethnicity or histories, obesity or gene polymorphism, the major thing is the etiology of gestational diabetes is because of the beta cell dysfunction, insulin resistance, neurohormonal dysfunctions, increased secretion of leptins, pro-inflammatory cytokines, as well as the oxidative stress. Now, why should we worry? It is not only that the physician should worry, we should worry not only for the mother, we should worry for the fetus also. Not here, it goes up to the newborns also, and if you follow the newborn till the adolescent or the childhood adult, so we should follow these kids, and that is the reason even the child or adult, if their mother is not controlled, well controlled with the diabetes, chances of obesity, type 2 diabetes and the non-communicable disease in the form of cardiovascular diseases, wheezing, arthritis, attention deficient disorders has been seen in a older age group also. So mother, we know that there is like mother chances of preeclampsia, hypertension, preterm labor, DKA, worsening of microvascular diseases, mainly your retinopathy, it happens, and there is a future risk of cardiovascular disease, and this risk is proportionate to the degree of hyperglycemia. And for the newborns, always rule out hypoglycemia after the birth, hypocalcemia, hypermagnesemia, polycythemia, preterm labor, or the respiratory distress syndrome which happens. Now a recent concept is that of the transgenerational concerns. What do you mean by the transgenerational concerns is, if the hyperglycemia happens at that time when the fetus organs are being maturing or they are being formed, it leads to the permanent change in their structure, physiology and the metabolism. So that is being responsible for development of non-communicable diseases later in the life. So हमारा काम तब नहीं शुरू होता जब बच्चे को बीमारी हो, हमारा काम तब शुरू होता है if the mother is having sugars, we have to control those sugars very well from the day one, rather than saying कि 15 दिन बाद आना या 20 दिन बाद आना, we will see to it. Now again a paper given by my colleague Dr. Gagan and Dr. Sanjay. So they say preconception optimization is very essential, and they have found that if the HbA1c increases right above 6, not 6.5 even, which is a goal, if it goes below 6, above 6, the chances of developing complications, they are on the higher side. So preconception, you have to optimize your sugars level, control of sugars, weight, blood pressure, start insulin. Even before you think of like you are going for a family way, discontinue all the teratogenic drugs. You can start with a folic acid, and you should screen for all the complications. So higher the periconception HbA1c, greater is the risk for the fetal anomalies. Now the main question is when to screen, who to screen, and how to screen. So this is again a big question mark, because there are different societies. There is ADA, there is ACOG, there is a FOXI, our ESI, RSSDI, DIPSI. They have, every society has given their own, say, guidelines ki how to screen and what to screen, and still it is slightly confusing. Indians, we follow the DIPSI guidelines which are updated in 2023. So when to screen? First, antenatal visit for pre-existing diabetes, or if we are suspecting early gestational diabetes. Otherwise 24 to 28 weeks or earlier if the risk is high for the gestational diabetes. Now to whom we should screen, whether it should be a universal screening or a high risk screening. If we talk about the high risk, this is usually age above 35 years. If the female is obese, overweight, past history of PCOS, family history, history of IGT, GDM or macrosomia, excess gain of weight during pregnancy, poor ops history, medications, or belongs to the high risk ethnic group. Now the question is, only these females we should screen early or we should screen all? Again, it's a big question. Universal screening, there is no clear cut guidelines on the universal screening also. Now how to screen? So should we go for a single step or should we go for a two-step? Initially we used to say first you do the GCT. If the GCT is abnormal, then you can go for the OGTT with the 75 gram of the glucose. So there are so HbA1c, which we usually don't do much during pregnancy. There are the limitations because of the high RBC turnover. Now different societies have given the different guidelines. The Western societies are following this IADSP guidelines. They say screen during the first trimester. Diagnosis is overt diabetes if the fasting plasma glucose is more than 126, 2-hour plasma glucose more than 200. If random plasma glucose 200 plus symptoms and the HbA1c is more than 6.5. But if fasting is less than 92, then you screen at 24 to 28 weeks with 75 gram of glucose. If fasting is between 92 or 125 or HbA1c lies between 5.7 to 6.4, then it fits into the category of gestational diabetes. Then you can screen right away with the 75 gram of glucose. But this seems to be a little, you say, cumbersome process. The DIPSI has come out with the very beautiful one line that all GDM can be diagnosed if 2-hour post-glucose plasma glucose is more than 140 with 75 gram of oral glucose to be dissolved in 300 ml of water given to a lady irrespective of the fasting or the non-fasting state. ये बहुत इंपॉर्टेंट है. आप दिन में कभी भी any female come to your OPD clinic, you can do this what we say the GCT or the glucose tolerance test. Simple, you give 75 gram of the glucose, एक ही sample लेना है after 2 hours. If the 2-hour value of the plasma glucose is more than 140, then you label that lady is suffering from GTT. And they have, DIPSI has given the two glucometers. One is with the Accujack glucometer Performa and one is the Roche, one is the active glucometer, because they are being calibrated to check the plasma glucose. Number one. Number two, the question is, क्योंकि वो बड़ा thick हो जाता है, like 75 gram of glucose. If the lady vomits out, what to do? If the vomitings happens after 30 minutes of intake, मान लो उसने 11 बजे लिया, पौने 12 बजे उसको vomiting आ गई, continue with the test. No need. If the vomiting happens within the 30 minutes after intake of the glucose, then abandon the test and repeat the test very next day. This is how we usually proceed. So DIPSI has given ideal screening times for the GDM. They say first screening to be done as early as on the first antenatal checkup visit for a checkup, if it has not been done preconceptionally. Second screening at 24 to 28 weeks and third screening in 32 to 34 weeks. हमें बार-बार screening करने की ज़रूरत क्यों है? इसी करके है, because to avoid the fetal glucose steal phenomena. So advantages of DIPSI: it is being simple procedure, easy to execute and implement, cost effective, and it reduces your perinatal morbidity and mortality also. This is about the HbA1c. I am not going into detail because of the shortage of the time. They say if A1c is high, chances are large for gestational age, preterm birth and neonatal ICUs are on the higher side. These are the simple 3 case scenarios. A 27-year-old lady with 26 weeks of gestation, 75 gram of OGTT, 97, 185, 169, diagnosis is GDM. 32-year lady, first antenatal visit, 14 weeks, fasting is 114, HbA1c is 6.1, it is early GDM. 33-year lady with 75 gram of glucose, fasting 115, 1 hour 231, 207, it is a case of overt diabetes. This is how we label the patient and then we can treat accordingly. So prompt detection and treatment, it improves your everything. It decreases your preeclampsia, reduces your rate of shoulder dystocia, reduces the birth weight, macrosomic risk, and reduces your birth defects also. So management is by MNT, that is medical nutritional therapy, insulins, and with the OADs, again big question mark. And our target is keep your fasting less than 95, 2 hour post meal, whether it's breakfast, lunch or dinner, to be less than 120. Simple. Then there is a role of CGMS also in pregnancy to decrease lower A1C and to decrease the chances of the hypoglycemia. And I'm just going to the target. Target is 63 to 140, which we have to keep in that range rather than 70 to 180, which we usually do in our non-pregnant or in a type 2 diabetic patients. So glycemic control is most important. You can check 7-point scale, that is 3 times pre-meals and post-meals. Check your blood pressure, thyroid functions, look for urinary ACR, fundus and ultrasounds for malabsorption. MNT, which very important, approximately 50% of your calories come from carbs. They say 175 grams. 71 grams close to proteins and 28 grams of fats, less of, 28 grams of fibers, and among the fats you take monounsaturated or polyunsaturated rather than the saturated fats. So do not eat for 2. Remember one thing, do physical activities 10 to 15 minutes after every meal, which is most important. And there are papers and papers on the physical activities in diabetes. And when to consider pharmacotherapy, 90% of GDM patients are able to achieve targets with your lifestyle modification. Otherwise, you start with the insulin therapy. So this is the guidelines. When you start insulin, if the fasting is more than 126 and 2 hour post meal is more than 200 along with the MNT. So insulin, we know that basal bolus is the main, where we give 3 shots of bolus insulin before every meal and 1 shot of basal insulin at the bedtime. And these are the, usually I think most of the people we know how to give and how to check your sugars accordingly. Counseling, I think if you counsel, if you educate your patient well, you will be able to take care each and every aspect of the gestational diabetes. No role of glyburide much, because of main concern is neonatal hypoglycemia, macrosemia and higher birth weight. A word about metformin. Lot of papers are there. Some papers they say safe, some papers they say not safe. But our guidelines say if you want to give metformin after 20 weeks of pregnancy, not before 20 weeks of pregnancy. If lady is having PCOS already on metformin, you can continue with the metformin in that case. But metformin is not going to help you in decreasing the chances of miscarriages, number 1. But there are papers, this is a recent paper which was published in 2024. They say if you have given even metformin along with the insulin, the chances of congenital malformation are slightly on the higher side. So we have to be little safe while prescribing the metformin in all your pregnant females. If you want to give because of so many reasons, then give after 20 weeks of the therapy. And why it causes increased risk is there, because metformin causes decreased vitamin B12 and folic acid level. There is a transplacental exposure to metformin. It will be uptake will be there by the placental. It will impair your mitochondrial respiration, which will decrease your nutrient uptake. It will impair the 1-carbon metabolism, which causes decrease in the gene methylation, and all these things causes defect in the fetal programming. And वो बच्चे who are जिनकी मदर metformin ले रही थी, they were little small for gestational age rather than they are macrosomic. And ये जो small for gestational age हैं, if you nurse them, they will be more obese at 9 years of the follow-up. So I think this is fetal monitoring label, and more monitoring is being required, and this is after immediate postpartum. The for GDM, number 1, testing is recommended thrice. First antenatal visit before 12 weeks, 24 to 28 weeks and 30 to 34 weeks. Single test procedure with 75 gram of glucose to be done. Pregnant female tested positive more than 40 should be started MNT only for 2 weeks. If 2-hour PPG more than 120 after MNT and physical exercise, medical management in the form of insulin or metformin is to be started as per guidelines, and pregnant women are to be monitored by 2-hour postprandial glucose throughout pregnancy as per high-risk pregnancy protocols. Pregnant females with GDM on insulin therapy with uncontrolled blood glucose more than 120 usually requires close to 20 units. If they require more, then it is better to shift to the higher institute. Delivery to be done close to 39 weeks, never before 37 weeks because their lungs are not so much matured. Vaginal delivery is preferred except if there is a fetal macrosomia. Neonatal monitoring of hypoglycemia and other complication is very important. जब भी कोई बच्चा पैदा हो, sugar should be checked within 1 hour after the birth and regularly after 4 hours. If the 4 readings are normal, last 4 readings, if their sugars are more than 45 milligram, then we say this child is not hypoglycemic right now. Thank you for the patience hearing, and thank you taking little extra time because the chapter is so big and I tried my best to cover the DIPSI guidelines in those 15 minutes.
Thank you very much, but that exceeding of temperature, the time is worthwhile because diabetes in pregnancy is coming up as a root cause of all non-communicable diseases, being stressed on maternal health for prevention of most of the non-communicable diseases. So this is really important, and I was honored to be one of the framers of DIPSI guidelines in 2006. When first guidelines, I think, are most appropriate in Indian setup. And now the concept is being forwarded as 4th trimester. So that there is no gap between the maternal health before pregnancy and after pregnancy in gestational diabetes.
Sir, और जो ये DIPSI guidelines which was revised in 2023 has been taken by the NICE guidelines.
Yes.
NICE people, like UK people, उन्होंने इसको advocate किया, and the NICE are also following the DIPSI guidelines.
Yes. So thank you very much.
Sir. Thank you,
we
sir.
Should stress on pre-marriage and preconceptual counseling as, a primordial prevention to all non-communicable diseases.
Thank you,
Thank
sir.
you very much
Thank you, sir.
for enlightening talk.
Thank you, sir. Thank you.
Thank you, sir, for your wonderful presentation. Now, I would like to invite our next presenter, Dr. Arpit Garg, MD, DNB Endocrinology, Consultant Endocrinologist at Amar Hospital, Patiala, to throw a light on the topic management of hyperthyroidism.
Good afternoon, everyone. And first of all, I would like to thank Professor Vitul Gupta and other organizing members of MAPICON for inviting me on this esteemed platform. I'll be talking about management of hyperthyroidism. We all know that it's a very vast topic and very common also. We get a lot of patients with abnormal thyroid function tests. Sometimes we don't know that what drug should we give now and what dose should we give. So I'll be discussing only about the difficulties which we usually face in our OPDs. So these will be the outline of my topic. First of all, approach, diagnosis, treatment, and finally the monitoring. So whenever we receive any patient in our OPD, the patient basically presents with features of thyrotoxicosis. The clinical features may be like tremors, palpitations, weight loss, hyperdefecation. So thyrotoxicosis has two main causes. One is the hyperfunctioning of the thyroid gland, which is called as hyperthyroidism. Secondly, the gland is normal, but there is thyroid hormone excess in the body. This is thyrotoxicosis without hyperthyroidism. So we have to divide whether it is a hyperthyroidism, a thyroid hormone excess due to other causes. Amongst hyperthyroidism, Graves' disease is the most common cause, accounting for 70 to 80% of the cases. And rest are toxic multinodular goiter, toxic adenoma, and other rare causes like struma ovariae. I'm not going to discuss all those things. And if we see the thyroid hormone excess not due to hyperthyroidism, it is thyroiditis and factitious thyrotoxicosis. Factitious thyrotoxicosis is the condition in which patient takes excess of levothyroxine, and thyroiditis is the main cause of thyrotoxicosis other than hyperthyroidism. Out of thyroiditis, subacute thyroiditis is very common, and it is usually preceded by viral infection, especially very common nowadays in this season, rainy season, because most of the people, they are having viral illness, and followed by viral illness, a lot of patients develop thyrotoxicosis, which is usually subacute thyroiditis. Other causes are infectious thyroiditis, radiation induced, or other forms like silent, postpartum, drug induced, or chronic lymphocytic thyroiditis. So how to differentiate between these two things, whether it is hyperthyroidism or thyrotoxicosis due to thyroiditis? So I am focusing only on the Graves' disease because it is the most common cause of hyperthyroidism. First of all, there will be clinical features of thyrotoxicosis like weight loss, tremors, hyperdefecation, excessive sweating. Then there will be goiter, which will be of significant size. It will be diffuse, soft, and if you auscultate, bruit may be audible in certain cases. There will be long-standing history of months, and patient may present directly with complications like ophthalmopathy or orbitopathy, we call as dermopathy and acropathy. These are the three typical complications of Graves' disease mediated by autoimmune phenomena. In the pictures I've shown here, the orbitopathy, the acropathy is the clubbing, and dermopathy is the skin condition. And if cardiac involvement is there, this is also typical of Graves' disease. If any of these complications are present, then you don't need any further test to differentiate between these two conditions. It will be obviously Graves' disease. If in case of thyroiditis, the patients usually present with features of thyrotoxicosis. Along with that, the goiter may be there. It is usually small, painful and tender. Patients usually come with pain in the neck radiating to the supraclavicular area or on the back of the neck also. There may be associated lymphadenopathy. The history is usually short, of days or months, maximum 1 to 2 months, and seasonal incidence is there. This disease of subacute thyroiditis is mainly in India, especially in North India. It is encountered especially in relatively 2 parts of the year. One is this season, in the rainy season, and second in the Jan to March, in the winters when the patients usually suffer from viral illnesses. And typically there will be absence of complications. So then we come to the investigations part. If we want to differentiate Graves' disease from toxic adenoma and thyroiditis, first of all, TSH, it will be low in all the 3 conditions because all are thyrotoxic, but in thyroiditis, TSH is slightly low. The striking thing here is the free T3 and T4. Free T3 will be elevated very too much in case of hyperthyroidism, whereas in thyroiditis, free T4 is markedly elevated. This is because in hyperthyroidism, the gland is hyperfunctioning. It is producing more of free T3. Whereas in thyroiditis, there is inflammation and destruction of the gland. So free T4 is higher in case of thyroiditis. Third typical marker of thyroiditis is ESR. ESR is very high in case of thyroiditis, whereas it's normal in Graves and toxic adenoma. And it is a typical exam question of also that what are the main causes of markedly high ESR. ESR may be more than 100 also in case of thyroiditis. Liver enzymes, they can be elevated in all the conditions. And the diagnostic, or you can say the gold standard investigation for differentiating these conditions, is the TSH receptor antibody. TSH receptor antibodies, these are elevated in Graves' disease, but these are normal, or you can say absent in toxic adenoma and thyroiditis. So this is the gold standard test for diagnosis of Graves' disease, biochemical test. Second test for differentiating these conditions is the technetium scan or the radioactive iodine uptake scan. Nowadays, this scan is done is available at all the nuclear medicine centers. I've seen all the conditions here. In Graves' disease, you can see that both the lobes are taking the uptake. These are diffusely toxic, and background uptake is very less. You can't see anything in the background because all the technetium or the radioactive iodine is taken up by the thyroid gland. Then we see the thyroiditis. In this, there is inflammation of the gland. There is ongoing destruction of the gland. So gland is not taking up any radioactive iodine or technetium, and that's why the uptake is seen in the peripheral tissues. No uptake is there in the thyroid gland. So 0% uptake is there. In adenoma, you can see the focal uptake in the lower pole, in the lower pole of the left lobe of the thyroid. So it is left inferior thyroid adenoma. And toxic MNG, you can see multiple points of uptake. So these are the typical pictures of the technetium scan in the different thyroid conditions. Coming to the treatment part. So hyperthyroidism or Graves' disease, the treatment discussion is very vast, but I'm going to just focus on the basic treatment. First and foremost is the symptomatic treatment for the patient, because the patient has come to us for the symptoms, that is weight loss, anxiety, palpitations. For this, beta blockers are the first line, and amongst that propranolol is the first line, which can be given in 10 to 40 milligrams dose 3 to 4 times a day. Ideally, short-acting propranolol should be given, but if short-acting is not available, you can give long-acting also. Other beta blockers like atenolol, metoprolol, nadolol, or esmolol can also be given. And second is the antithyroid treatment, which comprises of antithyroid drugs, radioactive iodine ablation, and thyroidectomy or surgery. We know that there are 3 antithyroid drugs with us: propylthiouracil, methimazole, and carbimazole. Now the important thing here to remember is the dose at initiation. I have seen a lot of times in my OPD that patient comes with very high levels of T3, T4 and undetectable TSH and started on neomercazole 10 mg once a day. So that is not a correct treatment. We have to start proper doses. So the dose of methimazole at initiation is defined by the free T3 levels. If free T3 is 1 to 1.5 times, then start with 5 to 10 milligrams methimazole per day. If free T3 levels are 1.5 to 2 times, start with 10 to 20 milligrams per day. And if free T3 levels are 2 to 3 times, then start with 30 to 40 milligrams of methimazole per day. So this is the dose of initiation. Further doses are determined based on the T3 levels. Then coming to the equivalent doses. This is again a very important concern in most of the doctors' mind, that if we want to shift the patient from methimazole to carbimazole or from methimazole to propylthiouracil, because propylthiouracil is recommended in pregnancy. So we have to know these numbers. Methimazole 6 milligrams is equivalent to 10 milligrams of carbimazole. And methimazole 1 milligram is equivalent to 20 milligrams of propylthiouracil. And we have to give antithyroid drugs for at least 12 to 18 months for Graves' disease in adults. Minimum 18 months of treatment is recommended. After that, you can think of tapering down the drugs and taking the patient off the treatment. Coming to the adverse drug reactions, these are divided into 2 parts, minor and major. Minor are like rash, pruritus and arthralgias. We usually give symptomatic treatment like antihistaminics for this, but we may have to stop if the patient is not tolerating at all. Major side effects like agranulocytosis, vasculitis and hepatotoxicity. If any of this major side effect occurs, then you have to immediately stop the antithyroid drug, and the drug can never be restarted. You have to go for other option like radioactive iodine or surgery in those cases. So clinical situations that favor a particular modality for Graves' hyperthyroidism. Basically in Graves' hyperthyroidism, you can go with either radioactive iodine or antithyroid drug. Surgery is indicated only in certain conditions like malignancy, compressive symptoms or hyperparathyroidism is there. Except pregnancy, where you cannot give radioactive iodine. In pregnancy, you have to give only antithyroid drugs. In case of toxic multinodular goiter or toxic adenoma, again, you can go with either radioactive iodine or antithyroid drug, but usually radioactive iodine carries a better response. So to summarize, for the choice of therapy in Graves' disease, both are okay. You can give either with the antithyroid drug or the radioactive iodine, and thyroidectomy is done only in selected cases. So the basic indications of surgery in hyperthyroidism is: one is malignancy, second is compressive features due to goiter, cosmetic concern, retrosternal extension of goiter, and concomitant hyperparathyroidism. If any of these conditions are there, then you should go with the surgery. In case of toxic adenoma, radioactive iodine carries an excellent response, and in toxic multinodular goiter, you should give antithyroid drugs, but it has to be lifelong therapy, or total thyroidectomy is usually considered, because toxic MNG patients, they usually have large goiters, and if some cosmetic concern is there, then surgery is usually considered. So coming to the last part, that is monitoring of therapy. Whenever you start antithyroid drugs, you have to monitor for the ADRs at each visit. Titrate the dose on basis of free T3 levels initially, followed by TSH, once free T3 and T4 are normalized. So this is again a second thing which we usually do wrong in our practice, is that in hyperthyroidism, we have to follow free T3 levels, not the TSH ones. Initially, you have to follow free T3, and later on TSH can be monitored. TSH may take up to 6 months to normalize, and monitor TSH receptor antibody levels 4 to 6 monthly after 12 to 18 months of treatment. And when the TSH receptor antibodies become undetectable, you can stop the treatment. In case of radioactive iodine ablation, we have to know one thing, that don't stop antithyroid drugs immediately after radioactive iodine therapy, because it will take some time to act. We have to monitor TSH, T3, T4 every 6 weekly for 6 months, or until the patient is hypothyroid and stable on levothyroxine replacement. After surgery, you have to start levothyroxine 1.6 microgram per kg immediately after the surgery, and monitor thyroid function tests after 6 weeks. And no need to start levothyroxine after partial thyroidectomy. This is also common practice which I see, that patients are done hemithyroidectomy and they are started on levothyroxine. There is no role of starting prophylactic levothyroxine in such patients. You have to just monitor your thyroid profile. Coming to the management of subacute thyroiditis, the main line of treatment is the symptomatic, that is NSAIDs are given. You can give indomethacin, ibuprofen, because you need potent NSAIDs for the control of pain, and beta blockers for symptomatic treatment. Nothing else is needed. But if this pain is very severe, or the patient is developing fever, or the patient is markedly symptomatic, you can give corticosteroids. If you want to start steroids, give prednisolone 40 mg once a day for 1 to 2 weeks, and then you can taper over 2 to 4 weeks depending on the clinical response. There is no role of antibiotics or antivirals in the management of subacute thyroiditis, and we have to monitor thyroid function test after 1 month. So that's all about the management of hyperthyroidism. So first of all, you have to differentiate whether it is Graves' disease or any other, or it is thyroiditis. If it is Graves' disease, you can go with the antithyroid drug or radioactive iodine ablation. If it is thyroiditis, just symptomatic treatment along with beta blockers is needed. But if patient is markedly symptomatic, you can give corticosteroids. Thank you. Thanks a lot for the patient hearing.
Thank you very much. Really very well summarized in, a big topic in small, and that to be understanding for all the people. Thank you very much, Dr. Arpit. This is really important problem. Thank you very much.
Thank you, sir.
Thank you, sir, for your fantastic presentation. Now it's time for our next speaker. I would like to invite Dr. Saurabh Arora, DM Endocrinology, Consultant Endocrinologist, Fortis Hospital, Ludhiana, to present his topic on hypercalcemia, diagnosis and management.
A very good afternoon to all. First of all, I would like to thank MAPICON faculty and especially Dr. Vitul for giving me this opportunity to speak on this platform. So for the next few minutes, I'll be speaking regarding the diagnosis and management of hypercalcemia. As we know, hypercalcemia per se is not a disease. It's rather a manifestation of underlying disorder. So a prompt diagnosis and management of that disorder is very crucial so as to prevent the end organ damage, because untreated hypercalcemia can lead on to acute kidney injury. It can also cause cardiac arrhythmias, which can be fatal sometimes, or it can have neurological implications. Can I have my slides, please? Not even. Oh, I think. Can you please? Slides, मेरी नहीं है ये. So hypercalcemia is defined as level of calcium that is above 10.5 milligram per deciliter. Normal concentration of total calcium is 8.5 to 10.5. So coming on to the etiology of hypercalcemia, etiology is broadly divided into two categories. One is PTH dependent, another one is PTH independent. So in the PTH dependent category, there is excessive autonomous secretion of PTH. And the most common cause of PTH dependent hypercalcemia is primary hyperparathyroidism. And then tertiary hyperparathyroidism, FHH, and lithium therapy can also lead to PTH-dependent hypercalcemia. Now coming on to PTH-independent hypercalcemia. It occurs due to malignancy, granulomatous disorders, multiple myeloma, and it can occur as a part of vitamin D intoxication, and certain medications can also lead to hypercalcemia. I'll be discussing this in detail. So the first step in the evaluation of patient with hypercalcemia is to confirm whether the patient is really having hypercalcemia or not. So we have to check the corrected calcium levels or ionized calcium level to confirm whether the patient is really having hypercalcemia or not. And the next step, which is most important step in the evaluation of hypercalcemia, is to do PTH level. I have seen many times in our institute also, when a patient comes with hypercalcemia, residents write a battery of tests, including PTH, serum protein electrophoresis, ACE levels, CT chest, CT abdomen, maybe for looking for malignancy. But the first and foremost step is PTH, because this can avoid many unnecessary investigations. So after doing PTH, if PTH level is elevated or even normal, because a level of 20 is taken as cutoff. If PTH is above 20, it means that hypercalcemia is PTH dependent. Because in patient who is having PTH independent hypercalcemia due to any cause maybe, we expect PTH levels to become undetectable as a normal response of the body. So if the PTH level is above 20, even if it is in the normal range, it is PTH dependent hypercalcemia. And the most common cause of hypercalcemia overall is primary hyperparathyroidism and malignancy related hypercalcemia. So in this category, it is primary hyperparathyroidism which is most common. Again, coming to tertiary hyperthyroidism, we have to check creatinine levels. If the creatinine levels are normal, patient does not have CKD, tertiary hyperpara is out. So then again, it remains primary hyperpara. Third, which is the rare cause, familial hypocalciuric hypercalcemia. In patient who is having hypercalcemia due to any cause, we expect 24 hours urinary calcium to be high. But in this scenario, 24 hours urinary calcium is low. So by doing 24 hours urinary calcium, we can get an idea. But if a patient is having PTH dependent hypercalcemia, more than 95% patient will be having primary hyperparathyroidism. So we should focus on this etiology and to diagnose primary hyperparathyroidism. And more precisely to localize where parathyroid adenoma is, we have to do a battery of tests, which include ultrasound is considered as the initial best test for the evaluation. Ultrasound neck has got 60 to 80% sensitivity. Then technetium system UV scan, which has got sensitivity of up to 85 to 90%. If we are not able to localize adenoma with ultrasound and even technetium system UV scan, which is a common scenario, sometimes happen in clinical practice, that we have a patient with hypercalcemia, PTH is elevated, ultrasound is normal, technetium system UV scan does not show any adenoma. Then the next best investigation is to go for PET choline scan, which is not available widely. In our region, it is only available at PGI Chandigarh. I don't know whether it is available in AIIMS Bathinda or not, but in Ludhiana, it's not available. So, but with this test, we can diagnose primary or we can localize the adenoma in up to 95% of patient. And this test has got a specificity of 80 to 100%. And again, 24 hours urinary calcium creatinine ratio when we are suspecting FHH. But in familial hypercalciuric hypercalcemia, the calcium level will be mildly raised up to 11 or 11.5. And patient will have a history of long-standing hypercalcemia. If you have calcium level of 13 or 14, FHH is out. It's primary hyperparathyroidism. We need not to go for 24 hours urinary calcium creatinine ratio even. And again, the second scenario when PTH is not elevated or PTH is undetectable. That is PTH is less than 20 picogram per ml. Then we have to perform certain tests to get into the etiology, and 25 hydroxy vitamin D levels are elevated in vitamin D intoxication. So the best is to go for 25 hydroxy vitamin D, a chest X-ray, ACE levels as an initial investigation in these cases. If ACE is elevated, we will think of sarcoidosis. 125 dihydroxy vitamin D levels, we don't routinely do, but in certain scenarios where we are not able to exactly diagnose the condition, we can take the help of this test. This is elevated in sarcoidosis, lymphoma, and tuberculosis. In patients who are having granulomatous disease, there is activation of 1-alpha hydroxylase enzyme, which results in increased levels of 125 dihydroxy vitamin D. Again, there is a scenario when there is normal vitamin D levels and PTH-RP levels. Then you can evaluate for multiple myeloma. Milk-Alkali syndrome remains the cause. But among patients who have PTH-independent hypercalcemia, CT chest, CT abdomen, and a PET scan is done to evaluate for hypercalcemia of malignancy. Given an option between PTH-RP and a PET scan, I would choose a PET scan because PTH-RP is a very costly test, and a PET scan is very good to diagnose any occult malignancy which is resulting into hypercalcemia. So if PET scan is negative, despite doing all investigations, CT chest, CT abdomen, PET scan, we are not able to localize where is the etiology of hypercalcemia, then we can go for PTH-RP levels. Otherwise, in routine clinical practice, we don't normally do it. So there are certain subtle clues to the etiology of hypercalcemia which can guide us in ordering an investigation or avoiding some unnecessary investigations. So presence of long-standing asymptomatic hypercalcemia is more common with primary hyperpara and FHH, familial hypocalciuric hypercalcemia. FHH is a very rare condition. Chances of primary hyperpara are more likely. But if a patient has mild hypercalcemia and patient gives you history of hypercalcemia in first decade, Suppose a 30 years old male comes to us and the parents give that when the patient was 5 or 6 years old, he was also having hypercalcemia at that time, diagnosed slight hypercalcemia. So it is FHH. It is not primary hyperparathyroidism, because FHH patients can have hypercalcemia during first decade of life. Again, hilar lymphadenopathy, uveitis, elevated ACE levels, or elevated 125 dihydroxyvitamin D levels point towards the diagnosis of sarcoidosis. High ESR, anemia with renal failure, and lytic lesions on chest X-ray do point towards multiple myeloma. A patient who has hypercalcemia with suppressed PTH level, elevated 125 dihydroxy levels, lymphadenopathy or mass lesions, or weight loss, elevated LDH with hyperuricemia, we have to keep the possibility of lymphoma, because lymphomas can present with hypercalcemia. And hypercalcemia with suppressed PTH levels, elevated PTH-RP, weight loss, bone pain, evidence of metastasis, it's hypercalcemia of malignancy. And again, another scenario where hypercalcemia is there, but PTH is suppressed, normal 125 dihydroxyvitamin D levels, but there is history of excessive intake of vitamin D injections. So it is vitamin D intoxication. And another rare entity which is characterized by alkalosis, renal failure, and hypercalcemia with a history of recent ingestion of calcium and alkali supplements. This is milk alkali syndrome. Not seen commonly nowadays, but 2 to 3 decades before it was quite common. So I'll take you through various real case scenarios which we have encountered in our hospital. First case scenarios of a 52-year-old male who presented with pain abdomen for 2 days, sudden in onset, associated with multiple episodes of vomiting. Vitals were normal, examination normal, except for mild tenderness in the epigastric region. On investigation, amylase lipase levels were elevated. Corrected calcium was 11.5, PTH was 50. And it was within normal range. Seeing these levels, we made the diagnosis of primary hyperparathyroidism presenting as acute pancreatitis. It's an uncommon manifestation of primary hyperparathyroidism. And the resident asked me a question, why we made the diagnosis of primary hyperparathyroidism despite normal PTH level. So the answer is clear: when PTH level is more than 20, because in any patient with hypercalcemia, we expect PTH level to be undetectable if it is PTH independent. So the level was within normal range, but it was inappropriate for calcium level. So the diagnosis was primary hyperparathyroidism with acute pancreatitis. Ultrasound neck did not show any adenoma. Technetium sestemi scan showed right inferior parathyroid adenoma, because sensitivity of technetium sestemi is more as compared to ultrasound neck. So this is the picture, and the arrow is showing right inferior parathyroid adenoma. Patient was given IV fluids and calcitonin. The protocol for giving IV fluid is 200 to 300 ml per hour for the first 24 hours. And we try to give 3 to 4 liters of fluid in the initial 24 hours if the patient is not having any evidence of fluid overload. Then, but calcium levels did not normalize. So patient was given zoledronic acid 4 mg and calcium level normalized on 3rd day of injection. After zoledronic acid, it takes 2 to 5 days to normalize calcium level with zoledronic acid. It does not act immediately, whereas calcitonin acts immediately, but it's not a very potent agent. So endoscopic left inferior parathyroidectomy was done after 4 weeks. After resolution of acute pancreatitis, intraoperative PTH levels dropped down. Postoperative day 2 patient developed hypocalcemia, given calcium gluconate, normalized in 3 to 4 days. So primary hyperparathyroidism masquerading as acute pancreatitis is an uncommon manifestation in Western world, but here in our country we do see it commonly. And this is a case series from our institute where we took the data of 30 patients who had acute pancreatitis with primary hyperparathyroidism and compared them with those who had primary hyperparathyroidism but did not have acute pancreatitis. The results showed that patient with PTH, primary hyperparathyroidism associated pancreatitis, has male preponderance, whereas primary hyperparathyroidism has female preponderance. They were having higher calcium levels and lower frequency of skeletal involvement as compared to those without pancreatitis. And presence of nephrolithiasis was associated with severe attack of acute pancreatitis in these patients. A second scenario presented similarly with pain abdomen, vomiting. Examination was almost normal. Again, we did the investigations. PTH was low. It was 4.78, less than 20. It means it was PTH independent hypercalcemia. vitamin D levels were elevated more than 174. If vitamin D levels are more than 150, it is considered vitamin D intoxication. And creatinine level was 3.1. So the diagnosis of vitamin D toxicity with hypercalcemia with acute pancreatitis. All other causes of pancreatitis were ruled out. In this patient, we published this case report also because it's a very uncommon manifestation of vitamin D intoxication. And in this patient, we gave IV fluids and calcitonin. The drug of choice for vitamin D intoxication is steroids. 30 to 40 milligram of prednisolone is given generally for 2 to 3 weeks. But in this patient was having acute pancreatitis. So steroids were relatively contraindicated, not absolutely. It is gray area whether to give steroids in such cases or not. But in this patient, we gave denosumab to be on the safer side. And because zoledronic acid could not be administered due to EGFR was less than 35. So denosumab 60 milligram subcutaneous was given and calcium level was normalized on the 4th day in this patient. And the third case scenario, it's of a 65-year-old woman brought to the emergency department with irrelevant talk and drowsiness for 5 days. History of backache was present for 1 month and general physical examination and neurological examination was essentially within normal limits. Investigation showed creatinine levels of 3.9, calcium of 16.1 and alkaline phosphatase of 550. PTH was less than 20. It was 7. So it was PTH independent hypercalcemia. Detailed examination revealed small lump in the left inferior quadrant of the breast. So possibility of malignancy associated hypercalcemia was kept. FNAC from the breast lump was suggestive of breast carcinoma. MRI spine showed thoracic vertebral metastasis. So the diagnosis of breast carcinoma with thoracic vertebral metastasis with hypercalcemia was kept. IV fluids, calcitonin were initiated, but calcium remained very high. So denosumab 120 mg was given in this patient. For malignancy associated hypercalcemia with skeletal metastasis, we do not give 60 mg dose, we give 120 mg dose because 120 mg of denosumab has been shown to prevent skeletal related adverse events in patients with skeletal metastasis. Patient developed bradycardia and AV block next day. The effect of denosumab or zoledronic acid comes after 2 to 3 days. But in this patient, on second day, patient was having hypercalcemia and was having arrhythmia. So urgent hemodialysis was done using low calcium dialysate. This is another modality which is done in emergency situation and the calcium level normalized with this. So denosumab inhibits bone resorption. 120 mg is preferred over 60 mg in patients with skeletal metastasis and no dose adjustment is required in renal failure. So again, this is the article we published with patients who presented with hypercalcemic encephalopathy. The most common cause in patients who had hypercalcemic encephalopathy was malignancy. Otherwise, the most common cause is primary hyperpara. But in this series, hypercalcemic encephalopathy malignancy was the most common cause because encephalopathy is not common in patients with primary hyperparathyroidism because of gradual rise in calcium levels. In malignancy, there is rapid rise in calcium levels which can lead to encephalopathy. So that's why malignancy associated hypercalcemia was most common cause in this series. Now coming to the last case, this is a case of 51-year-old female presented with nausea, vomiting and weight loss. 4 kg weight loss was reported in 2 months and blood pressure was normal. Patient had tachycardia. Oxygen saturation was 98%. On investigation, serum calcium was 12.4, creatinine was 1.3, PTH was less than 18. So it was PTH independent hypercalcemia. ACE levels were elevated. It was 121. So we got a call from gastroenterology department for this patient. They worked up this patient of diffuse uptake, suggesting Graves' disease. Hypercalcemia is not a very common initial manifestation of Graves' disease. It can occur in 10% of the patients with Graves' disease. So this patient was treated with carbimazole 30 milligram per day and propranolol 40 milligram per day. After 4 weeks, free T3, T4 levels and calcium normalized. And after 3 months, ACE levels turned out to be normal and repeat CT showed no evidence of thymic hyperplasia. So the lesson we learned from this case was that ACE levels can be elevated in patients with thyrotoxicosis, and even thymic hyperplasia can occur in these individuals which revert back to normal after the treatment of hyperthyroidism when patient returns to euthyroid state. So the take-home message include initial evaluation should include confirming hypercalcemia with corrected calcium or ionized calcium, followed by assessing PTH level to determine whether it is PTH dependent or independent hypercalcemia. IV saline is the first line treatment. Zoledronic acid or denosumab are preferred treatments for malignancy-associated hypercalcemia, particularly in patients with skeletal metastasis. Denosumab is considered slightly better in this situation. Calcitonin provides a rapid but transient reduction in serum calcium levels, and tachyphylaxis occurs within 24 to 48 hours. Steroids are effective in granulomatous diseases, lymphoma, and vitamin D intoxication. Steroids have no role in patients who have hypercalcemia due to primary hyperparathyroidism. These patients, we use zoledronic acid or denosumab to normalize calcium level, and ultimate treatment is removal of the adenoma. Dialysis is used for severe life-threatening hypercalcemia. Thank you.
Thank you very much. Again, a beautiful talk about very less talked about issue. So when you suggested, I readily picked up, because in a lot of lectures or conferences I attend, hypercalcemia is never talked. Yes. So thank you very much. And I want to ask you, in your practice, how many people of hypercalcemia you encounter with now very prevalent intake of vitamin D and calcium? Oral intake.
Oral intake of, sir, with oral intake of vitamin D, we don't encounter much patients with hypercalcemia. But with injectable vitamin D, we do frequently encounter patients with vitamin D intoxication, and that too with vitamin D injections. With oral, 1 or 2 patients, I would say, out of 50 to 60 patients we have seen. We are also doing a study with Dr. Naveen Mittal in DMCH. I was also doing with sir, clinical profile of patients with vitamin D intoxication presenting with hypercalcemia. I think we are having 30 patients. We have enrolled 30 patients, and we are looking into the clinical profile of those patients. And most of the time, the patients who presented with hypercalcemia, they had received vitamin D injections from, and the most common department from where they received was orthopedic department.
Because now vitamin D is being considered as, you know, Panacea of all diseases. Yes, you take vitamin D, and I don't know what was happening 40 years back when we were students. Then the population did not have vitamin D deficiency. Now it is, you know, thought that about 80% of Indian population is vitamin D deficient. So everybody is after taking vitamin D. Thank you very much.
Thank you. Thank you, sir.
Thank you, sir, for your excellent presentation. Now, I would call upon Dr. Sumit Pal Singh Chawla, Associate Professor, Department of Medicine, GGS Medical College and Hospital, Faridkot, to present his topic, Hypertension in Young.
Important topic, because I was in MAPICON last week, and Dr. Rajiv Gupta, the best person who is taking on this hypertension, when we interacted, he suggested to focus on hypertension in young. So we are also analyzing the data of 25,000 patients we collected during May measurement month of hypertension in young, especially in Indian setup. So I must congratulate you, picked up this topic, and really burning topic in present day scenario.
Thank you so much, sir, for the kind introduction. First of all, a very good afternoon to all present. I extend my heartfelt gratitude to the organizing team of MAPICON, especially Professor Dr. Vitul Gupta, for giving me this opportunity to speak on a very important topic, which is hypertension in young. Hypertension, as we all know, is the most common non-communicable disease all over the world. Its prevalence and incidence is increasing at a startling rate all over the world, especially in Asia. Despite this, its proportion in the young population is largely underestimated both by the medical and the non-medical community. Because of this, a large chunk of this population is still undiagnosed, and most of them are even unaware of the severe complications of this so-called benign entity. So with this, first we see the key points of today's talk. Hypertension in young, there is no fixed age for defining hypertension in young, but most of the previous literature says that any individual who develops hypertension between the age of 18 to 40 can be labeled as a young hypertensive. As I've said, it is not uncommon. In fact, 1 in 8 individuals between the ages of 20 to 40 years are affected with it. The incidence is rising day by day because of the modern lifestyle and due to ever reducing hypertension thresholds in different guidelines, especially the last guideline issued by AHA, where the hypertension threshold has been reduced to 130 by 80. The treatment is often delayed, and it is very important that we screen for secondary hypertension and monogenic hypertension in these individuals. Now, hypertension as such affects almost 25% of the global population. It is the leading modifiable risk factor for cardiovascular morbidity and mortality. We can imagine that if a young individual develops hypertension, say at the age of 20-25, the chances of cardiovascular and cerebrovascular complications will be all the more, and they will tend to appear at an earlier age. So this is the population that we need to diagnose early, treat early, and screen early for complications. Now, this was a large ICMR study which was concluded in 2023. It was published in Lancet. It found the prevalence of hypertension in India at a very high value, that is 35.5%, almost 1/3 of the entire population being affected by hypertension. Now, these are startling figures. It also found that hypertension was the most common non-communicable metabolic disorders among all the other disorders like diabetes, prediabetes, metabolic syndrome, and dyslipidemia. World over, the prevalence of hypertension is also high in the younger population. The incidence is more than 10%, and there has been a tremendous increase in the proportion of hypertension in young individuals. In fact, in the last decade, we have seen almost doubling of the number of individuals who present at an early age with hypertension. This was another Indian study which concluded in 2020 and published in 2020, which found the prevalence of hypertension between 20 to 40% in the urban adults and 12 to 17% in the rural adults. Even in this study, the individuals between the ages of 20 to 44% had a high prevalence of hypertension. It was 26.7%. Now, if we compare this data with the US counterparts, in US, the prevalence of hypertension in this age group was only 10.5%. So with this, we can actually understand the magnitude of hypertension in the young population in our country. The ironical part is this is only the tip of the iceberg because many of the individuals are still undiagnosed. So Ministry of Health in 2019 to 2021 conducted their 5th round of National Family Health Survey, and they found that the prevalence of hypertension in the young individuals was 17.6%. Now, despite a high prevalence and a high incidence of hypertension in these young individuals, there are certain barriers to controlling hypertension. What are those barriers? Most important is altered health identity. The young individuals do not accept the diagnosis of hypertension. The physicians as well as the patients show great reluctance in starting antihypertensive medication. There is a definite gender difference. Males tend to decrease their follow-up visits. Females are more compliant with the antihypertensive medication and with the frequent follow-ups. There is a great blood pressure variability. There is a great diurnal variation of blood pressure in these individuals, which further increases the chances of cardiovascular morbidity and mortality. And the visit adherence in this population is also very low. Now, different guidelines propose different definition for hypertension. We'll follow the International Society of Hypertension guidelines, which clearly state that any individual with a systolic BP of more than equal to 140 and a diastolic BP of more than equal to 90 can be labeled as hypertension. But most of the guidelines also state that ambulatory blood pressure monitoring should be the gold standard for diagnosis of hypertension. So if we are using ambulatory blood pressure monitoring, the 24-hour average is taken as more than equal to 130 and diastolic more than equal to 80 to label anyone as hypertensive. The AHA guidelines, on the other hand, state that any individual who has a systolic BP more than equal to 130 and a diastolic BP more than equal to 80 is a hypertensive. Now, the pathophysiology of hypertension in young individuals is very complex. Most of the individuals are males, and most of them show a isolated systolic hypertension phenotype. That is because of increased sympathetic tone. So increased sympathetic tone leads to increased stroke volume, increased cardiac output. On the other hand, the females tend to show isolated diastolic hypertension phenotype or cystodiastolic hypertension. That is due to increased peripheral vascular resistance, and that is due to increased stimulation of the renin-angiotensin-aldosterone system. So it has been observed that the young males who are hypertensive tend to have a cardiac hypertension phenotype, whereas young females tend to have a vascular phenotype. What are the important risk factors? Family history and genetic factors obviously play a big part. A very interesting hypothesis was given by Barker and Brenner, which was termed as developmental origins of health and disease hypothesis. It states that there are certain perinatal factors which govern the occurrence of hypertension in the young individuals. Now, what are those perinatal factors? One is fetal IUGR, low birth weight, preterm babies, and if their mother had hypertensive disease of the pregnancy. These individuals are at a far greater risk to develop hypertension in young. Other traditional risk factors we all are aware of are sedentary lifestyle, high intake of salt, metabolic syndrome, high alcohol consumption, smoking, consumption of tobacco products, consumption of illegal drugs, etc. There are two types of hypertension. One is primary hypertension, also termed as essential hypertension. This is the most common phenotype. It doesn't have an underlying cause. The family history plays a very big part, and there is a very big contribution of metabolic syndrome and obesity. Second is the secondary hypertension. It is very important that we screen all young hypertensives for secondary hypertension because these causes are potentially curable. Approximately 10% of the individuals have secondary hypertension, and secondary hypertension proportion has an inverse proportion with age. That is, as the age advances, the chances of secondary hypertension reduce. So the causes for secondary hypertension are more prevalent in school-going age. What are the factors which should make us suspect a patient for secondary hypertension? Obviously, first is if a patient comes to us with a high blood pressure and he is less than 40 years of age. If a patient comes to us with drug-resistant hypertension, there is severe hypertension at presentation. Patient straight away comes to you in the ER with history of frank pulmonary edema, malignant hypertension, or a stroke, then you should suspect secondary hypertension. There is a sudden deterioration in the blood pressure control. You are following up the patient for 2 to 2.5 years, and suddenly your patient has stopped responding to the traditional drugs. If you do an ambulatory blood pressure monitoring and you find a strong non-dipping status and presence of hypertension-mediated organ damage, all of these factors should lead you to suspect secondary hypertension. What are the important causes for secondary hypertension? Most important cause are the renovascular and the renal. In renovascular, we should rule out fibromuscular dysplasia and atherosclerosis. There are numerous endocrinopathies which also lead to secondary hypertension, most important being thyroid disorders, both hypo and hyperthyroidism, hyperparathyroidism, primary hyperaldosteronism, Cushing syndrome, and pheochromocytoma. Other miscellaneous causes are coarctation of aorta and obstructive sleep apnea syndromes. What is monogenic hypertension? Monogenic hypertension is again an important entity which is associated with hypertension in young, and it arises from specific gene mutations. Obviously, it has a very strong family history, and these syndromes, since they have a genetic predisposition, they tend to present early in life. Now, what are the factors which should enable you to suspect monogenic hypertension? One is young onset hypertension, presence of low renin, persistent electrolyte abnormalities, especially potassium and bicarbonate. This should lead you to suspect aldosterone hypersecretion. So brachydactyly, disorders of adrenal steroids like congenital adrenal hyperplasia, and a strong family history of young onset hypertension, myocardial infarction, sudden cardiac death, stroke in a first degree relative. And the most important part for today's talk is how to evaluate a young patient who comes to you with a high BP measurement. First, we have to ensure that whether that patient has hypertension or not. Second is, if that patient is diagnosed with hypertension, you have to assess the cardiovascular risk. You have to assess for the end organ damage, and then you have to screen for the secondary causes of hypertension. Now, if a patient comes to you in the office, you take his blood pressure, you cannot label that patient hypertension on a single reading. Ideally, this has to be done on 2 different occasions. The patient should be relaxed for 5 to 10 minutes. You have to take at least 3 readings, and you take the average of last 2 readings. These readings have to be taken at 1 to 2 minutes apart. If your patient is found to have high blood pressure on both the occasions, you should subject the patient to ambulatory blood pressure monitoring to confirm the diagnosis of hypertension. What are the clinical features of hypertension in young? Apparently, most patients are asymptomatic and they are diagnosed incidentally. They come to you for another pathology, you check their BP and found them to be hypertensive. There are very few patients who come with hypertensive headache. They are the ones who have severe hypertension. They present with a classical occipital headache, which is more in the morning. There are certain patients who directly present to you with hypertensive emergency, like frank pulmonary edema, congestive heart failure, renal failure, or a MI. Now, what are the investigations which you have to do to assess for cardiovascular risk and to assess for end organ damage? ECG has to be done for all patients, followed by 2D echo. 2D echo is meant to find out left ventricular hypertrophy. That gives you an idea that for how long your patient is hypertension. Then you have to look for systolic and diastolic dysfunction. You have to look for the dilated atria and other chamber dimensions. Blood tests which are routinely ordered are LFT, RFT, HbA1c, lipid profile, thyroid profile. You have to do a fundus examination for all the young hypertensives to rule out hypertensive retinopathy. And urine routine examination, especially urine albumin to creatinine ratio, has to be done for all to look for microalbuminuria. Now, this is the fundus of a young hypertensive male. You can observe the cotton wool spots, and plus you can hardly see the margins of the optic discs. So there is obliteration of the optic disc margins. Now, how do we diagnose secondary hypertension? Most important is to rule out renovascular and the renal causes. There are certain clinical features which give you important clinical clues. One of them is abrupt onset of hypertension, severe or resistant hypertension. If a patient comes to you with hematuria, oliguria, pedal edema, dyspnea, again you should suspect renovascular or renal causes. And one important history is a patient being diagnosed as hypertension and given an ACE inhibitor or ARB, and you follow up that patient for 4 to 8 weeks, and you find a sudden deterioration in the estimated GFR. There is an increase in the serum creatinine, then you should strongly suspect a renovascular cause. Some of these patients may also present with flash pulmonary edema, and on examination you can find abdominal bruit, especially a renal artery bruit. What are the important lab investigations you should order? First being RFT, then urine routine examination. We should order a plasma renin level which will be high, and ultrasound can show either a unilateral or a bilateral atrophic kidney. The investigation of choice for renovascular hypertension are a Doppler arterial ultrasound, a CT or a MR angiography. If available, we can also go in for captopril enhanced radioisotope renal scan. Now, this is the CT. On your left, you can see a CT angiogram, which is classically showing stenosis of the right renal artery. And on the other panel, you can see the classical string of beads appearance, which is very classical of fibromuscular dysplasia. So when to suspect a patient for Cushing syndrome? When a patient presents to you with classical features of Cushing's like truncal obesity, moon face, proximal myopathy, osteoporosis, buffalo hump, purple striae, and easy bruisability. Simple investigations to be ordered are 24-hour urinary cortisol level followed by a dexamethasone suppression test. Now, when to suspect pheochromocytoma? Pheochromocytoma typically presents with episodic hypertension. There are multiple episodes of severe headache, palpitation, sweating, panic attacks, and pallor. Investigations to be done are screening can be done by a serum metanephrine level. Diagnosis is by 24-hour urinary metanephrine or normetanephrine level. Pheochromocytoma can be localized by a CT or a MRI, and if available, we can go in for MIBG scintigraphy. Now, when should we suspect our patient to be having coarctation of aorta? It classically presents in school-going children who either present with an innocent murmur or hypertension. You check the blood pressure in both the limbs, there can be discrepancy. You check pressure in the left upper limb and the left lower limb, and you can find a marked difference in blood pressure in the two limbs. It can also be suspected whenever there is a radio-radial delay or a radio-femoral delay, and it is 8 times more common among boys. Now, coarctation of aorta can be easily diagnosed on a chest X-ray, which shows a classical 3 sign, which I'll show you subsequently. You can also find rib notching, which is due to intercostal collaterals. A barium swallow may show a reverse 3 sign. Definitive diagnosis is by magnetic resonance aortography. Now, the classical 3 sign is actually found by a pre-stenotic segment, which is the aortic knuckle. It is followed by the coarctic segment, and then there is dilatation of the post-stenotic segment, which leads to a classical 3 sign. One can also see in the rib notching in the red arrows. Now, which guidelines should we follow for managing a patient with hypertension? We'll stick to the Indian guidelines and the European guidelines. Both say that any hypertensive young male who has a BP more than equal to 140/90 can be put on drug therapy. But if the patient already has diabetes, CKD, cardiovascular disorder, or familial hypercholesterolemia, then this threshold may be lowered to 130/80 millimeters of mercury. And most of the international guidelines advocate that an ambulatory blood pressure monitoring is a must to confirm the diagnosis of hypertension. AHA guidelines also advocate the same. They say that stage 1 hypertensive have to be treated if they have a established cardiovascular disease, or if the 10-year atherosclerotic cardiovascular disease risk is more than 10%. Otherwise, irrespective of comorbidities, any patient with a BP more than equal to 140/90 needs to be put on lifestyle modification and pharmacotherapy. Now, treatment for hypertension should always be a multidiscipline approach, should always be a holistic approach, and very important, which we tend to ignore, is the lifestyle modification. So most important is weight reduction. BMI has to be kept below 25. Dietary salt intake should be less than 6 grams of salt per day. Advice for a DASH type of diet with more amount of fruits, vegetables, low fat dairy products, and low amount of saturated fats in diet. The alcohol consumption has to be reduced. Smoking has to be stopped. Tobacco products consumption have to be stopped. And patients should be advised to go in for physical activity, at least 30 minutes of physical activity for 5 days a week. This is a very busy slide, but we'll take a few important clues from this. This is the JNC 8 treatment guideline. It gives us definite target goals. So first goal is, if your patient is not a diabetic, not a CKD, our goal is to reduce the blood pressure to less than 140/90. However, if your patient is either CKD or having diabetes, then your target is less than 130/80. And 3 different strategies can be used. Strategy A is, we start with a monotherapy, then follow up the patient, increase the dose to the maximum permissible limit. Strategy B is, we start with a single drug, then follow up the patient, and a second drug may be added without first increasing the dose of the first drug. And strategy C is, we start with a combination therapy right from the outset. This is advisable when the systolic BP is more than 20 above the threshold and diastolic BP more than 10 above the target goal. All of this have to be complemented by lifestyle modification measures, which we have just discussed. Now we'll focus more on the Indian guidelines. For younger individuals, the drugs of choice are ACE inhibitors and ARBs. But before that, in case of a young female, you have to exclude pregnancy and you have to exclude conception. If the target goal is not achieved with either an ACE inhibitor or ARB, we can either add a calcium channel blocker or a diuretic. In step 3, if the BP is still not controlled, we give all the 3 drugs together, ACE inhibitor or ARB with a calcium channel blocker and a diuretic. If the BP is still not controlled, it is termed as resistant hypertension. If your patient has resistant hypertension, you have to add another agent, which is mineralocorticoid receptor antagonist in the form of spironolactone or eplerenone. If the BP is still not controlled, the other options we have are beta blockers, alpha blockers, and centrally acting agents. So pregnancy is another very important entity in young individuals. If the patient is pregnant, we cannot give ACE inhibitor or ARB. If the patient is planning to conceive, then ACE inhibitor or ARB have to be substituted by a safer option like labetalol, nifedipine, or methyl-dopa. So how frequent the follow-up should be? It should be at least after 3 months. So prior to 3 months, we should not try to change either the dose or the drug regimen. So to summarize, hypertension in general and hypertension in young is tip of the iceberg. Although the prevalence and incidence is already high, but there are many more who are still undiagnosed and unaware. It is important that we diagnose them timely and treat them timely. The number of young adults with hypertension are increasing globally on a rapid pace. If early onset of hypertension is there in the young population, many of them will end up with cardiovascular and cerebrovascular morbidity and mortality. This will affect the financial and the productional age of the society. It is important that we rule out secondary causes, although the number is less than 10%, but these are the patients who are potentially curable. Treatment has to be started. Most of the guidelines say treatment has to be started when the BP is more than equal to 140/90. These can be lowered if patient already has diabetes, chronic kidney disease, and established cardiovascular disease or familial hypercholesterolemia. While tackling a female young patient, do rule out pregnancy. If pregnancy is detected or patient is planning to conceive, do not give ACE inhibitor or ARB. For rest of the population, ACE inhibitors and ARBs are the drugs of the choice. Thank you for your patient listening.
Thank you, Dr. Sumit, for touching this rather important topic briefly and explained very well.
Thank you, sir.
And I suggest, as I was sensitized to work in hypertension in young, you are in a good institute with very high patient load. I think you should also have some data in hypertension in young. Thank you very much.
Thank you so much, sir. Thank you.
Thank you for your incredibly insightful presentation, sir. Now we'll move forward to Dr. Aman Bharti with her topic, Diabetic Kidney Disease. She is an Associate Professor in Department of Medicine in GGS Medical College, Faridkot.
A very good afternoon to all of you present. I especially thanks to the all organizing team, as especially Dr. Vitul Gupta and all ma'am for giving me a chance to speak today. So I begin my slides. So I will be talking today on the diabetic kidney disease. So what is exactly diabetic kidney disease? As such, there is no widely accepted definition for DKD, but as such, for the American Diabetes Association, it is usually a clinical diagnosis that is based on the presence of albuminuria or reduced estimated GFR in the absence of signs or symptoms of other primary causes of the kidney damage. So diabetic kidney disease is a serious matter. Kidney disease is a frequent diabetic complication, as we all know, as it occurs in 30% in type 1 diabetic patients and 40% in type 2 diabetic patients. So diabetes is most common cause of CKD and end-stage renal disease in developed as well as in developing worlds. It also amplifies the cardiovascular disease risk. So as for diabetes is one of the leading cause of the CKD, we all know, and the prevalence of the end stage CKD is 10 times higher in people with diabetes, and 80% is the cause of the end stage renal disease that is caused by diabetes, hypertension, or the combination of the both. So in this scenario, the screening of albuminuria should be done every yearly after the diagnosis in people with type 1 diabetes or type 2, and the same after first 5 years in people with the type 1 diabetes. So if we're talking about what is the residual risk and the cardiovascular in type 2 diabetes, as such, you can see in this, the diabetes mellitus is coincident with this cardiovascular disease risk to the tune of 12.3 to 15.3%, and the diabetes mellitus is also leading in the prevalence of the CKD to the tune of 48.4%. And there are many contributors to this excess risk, because this chronic kidney disease, it is all we know that a CV risk multiplier, because limited treatment options are there. Then the heart failure could be there. It goes under recognized as the diabetic complications, and limited preventive care strategies are there. So if we see in this slide, we see the natural course of the history of diabetic kidney disease. In the years, you can see 2 year, 5th year, 10, 20, and 30 years. Initially, in the first 1 to 2 years, there will be the signs and symptoms of hyperglycemia. GFR could be raised, normal. And initially, when we see pathological, there could be cellular injury, leading on to coming years mesangial expansion with the glomerular sclerosis or tubular diseases. And initially, after the 5 years, you can detect in the patients there could be microalbuminuria. GFR could be normal at the stages, and the other concomitant hypertension could be detected. And next, over 5 to 10 years, you can assess for the cardiovascular diseases. Other with the GFR can be declining low. Instead of microalbuminuria, you can have the macroalbuminuria in your patients. And the pathological changes may be always increasing from the cellular injury to tubular interstitial fibrosis, along with some inflammation, and leading on to kidney complications, and along with the end stage renal diseases. This occurs over the lifespan from diagnosis up to the 30 to 35 years. So our target is we have to always halt the disease progress. There is as such no cure for CKD, or the diabetic kidney disease can be itself prevented, or it can be, the disease process can be halted. So I will be coming in the next slides how it could be achieved. So there is a mechanistic link between pre-diabetes, diabetes, and diabetic kidney disease, and the end-stage renal disease. So there is always a risk, link between pre-diabetes, diabetes leading to the chronic hyperglycemic changes because of metabolic syndrome, dyslipidemia, increased fatty acids, metabolisms. There could be hemodynamic changes leading on to cascades of inflammation, cytokines and chemokines leading to oxidative stress, then leading to apoptosis, autophagy, mitochondrial dysfunction or the mitophagy, leading on to the diabetic nephropathy. And all these things lead to, again, to the end stage kidney disease. This is a mechanistic link between the pre-diabetic diabetes and this nephropathy, along with end stage renal disease. So this is a healthy glomerulus. You can see fenestrated epithelium is well appreciated, mesangium is there, basement membrane is there, podocytes are there. Then the diabetic, when there is diabetic kidney disease, what happens? There is a thickening of the basement membrane, that is the blue darkened. Then the mesangial expansion is there, and there is a loss of fenestration and glycocalyx, and then the podocyte injury and the loss of the tissue is all appreciated. So this is again structural changes in the diabetic kidney diseases. Then what does the diabetes damage do to the kidney? It affects mainly direct glomerular damage could be there, or the direct tubular damage could be there. In both of the scenarios, there is albuminuria, leakage of the albumin inside the urine. So there is a podocyte barrier damage when there is a direct glomerular damage leading on to glomerular leaks, and if there is a direct tubular damage, it leads to decrease in albumin endocytosis, leading to the reduced retrieval, and again leading to microalbuminuria, and again the vascular imbalances, then leading to the hyperglycemic. All is the cascade that is the damage in the diabetic kidney disease. So this is again one of the pathological model we all had discussed. So what are the other diabetic complications which is associated with this diabetic kidney disease? Once the patient is diagnosed with diabetic kidney disease, so he or she could be having some of the other complications in the later lives. There could be cerebrovascular coronary artery disease. There could be diabetic cardiomyopathy, peripheral vascular disease, foot disease, bladder dysfunction, neuropathies, erectile dysfunctions, eye diseases, periodontal diseases, along with depression and anxiety, leading all to cascades of the cognitive impairments. So the other complications, it could be increased risk of UTI, serum electrolytes, acid-base. Complications could be there, type 4 RTA, that is hyperkalemic and low in iron gap. They are more common in diabetic kidney disease patients. Even the kidney stones are more common in patients, especially those with moderate renal dysfunction. Even this low urinary pH, that is more, and it leads to the uric acid stone. These are one of the complications of diabetic kidney diseases. Now what to do? What is the CKD screening and the diagnosis people for living with the diabetes? So who and when to screen? Yeah, when the patients come to you with the type 1 diabetes, start immediately screening for albumin, yearly starting and 5 years after the diagnosis in type 1 diabetes, and in case of type 2 diabetes, yearly starting at the diagnosis and again thereafter annually. How to screen? You need to get a spot urine ACR, that is albumin creatinine ratio, and the estimated GFR. So what to do? When the test is positive, then we need always to repeat and confirm. We need to again evaluate possible temporary or the spurious causes, and then we can always consider using cystatin C and creatinine to more precisely estimated GFR, and only persistent abnormalities define the CKD. And we should always initiate this evidence-based treatments. So what exactly defines your diagnosis for the CKD? There could be persistent urine ACR that is more than or equal to 30 milligram per gram, or persistent estimated GFR, it is less than 60 ml per minute, and over other evidence for the kidney damage. So I had discussed the screening for microalbuminuria. You can see the microalbuminuria, second normal and micro, and then came macro. So the microalbuminuria is, you should be always repeat 2 times over 3 months, and you should be always confirming albuminuria if 2 out of the 3 tests are positive. And in case of macroalbuminuria, that is also called proteinuria. In the case of females, it is labeled as when it is more than 35, and in case of males, it is more than 25 milligram per millimole. And in this case, we need to quantitate. We need to collect 24-hour urinary protein and quantify the protein excretion, and we need to get a protein creatinine ratio. So there are certain factors which affect your urine albumin excretion. For example, in case there could be increased fallacious or spurious, for example, in strenuous exercise, poorly controlled diabetes mellitus, even in heart failure, UTI, acute febrile illness, uncontrolled hypertension, hematuria, menstruation, even in pregnancy. And there are certain conditions in which there could be decreased AER, that is patients when on NSAIDs or ACE inhibitors. So these should be always kept in mind before labeling the patient as to be microalbuminuria, it is true or it is false. So what are the other biomarkers? These are the latest biomarkers associated with predicting for the diabetic kidney disease. For example, when we suspect there is inflammation or endothelial damage, or there is fibrosis, we need to get some of the biomarkers at the level of glomerulus, similarly proximal tubules, loop of Henle, distal tubules, and the collecting ducts. For example, inflammatory to the endothelial damage or the vascular damages, there we always get alpha-1 antitrypsin levels, TGF, beta-1, MCP-1, VEGF, and other markers. Glomerulus for cystatin C, alpha-1 microglobulin, and the beta-2 microglobulin along with albumin. Then the PCT, there came Managal, and along with distal tubule again the similar, that's osteopontin and uromodulin for the loop of Henle, and copactin for the collecting ducts. Now, what are the symptoms of DKD? The patients will be coming, they will be saying they are passing the foamy urine, there is frothy urine, and there is unexplained proteinuria. Patient will be feeling fatigue, there will be fetal edema, or any associated, you could fetch the peripheral vascular disease, or could be hypertension, coronary artery diseases. So I had already discussed how you will diagnose them when there is impaired estimated GFR less than 60, there is albuminuria, that is UACR is more than 30 milligram per gram creatinine, and it is always spot sample to calculate the ratio of albumin to creatinine. Morning sample is preferable, and the annual screening is always very important in diabetic kidney disease, that is 5 years after the diagnosis with type 1 diabetes, and upon diagnosis in case of type 2, and then yearly afterwards. So if we look for the stages of diabetic kidney disease, there are 1, 2, 3, 4 and 5 stages as such. In the stage 1, there is hyperfiltration along with nephromegaly. GFR could be normal, elevated. Even the albuminuria could be absent and BP can be normal at the time of diagnosis. Stage 2, that is GFR could be normal or even high, and albuminuria is absent. The BP could be normal and time of illness is less than 5 years. Stage 3, here it comes the microalbuminuria, and it is incipient nephropathy is there. Albuminuria ranges between 30 to 300 milligram per day. You always remember DKD can be even reversed till stage 3. Then comes your stage 4 where there is macroalbuminuria and there is declining in the GFR, and comes the later stage, that is CKD stage 5, in where the GFR is diminished and the albuminuria is decreasing. And the time course of the illness, it is 15 to 30 years after diagnosis. So it is a CKD risk progression. In this you can see there is various categorization according to the GFR, that is G1 to 3A, 3B, 3G4 and G5, along with albuminuria categorizes into A1, A2 and A3. So it is again we need to step up the where should we screen the patient, and the yellow part shows you need to treat the patients, and the orange part is like we need to treat and refer the patient, and then it should be aggressively treated, as well as the proper monitoring should be done in the coming years. So let's talk about how to manage this diabetic kidney disease. You know, it's the aim is all to slow down the progression of the kidney damage. We should always target onto proteinuria to decrease this proteinuria, hypertension to control hypertension by many drugs or 1 or 2, or this decrease this glycemic levels, or the target on the hyperglycemic. So for overcoming barriers to management of the CKD in patients with diabetes, there are various multidisciplinary education, harmonized clinical practical guidelines are there, self-management programs are there. There are various care models and risk mitigation strategies to improve management of diabetes and this CKD. So there is multifocal approach. Number 1, we need to slow down the progression of diabetic nephropathy with the optimal glycemic control. The target should be HbA1c should be less than 7%. In case we should be starting with intensive antihypertensive control when the blood pressure is to target less than 130 to 80 for people with proteinuria, which is less than 1 gram per day, and BP should be targeting in those cases where the proteinuria is more than 1 gram per day, it should be less than 120/75. Then you need to start with blockage of RAS for the ACE inhibitors or ARBs to control this proteinuria. So this is a pyramid where we can see that starting from the base, we need to exercise, we should be cutting off excess salt, and nutrition should be controlled, smoking cessation should be done. Even in all the patients you need to control your lipid management, blood pressure, glycemic controls. In most of the patients you should be starting with RAS blockage agents with SGLT2 inhibitors to control the glycemic status, and in some patients you need to take care of this vascular damage when we start the antiplatelet therapies. So targets for incipient and overt diabetic nephropathy, we need to lower the blood pressure to target of less than 130 to 80 mm of Hg. We need to block the RS by using ACE inhibitors or ARBs to maximum tolerated doses. Then we need to improve the glycemic state, and we should be targeting with less than 6.5% by using the insulin injectables, and when we should be targeting to lower the LDL levels to less than 100, and anemia management should be done to the targeting between 11 to 12. We can use erythropoietins or plus oral injectables as well, and the endothelial protection we use to aspirin we should starting daily, and smoking should be cessation. The glycemic monitoring and target, we should be always HbA1c, if we are targeting less than 6.5, then the severity of CKD will be lesser, macrovascular complications will be absent, comorbidities will be few, and life expectancy will be good as compared to if the targeting HbA1c is less than 8. Then in the similar scenario, the life expectancy will be short, comorbidities will be many, and resources for hypoglycemic management are also impaired in such scenarios. So in this scenario, the physical activity, nutrition and weight loss, we should be in all the patients of diabetic nephropathy or diabetic kidney disease, and the first line therapy should be metformin. Now metformin should be used always when the GFR should be more than 60, and if the GFR is less than 45, you should always reduce the dose of metformin, and you should discontinue metformin when the GFR is less than 30. Or in case of kidney failure, when there is SGLT2 inhibitor, when the GFR is less than 30, we should not initiate such. And in case of kidney failure also, SGLT2 inhibitors, they are not initiated. You can use additional drug therapy needed for glycemic control like GLP-1 receptor and agonist are preferred, DPP-4 inhibitors, insulin, even sulfonylureas are good enough, and alpha glucosidase inhibitor. And again, this is a slide which you can see the drugs: metformin, SGLT2 inhibitors, GLP-1 receptor agonist, DPP-4 inhibitors. So in these slides, you can see that SGLT2 inhibitors and this DPP-4 inhibitors, they are safer in type 2 diabetes with CKD across the patient profile. So if we discuss what about the transplantation in the diabetic kidney disease, transplantation is always superior in dialysis in terms of patient survival, because living related donor provides excellent results, and it has been found in many studies that patients with end stage renal disease due to diabetic kidney disease who receive transplantation will have projected life expand to 19 years as compared to 8 years for those who remain on the dialysis. And how to prevent this diabetic? We should always be maintaining or target HbA1c less than 7. We should be controlling hypertension. We should avoid potential nephrotoxic drugs and substances. Early detection and optimum management of diabetes should be done, and the regular follow-up should be managed. So I will be discussing about what are the latest advances and research. These are my last slides, and in this I would like to say there is one molecule, that is finerenone, that is a non-steroidal mineralocorticoid receptor antagonist. What it do, it reduces the kidney failure and disease progression in the diabetic kidney disease, and the trial demonstrated, and it is to be taken in the single dose of 10 mg or 20 mg orally once daily, and its adverse effects are generally hypercalcemia, hypotension or hyponatremia. So there is another trial, that is a carmilena, that is a long-term CV and cardio, this renal safety of linagliptin. Linagliptin also safe molecule to be used. It also slows down the progression of diabetic kidney disease. It is used as a 5 mg per day dosage. Along with this, dapagliflozin is also wonder drug. It is also used as a 10 mg per day. It also reduces to this diabetic kidney disease. Along with it also reduces the risk potential of cardiovascular events in patients with chronic kidney disease. The SGLT2 inhibitor, that is dapagliflozin, it is based on the results of DAPA and the CKD. There are various with the heart failure patients also it is safe, and all in the CKD patients it is also safe. So if it is the first line drug therapy in case when there is the cardiac patient is there or the other more progressive diseases there, so it is always safer. So this new drug is again approved, that is a vaxagliflozin, that is 20 mg. It is a sodium glucose co-transporter 2 inhibitor indicated as an adjuvant to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus. This is a new device approved by the FDA, that is the MiniMed 780G system, an automated insulin delivery system that helps people ages 7 or old. It manages their diabetes by detecting trends and tracking patterns in glucose levels through continuous monitoring, using an insulin pump to automatically deliver insulin and adjust the amount of insulin delivered. So this is again one of the slides we shall go in brief, that is albuminuria in the diabetic kidney disease and non-albuminuric diabetic kidney disease. So in albuminuric diabetic kidney disease there is always a microangiopathy, whereas in non-albumin there is macroangiopathy. So in this case this albuminuric diabetic kidney disease, you will see there will be more patients with glomerulosclerosis, whereas in other setup there will be tubular and vascular damage. So there are a lot of historical perspectives on slowing of this diabetic kidney disease or CKD progression starting from 1980 to the 2022. There are a lot of trials which have been suggested and summarized all the drugs. So the key updates are, there is evidence that people with poorly managed hyperglycemia associated with type 2 diabetes can also be effectively treated with sulfonylurea, GLP-1 receptor agonist and dual GIP. And GLP-1 receptor agonist and the teriparatide have additional benefits over insulin and sulfonylurea, especially lower the risk for hypoglycemia. And the results from the comparative effectiveness meta-analysis suggested that each new class of oral non-insulin agents added to initial therapy with metformin generally lowers the HbA1c level to 0.7 to 1%. And if GLP-1 receptor or the dual is added, then it is more than 2% lowering of HbA1c is expected. So particularly important, as SGLT2 inhibitor and GLP are associated with lower risk of hypoglycemia and individuals with atherosclerotic related cardiovascular disease, heart failure and the CKD. So the carry home points are, advanced CKD is high risk clinical entity with high morbidity and mortality. CKD doubles the risk of cardiovascular events and death in patients with type 2 diabetes. It's never too late to improve glycemic control, but strategy is different. CKD should be considered when choosing an anti-diabetic drug, avoiding the hypoglycemia, and many changes in treatment are needed, making management challenging. SGLT2 inhibitor dapagliflozin reduces CKD progression and heart failure patients and other cardiovascular disease risks. And non-steroidal MRI inhibitor already discussed, that is finerenone, should be thought of an adjuvant therapy to slow nephropathy progression. And GLP-1 receptor agonist like liraglutide, exenatide and semaglutide also reduces CV risk and are safe. So additional BP control is very important, but challenging and novel approaches are really needed to improve the prognosis. So here I end up my slides, and thank you all for your patience listening. Thank you.
Thank you very much, Dr. Aman Bharti. You have done justice to the topic. And I think recently SGLT2 inhibitors have revolutionized the diabetic kidney disease for prevention as well as treatment. Thank you very much.
Thanks a lot, sir. Thanks.
Thank you, ma'am. It was a fantastic presentation. Now we'll move forward with Dr. Arvind K. Sharma, Consultant Obstetrician and Gynecologist, Executive Patron IAGE Punjab, Senior Member IMA Bathinda, on his presentation, Drugs Used in Pregnancy.
मैं करा देना जी. Okay. Hanji. So this is also an important topic, because most of the consultants, I believe, they don't know what drugs should be used in pregnancy, and sometimes it can cause a great harm. So great to choose this topic to make us aware about drug use in pregnancy. Thank you.
Good afternoon. And Dr. Vitul has already introduced the topic, and definitely this is an honor and pleasure for me also to be able to contribute, even if a small topic, at a very basic level, because mistakes are commonly made in this field. That is, when a patient is pregnant. Okay, one recent development that we can Google it out on our mobile phones, that's in a way good. But still, to have a background information, because everything can't be, you can't be Googling every time. And I'm just providing the basic background information. Next slide control, kahan se hai ji? Is this the one? Yeah. So this story actually, just about 100 years ago, no one was fully aware that drugs can have very bad effects on the fetus. So the entire topic came into focus just in 1960, around 1960, when a popular drug, thalidomide, it's a part of history of medicine now, It's still used for certain other indications. But this being a newer drug at that time, it was found useful in early pregnancy for nausea, vomiting, ghabrahat, that means restlessness or even lack of sleep. It was introduced as a hypnotic. It had some anti-emetic actions, and it became popular in Europe. And then there was kind of epidemic of this kind of babies. So this condition is called phocomelia, that means seal limbs, limbs like a seal. That's actually aplasia of the limbs, or very severe hypoplasia of all four limbs. And this was in variable degree when they found it, and some correlation led to this, that this is the drug taken by every pregnant mother in the first trimester who has given birth to such malformed babies. Babies were otherwise fine, but limbs were gone. So this created a great awareness, and everyone then, almost all the doctors became careful, and trials also were started. Even though there's a limitation, you cannot have the standard type of trials in pregnant women, give some experimental drug to a group and give some placebo to a group. That is ethically usually not permissible in pregnancy. That doesn't happen. So again, a difficult situation arose, that how to go about it. But then certain ways were found that we'll talk about a bit later. So now we come to basics about what's the relevance of drugs in pregnancy. Before reviewing this chart, which is very fundamental chart, the problems which can arise is, number one is teratogenesis. Teratogenesis just means structural defects, grossly visible structural defects. Then there can be problems with function. Structure is okay, but then the function of certain organs may get impaired. And then there may be subtle effects which are attributable to a damage. Now, particularly, first thing we are talking about is teratogens. Teratogens are, we know now that not just drugs. Drugs are important, and that's why we are having this talk right now. There are other teratogens as well, like environmental radiation, X-rays, etc., other kind of radiation. Then there may be certain food items, or even non-prescription drugs, or so-called indigenous desi medicine, which most of the times its ingredients are not known, like Ayurvedic, homeopathic people. Those are popular with laypersons, and we don't know, there's no study about those drugs. So teratogens, not just drugs, but there are several other factors. But in drugs, we know quite a bit which drugs are bad and which are good. Now here, if we see, this is just a chart showing the fetal development right from conception onwards till term pregnancy. So early development, the day one mentioned here is the day of fertilization, when the ovum and sperm, they unite and a fertilized zygote is formed. That's the day one, and that is usually taken as the moment of conception. And thereafter there is rapid cell division, we know, and this is around the time of day 14 to 15 of the menses cycle of the lady who is conceiving. So usually the pregnancy cannot be diagnosed at this stage. You know that. Mid-cycle conception starts, and we cannot diagnose pregnancy at that time unless we do very sensitive HCG assays and all. So that's not the part of clinical practice. Then for 2 weeks, it's pre-embryonic development, 2 weeks approximately. Some would say 17 days, some would say 14 days, but anyway, 14 to 17 days till the next missed period. So when the lady misses the period, then she gets her urine pregnancy test done, and that's how usually clinically a patient as well as her doctor comes to know that she is pregnant now. By that time, it has implanted in the uterus. So just as a passing reference, the fertilized ovum stays in the fallopian tube for 4 days. On the 5th day, it goes into the uterine cavity, gets implanted. Still, the circulation hasn't formed. Circulation forms at this time a few days after the missed period. The primitive circulation of the fetus or embryo it's called up to 8 weeks. So after that, the development shown in this chart is that up to 8 weeks following fertilization, that becomes 10 weeks following LMP. Clinically, we can count from LMP only because not possible for us to pinpoint which day did the fertilization happen, because it may happen anytime between day 11 and 17, which means 14 days, day 14 of ladies' menstrual cycle, plus minus 3 days. That's the time of fertilization. And thereafter, anyway, so then embryonic development, it's very basic thing, which I'm just revising, that up to week 8, 56 days, embryonic development happens, and all the organs are being formed from the totipotent cells of early embryo. All the organs are formed, which is a wonder of life. Almost all living beings develop like this. And thereafter, just the increase in size, the growth of those organs which have taken shape, that happens. Some organs like brain, kidneys, they do keep on forming up to 12 weeks post-fertilization. So I'm just telling you a basic thing is sometimes it's a source of confusion. Pregnancy is counted from the LMP date by the clinician. Clinical doctor will say, ask the LMP, and by tradition, we know that when there is LMP, there is no conception. Conception actually has begun 2 weeks later. So clinical or menstrual age is 2 weeks more than the real embryonic age or biological age of the conceptus. So the crux of this matter is that there is pre-embryonic development, or which is before the missed period. After the missed period, up to 8 weeks from the moment of fertilization is the crucial period of main organogenesis. Some think it goes up to 10 weeks, which is clinically 12 weeks of amenorrhea. And thereafter there is fetal growth. This is again the depiction of the same. Here it shows that this, you can see from the third column, heart, CNS, eye, teeth, ear, palate, all these things form. Whereas brain development does continue up to just the formation, does continue up to 12 weeks post-fertilization, 14 weeks post-LMP. Okay, so thereafter it's mainly the growth. This is still more simplified. I have included it just to show that these are the main periods we got to keep in mind. Pre-embryonic period, then period up to day 8, and thereafter the further fetal period. Up to 8 weeks post-fertilization, it's embryo. Thereafter, it's called fetus by medical terminology. And that tells us that up to 8 weeks is the time, 8 weeks post-fertilization. Again, I'm repeating because it's a source of confusion. That means 10 weeks post-LMP, menstrual age, is the time when there is maximum chance of drugs causing teratogenesis. That means major structural defects in the organs. Thereafter, drugs can cause harm, but that is mainly interfering in the function or growth, general growth of the fetus. So the same thing, reiterating it, that before the 18th day after fertilization, matlab missed period se 3 din pehle tak, when the lady misses her period, even 3 days after that, because circulation forms at that time, from maternal blood and fetal blood, embryonic tissues, you can say. Sorry. During this time, the effect is all or none. If the drug is bad, it's going to destroy all the cells. And that will become a biochemical pregnancy. Just when it's implanting, it will get damaged and very early abortion. Or if the drug is not harmful, it may kill a few cells, but because cells are totipotent, omnipotent till then, so therefore normal fetus is going to develop. So this is about the second half of menstrual cycle of the lady. In second half, we still should be careful because it will not become evident. किसी को पता नहीं चलेगा कि आपने जो ड्रग दी है उससे बेबी का बायोकेमिकल अबॉर्शन हो गया या बहुत अर्ली डेथ हो गई है एम्ब्रियो की, प्री एम्ब्रियो की. But still, we should avoid using in general hazardous drugs which are known teratogens in the second half of ladies' menstrual cycle, because there can be total fetal death without even we coming to know that there was going to be a pregnancy. Next is suppose pregnancy ठीक हो गई, so it's a luteal phase rule इसको बोला जाता है जो पहले मैंने बोला है. Luteal phase rule or the second half of the menstrual cycle, better to avoid hazardous drugs. Even though no one is going to come to know if you do administer those. So then now the menses have been missed. It's been 2-3 days since menses and pregnancy is clinically diagnosed. That is day 18 post-fertilization. Fertilization is on day 14 and by day 18 after fertilization, that means about 2 or 3 days after the missed period, the circulation is starting. So whatever there is in the maternal blood, that gets transferred to the fetal tissues very well. Before this, embryo is surrounded by the tissue fluid. So that's through the tissue fluid, which is less efficient in transfer of the substance into the fetus. So now this is the main, between day 18 up to 8 weeks after fertilization is the main period, considered to be the main period of organogenesis. So therefore it's a period for teratogenesis. Teratogenesis means drug causing structural malformation when the organ is being formed. So rarely it may cause spontaneous abortion, but most of the times the drugs cause true anatomic or structural defect. Occasionally it may cause covert, that means which is not manifest or overt, functional defect also. So that's why we need to know certain basic facts. Again, reiterating the same thing, that in first trimester there will be teratogenesis or the organ defect, or totally it will get aborted. In the second trimester, developmental defects, especially neurological, which is important. See, brain is what makes us what we are. So fetal brain may get affected by certain drugs. And in the third trimester, there are different type of obstetrical complications which may result like preterm labor or obstetrical hemorrhage. Now, so we are coming to the main topic, that the drug categories were devised about the same time, 1965, 1970. US FDA, category A, B, C, D, and X. So again, in short, I think most of the doctors know about it. The category A is that there are human studies. Human studies aajkal possible nahi hai because of ethical considerations. You cannot have a control group of pregnant women and a test group of pregnant women for a new drug. Ethically, it's not permissible. And category A is that human studies don't show any fetal risk. Category B is that animal studies indicate no fetal risk, but human studies aren't available. Category C is just in the middle of the spectrum, that no adequate studies are there, but no adverse effects have ever been observed in clinical practice or reported. Category D is that there is evidence of fetal risk, either by studies or by clinical observation, but the benefits are considered, benefits of giving the drug are more than the estimated risk. And category X is the worst category, where we know that there are fetal risks, and even these risks are worse than any benefit which may be there. Now, this classification was there for a long time, but then a lot of controversy arose that which drug to be classified as which, because there were certain conflicting studies that you know that many times we get एक fact है, you can get studies in favor of that or against that as well. And the quality of studies in pregnancy, as I have already said, could not be so good because control or उसमें ethical हम नहीं कर सकते. So these were the drawbacks. Controversies arose about the efficacy and safety of many drugs for use during pregnancy. And most of the pharmaceutical studies or pharmacological studies, they started excluding pregnant women just to avoid litigation, because there were certain litigations where companies had to pay a heavy compensation. And then there was some confusion. A, B, C, D. Some people claimed that isko hamari drug ko A mein karo, B mein karo. So all this was cancelled around the 2012. आज से 12 साल पहले this classification was given up. Sorry. So new FDA classification, rather it's a recommendation. The US FDA then just gave a recommendation that it's we will not classify drugs into A, B, C, D, X. Every drug will have particular information which is kind of certified by FDA, and that was called Pregnancy and Lactation Labeling Rule, PLLR, or final rule. That just shows, that just means that with every drug, the manufacturer or the medical scientists will provide a literature or drug labeling which will describe everything about it, every salient point, that means benefit as well as risk associated with use in pregnancy. So accordingly, so just state the facts. Don't say that it's totally safe, it's totally contraindicated. That's what they concluded because of this confusion. So the and along with that, they said that whatever observations are available, in which phase of the embryonic or fetal development are these harmful. That is again pre-embryonic phase, जो हमने बात की अभी, 17-18 days after fertilization, and embryonic phase up to 8 weeks, and fetal phase 8 weeks onwards after fertilization. And in this, they have to mention that exposure at which stage leads to what. Anyway, so the follow-up is that after about 10 weeks of menstrual age or 8 weeks of post-fertilization age, teratogenesis is less likely, but growth and function of the already formed organs can get impaired. Now, we come to one practical point which is important. See, the teratogenesis is the main concern because it becomes obvious. Everyone gets alarmed that bacha malformed hai. It really doesn't look well. Even those subtle abnormalities of function, even neurological function, may become manifest later on. So this is, for clinicians, it's important to know that in the overall population, okay, I'll hurry up. In the overall population, 2 to 3% babies have significant anomalies. All are not due to drugs. Sorry, 2 to 3% are not due to drugs. There are other teratogens also, genetic teratogens or environmental radiation or certain other factors. Our patients are fond of taking desi medicines. They also may be, they conceal the fact that they have taken desi medicines. So, and therefore, it's really difficult to determine the proportion of congenital malformations which have been caused by our prescription drugs. But still, for example, we know of cases where this Klinefelter syndrome case went to court. They said that the doctor's medicine has caused this. But doctor could easily defend it that this is a genetic disorder, chromosomal disorder. It cannot be due to any drug given in pregnancy at any stage. Then this is a common disorder, a common problem that Ayurvedic or indigenous medicine, Live 52, which may be toxic. They claim that this is not toxic at all, but they don't know really, and false claims are made. Anyway, so what we know already, and we should know, which drugs are really considered teratogenic. This is about phenytoin. So that's why instead of phenytoin of phenobarbital, lamotrigine is now preferred. Fetal hydantoin syndrome. Features are already written. There are pictures on the Google and in textbooks. So because we are running out of time, warfarin, fetal warfarin embryopathy is well-defined condition. If you give warfarin during first trimester especially, you can be held negligent. Okay, why did you give? Because that's why heparin is used in pregnancy. Then alcohol, in our society, very few ladies take alcohol, but this is also a well-defined syndrome, fetal alcohol syndrome. And then this is just a list you will find everywhere, documented adverse effects. These medicines, if you have prescribed in early pregnancy especially, first trimester, then you may be held accountable. ACE inhibitors, you know, carbamazepine is considered safe. Here in this list, they have chloramphenicol is bad if you use it in near term when delivery is due, gray baby syndrome. Lithium, totally contraindicated. Misoprostol is. So this is a list which you will find at most of the. I have just got a copy done from our textbook of a list. This can be distributed. I have few copies, which very well gives you don't have to Google it up. It gives all the groups of drugs, commonly used groups of drugs, whether they are safe or not. But my point is that these are labeled culprits. So here all these ACE inhibitors, ARBs, lithium methotrexate, etc., valproic acid, warfarin should be avoided. And see, these are the lists I have collected from various sources. In every obstetrical source, you will find these. Now, winding it up, for hypertension, which is a common thing, labetalol, hydralazine, and nifedipine. These three drugs are considered safe in obstetrics at any stage. And labetalol is an alpha plus beta blocker. Beta blockers given alone cause IUGR and certain other complications. So this alpha and beta dual blocker is the drug of choice. Methyl dopa is a central adrenergic blocker which was used earlier, and then now it's not available because everyone started using labetalol because of the recommendations. These are certain other cardiovascular drugs. These are mentioned in the list which I have brought the photocopy. So cardiovascular drugs for various purposes. Anyway, now because we'll skip it because of paucity of time, and you can go through that paper which I've brought. Vaccination, lastly, vaccinations, very simple. Live attenuated vaccines are risky because they may cause fetal disease. So killed vaccines or toxoids can be given in pregnancy. Live virus vaccines are which are live virus vaccines, BCG, MMR, and so MMR is not given in pregnancy. And perhaps oral typhoid vaccine is also live attenuated. These are to be avoided. So which can be given? In routine, we can give tetanus. Aajkal tetanus and diphtheria combined, TD is in vogue, but anyway, tetanus is the routine. Second is hepatitis B. A patient who doesn't know her history of having been immunized against hep B should be immunized in pregnancy. And third is flu shot. Flu shot also should be given because flu may cause problems in pregnancy. So tetanus, hep B and flu, THF, is the mnemonic for vaccines which may be given in pregnancy, and the other one is BCG, MMR and varicella, which are contraindicated. When indicated, there are 3 more vaccines which are given to pregnant lady. RMP registered medical practitioner wala, that is for rubella, meningococcus and pneumococcus. Rubella, meningococcus and pneumococcus. Rabies, obviously, dog bite. So at any stage of pregnancy, you have to protect the mother. Meningococcus and pneumococcal exposure, or whenever there is indication. Drug use during lactation, it's really not so important because most of the times the amount of drug in the milk is really not significant, but still we can go through the same list which I have provided. And only practical rule which is useful is for a clinician that if she's taking any drug which you have doubt, tell her that take this drugs after feeding the baby. Take it about 5 minutes after feeding the baby, and then baby will sleep for 2-3 hours. So don't take it during that time. So that's about all this about this basic topic. Thank you so much for patient listening.
Thank you very much for masterly talk. In fact, I must apprise the audience that your prescription slip is one of the most detailed copybook style prescription slip, which indicates the mindset of the consultant for research, academics, as well as patient safety. Thank you very much.
Thank you. But that's because of training, that the way
yes. But a lot of people are trained, they forget training they are earning money and seeing patients, very fast. But you, I believe, see every patient giving 20-30 minutes to each and every patient.
15,
yes.
minimum 15 minutes.
Thank you. Thank you very much.
Thank you for sharing your knowledge.
So we have a change in the schedule. We are adjusting Dr. Dote because he has to go for surgery.
Please welcome Dr. Navdeep Singh Dhot, Associate Professor, Department of Pediatric Surgery, AIIMS Bathinda, to present his topic, Newborn Care.
Good evening, everyone. Today I'll be discussing a very interesting topic, newborn care, and I'll be talking about essential newborn care. We'll be discussing the definition components, how to provide ENC algorithms, and prevention of hypothermia in neonates. Firstly, the definition of ENC. Majority of the babies born healthy at the term, and care during the first hours, days and week determine whether they remain healthy or not, and they have to be put on basic care to support survival and well-being. Includes care from birth till 28 days of life, that is the neonate period. Neonatal death, under 5-year deaths were 37% in the world, whereas in India that was around 50%. But now, because of the advances in NICU care, it has come down to 27.5%. Major causes of under 5 mortality are neonatal sepsis, pneumonia, and diarrhea. And now it has further come down. The sepsis has come down from 45 to 36%. Asphyxia has come out to be a major cause now, 23%. And diarrhea has gone down to 2% only. In India, when and why do neonates die? In India, the neonates die most in the initial first week. Thereafter, in 4th week, it comes down to 4.2%. And the cause of death is usually the sepsis, pneumonia, asphyxia, prematurity, and tetanus. There are 4 basic needs of newborn. That is, one is to breathe normally. Second is to be protected. Third is to be kept warm. And fourth is the feeding part. So first, the interventions: clean childbirth and cord care that prevents newborn infections. There should be a thermal protection to prevent and manage newborn hypothermia. Early and exclusive breastfeeding, which is started within 1 hour of the birth. Initiation of the breathing and resuscitation. Early asphyxia identification and management plays a key role. Then comes the universal precautions and cleanliness. Hand washing, gloves, protect yourself. We have to protect ourselves also from blood and body fluids, because many a times we have come across HCV positive babies also, HIV and HCV born. We have to protect ourselves from blood and blood products. Sharps and waste disposal should be adequate. And we have to deal with the contaminated laundry as well, and sterilize clean contaminated equipments. Hand washing, essentially, we should keep the baby in a cold-free, warm room where the temperature should be more than equal to 25 degrees Celsius. And use a clean, dry, warm delivery surface. Use a radiant heater. 2 clean, warm towels, clothes, dry wrap and cover the newborn baby is a must. And folded piece of clothes are also available. And preparing for the birth, we should have a suction device, newborn size, self-inflating bags, mask, laryngoscope, oxygen supply, disposable medication should be available properly. Care of the baby at the time of birth. Until around 1 hour after the birth, provide routine care at the birth for all newborns, and identify and manage newborns who may need special care. I'll be discussing in detail about those babies requiring special care. In routine care, call out time of the birth, because time and date is very important. And kangaroo mother care, we are all well aware of. That prevents hypothermia, and there is a bonding between child and a mother. Dry baby, wipe mouth, nose with a clean cloth. Assess breathing while drying. Clamp cord after 1 to 3 minutes. Cut with sterile instrument. Put sterile tie. And there may be bleeding from the cord because of the ligature, slippage. So we have to take care while tying. Put identity label on the baby so that babies don't get exchanged where there is a high load of in the delivery room. So examine for malformation, congenital birth defects, and birth injuries. Initiate breastfeeding within 1 hour. Record baby weight. Give injection vitamin K 1 mg intramuscular. 0.5 is for the preterms. And cover head with cloth. Cover mother and baby with warm cloth. And for the resuscitation, all babies must be assessed for need of resuscitation at birth. At least one person skilled in providing resuscitation must be present. Ventilation must be started within 1 minute of birth so as to prevent asphyxia. And brain damage. First golden minute, resuscitation flow charts that depicts at the time of birth, when we receive baby, there should be dry, warm linen wrapped around the baby. Then we have to see whether the baby is crying or not, or breathing. If child is crying and breathing, routine care, dry baby on mother's abdomen, provide warmth, skin to skin care, and assure open airway if needed, cut cord in 1 to 2 minutes. Ongoing evaluation of the neonate should continue. If child is not crying or breathing, cut cord immediately and place under radiant warmer. Provide initial steps, dry position, clean airway, tactile stimulus. If the child, in 30 seconds, if the child is gasping and apnea or heart rate comes down below 100, then we have to, there is no labored breathing, there's no cyanosis, then we can continue with the routine care. If there is gasping and apnea, then we have to initiate positive pressure ventilation using air and oxygen. And with the positive pressure ventilation, heart rate after inflation should not be less than 100 beats per minute. If heart rate is above, then further evaluation, routine evaluation can continue. But if it is less than 100, then look for the chest rise. If not, reduce any leaks, ensure open airway, consider increasing pressure. If heart rate still goes down below 60 beats per minute and chest rising is less, continue positive pressure ventilation, add 100% oxygen, start chest compressions. And if heart rate is not detectable or is less than 60, then we have to give adrenaline at 0.01 to 0.03 mg per kg IV. Or we can we can intubate the child and put adrenaline via the ET tube also, 0.05 to 0.01 mg per kg. Now, where do babies go from the delivery room? We have to refer the babies if the birth weight is less than 1.5 kilogram, or if it is less than, if it's a preterm baby. Major congenital malformations are to be looked for, which is, we have to look for surgical correctable birth defects or otherwise also. Severe birth injury should be checked. Respiratory distress, positive pressure ventilation for 1 minute, or needing chest compression or drugs, we have to refer them to NICU, neonatal ICU. Observation care, birth weight, if the birth weight is between 1.5 to 1.8 kgs, or intermittent positive pressure ventilation, less than 1 minute, or vigorous. Now, immediate cord care, clamp or cut cord with the sterile instrument only, and use a sterile thread only, or a sterile clamp. 2 to 3 centimeters above the base, because I have seen many times, being a surgeon, I have operated on so many babies there was umbilical hernia, and cord was and gut was clamped along with the cord. So you have to check for the umbilical hernia while clamping the cord, and by default you have to clamp the cord 2 to 3 centimeters from the base. Observe for any oozing or blood. Do not apply any substance on the stump. Do not bind or bandage the stump. Let it be open. Leave stump uncovered. Now, newborn can lose heat in 4 ways: radiation, convection, evaporation, and conduction. Now, keeping a newborn baby warm after delivery is our utmost objective. We have to decrease the evaporation by drying the baby with a clean, warm, dry cloth. The conduction by kangaroo care, put the baby on the mother's abdomen or on a warm surface. And the convention, we have to keep the room warm, draught-free room with more than equal to 25 degrees Celsius. Then radiation losses can be minimized by keeping the room warm. This is the typical picture which shows kangaroo mother care. This enhances bonding, increases lactation, and this keeps the baby warm, prevents hypothermia. And there's no need for a mother to do this kangaroo care. Any person in the family can do it if mother is undergoing a C-section or otherwise. So any family member can do it. So skin to skin contact, any family member can do it, not less than 1 hour at a time. And it is useful for especially low birth weight babies. And it provides warmth, promotes breastfeeding, protects from infection, emotional bonding is there, physiological stability which reduces apnea, and multimodal stimulation. Now warm delivery room should be there, immediate drying, skin to skin contact at the birth, breastfeeding, bathing and weighing should be postponed because it can cause hypothermia and infection if it is done in hospital scenario. So it should be postponed. You can clean the baby properly using wipes. Appropriate clothing and mother and baby together should be kept together, and warm incubators should be used for transport. Now something about the breastfeeding. It should be initiated within first hour of the birth, and a trained nursing officer should or a junior resident or doctor should help mother at the first feed. We should ensure good position, good attachment and effective suckling. So postnatal environment should be kept warm. There should be no draughts. Temperature should be more than equal to 25 degrees Celsius. Mother baby kept together in same bed rooming in, which is called as rooming in. Bonding can respond quickly when the baby wants to feed, reduce breastfeeding difficulties. We should ask the mother, do you or baby have any problem? Has infant passed stools, urine? Have you started breastfeeding? Is there any difficulty in feeding? Do you have any pain while breastfeeding? Give any other food or drinks to the infant which is being done by the relatives. So examine the baby, count breaths for 1 minute. It should be normally 40 to 60 breaths per minute. Sometimes it is 30 to 40. But look for severe chest indrawing, look and listen for grunting. Look at the umbilicus. There is any redness, draining pus. If there is a feculent, rule out Michel's tuberculum. If it is watery, rule out patent urachus. Look for skin pustules, 10 or more pustules, or a big boil. Then auxiliary temperature can be taken, which is informative, lethargic. Check for lethargy, jaundice, and congenital malformation. Now, if not fed in previous hour, ask mother to breastfeed and observe for 4 minutes, and check whether she is able to attach. For attachment, chin should touch the breast of the baby, and mouth should be wide open, lower lip turned outwards, more areola above than below the mouth. Help mother to position, infant suckling effective, slow, deep sucks, and sometimes pausing. Not sucking well, ulcer or white patches in the mouth should be ruled out. Difficulty or painful feeding, then check for the mother's engrossed breast or breast abscess, flat or inverted, or sore nipples. Then Melia, Epstein pearls, Mongolian spots, enlarged breast, capillary nevi, they should be checked. And transitional stools, which usually occurs from meconium to takes 2 to 10 days for normal colored stools. That should be checked. Vaginal white discharge, bleeding due to maternal estrogen can be checked. Red rashes on the skin, 2 to 3 days of life can be checked. Weight loss, 6 to 8%, which is 10 to 12% in preterms. First few days of life should be checked. And skin and eye care, not bath routinely in hospital. Hypothermia infection should be checked, maybe. And child may be sponged with lukewarm water, and no routine eye care is required. But if there is a watering in the eye, then tobramycin can be used. Immunization, BCG, OPV, and hepatitis B is to be given at birth. Now follow-up. First week on day 3 and day 7 of the delivery, low birth weight, day 14, 21, and they should be called every weekly. And growth development and signs of illness should be checked. Health education of the parents, and once every month for 3 months, and subsequently 3 months till 1 year should be called upon. Summary: basic care to support survival and well-being is essential newborn care, and ventilation must be initiated within first minute of life. Help to initiate breastfeeding with the first hour of the birth. Identify and refer neonates requiring special care, and prevent infection and hypothermia, and conceal mother for the danger sign, and immunization and follow-up. Thank you. I have to share one incident which has occurred recently. There was one child who was operated outside. Some gynecologists have operated on that child, and I got a call at night. I was not here. I've gone for a conference. So I've got a call that night saying that all the attendants of the child, they are against our life. They are saying that during the surgery, we have given an incision over the patient's abdomen, and we have opened in cesarean section, we have opened the abdomen, and all the gut are lying outside. So this is a common mistake, because we usually get the radiology people, all the doctors who are doing ultrasound, they have not picked up any gastroschisis or omphalocele. Actually, that was a child with gastroschisis. So they have not ruled out gastroschisis, and that doctor's hospital, all the glasses were shattered, and all the attendants were sitting outside the AIIMS main road. We're going to block that road, and it was a big mess, because the radiologist didn't pick out gastroschisis, and it was all the blame came on the gynecologist who has operated and done cesarean section. And I tried to convince the attendants, and somehow we managed to and we informed them well that that is a congenital anomaly, that is not caused by a gynecologist, that is just mere a congenital anomaly which can be corrected. We can operate on it and it can be corrected. It is not the blade of the gynecologist which has done all the abdomen, there's an incision over the abdomen and all the gut are lying outside. So this is we should get proper ultrasound before treating such cases, because if radiologist has missed that point, then all the blame comes on the gynecologist. So that the take-home message is we should thoroughly investigate the child before taking any surgical procedure. And thank you.
Thank you, Dr. Navdeep, for a great talk. In fact, newborns care is the most important for health as well as future disability, mortality and morbidity. And I think Punjab is lacking behind, because we are at the middle of maternal mortality rate as well as infant mortality rate. Yes, thank you very much.
Sir, in India now the mortality rate has come down from 50 to 27.5. That is a milestone for us. Yes. So we are able to achieve that, sir. I will be happy to answer any questions, any queries if you have regarding this topic. Okay, thank you.
Okay.
Thank you for sharing your knowledge with us, sir. Now, we'll move forward to Dr. Poonam Bharti, Professor and Head, Department of Psychiatry, MIMSR Mulana, on her topic, Recent Advances in Psychiatry.
Thank you, madam, for considering our request to give slot to Dr. Navdeep.
No issue,
so thank you very much.
Thank you, sir.
And your topic again gets very much important, because we will be listening to all the recent advances, a very broad aspect, right, and you will have advantage of free time. So there is no one after that. So we want to listen the recent advances, because psychiatry itself is a very big subject and very complicated. आप किसी को भी पागल बना सकते हो कि साइकियाट्रिस्ट ने मोहर लगा दी, अब तो तू पागल ही है.
नहीं सर,
थैंक यू.
हम ठीक करते हैं पागलों को, हम बना नहीं सकते. So good evening all, and I welcome you all over here. and pay my gratitude to Dr. Vitul Gupta, who always gave me a chance to be a part of this MAPICON Academic Fest on day 2. So myself, Dr. Poonam, you all know that I am a professor and head in Maulana University. So here the topic is the recent advances in psychiatry, on which I will be discussing. So I had divided my whole presentation into 8 parts, where I will be taking up the digital interventions in psychiatry, number 1. Then the neurostimulation therapies, which are available right now. I will be discussing little bit about them. Then the artificial intelligence, how it is helpful in psychiatry. Further, the detoxification of opioid and other substance uses. Then the involvement of the genetics and biomarkers along with the radiological interventions. Further, moving to the newer drugs which are available with the non-pharmacological CBT therapy and psychedelic assisted therapies. So, as we all know, Pagal ke word is very commonly being used by everyone wherever we go, and always the people laugh on us and smile, and it's like this only. Everybody is like lot of huge stigma and neglected part is available, attached with the psychiatrist and the mental health. It's not only the general population, we all are doctors, still we are talking in like that only. So new advances are very much important, though the conventional and traditional methods are also important in the management part. Further, if I go on the census prevalence, the National Mental Health Survey in 2015 and 16 reported that nearly 150 million people, they are suffering from mental health, but only 30 million, they are seeking the mental treatment. In 2016, the National Mental Health Survey reports that 5.1% Indian population, they commonly suffer from a common mental disorders. They are like anxiety and depression. In 2023, NCBI article reports that the prevalence is increasing day by day from 9.5 to 37 people per 1,000 population. So it's the number is increasing day by day. Current challenges in psychiatry is there is a shortage of mental health professionals per population who is suffering from the mental health issues. Overburdened health care infrastructure is there. In the rural area, there is a less of the psychiatrist, psychologist available, and even they don't have a knowledge of this thing that they are suffering from any kind of psychiatric issues. So a lot of stigma is attached. Need is the integration of the primary health care services along with this, so that we can provide the mental health troubles, issues should be addressed properly, diagnosed properly, and then treated and managed properly. So need is for the systemic and the newer technology. Now, my first part on the digital mental health, there is, after the COVID era, that we all in pan-India, pan-world, everywhere suffered this issue. Mental health apps became an online platform, became a way to consult the patient. The doctors use these, in which I will be discussing 2 main, Telemanas and eSanjeevani. In this, the digital mental health transformation has been seen from digital mental health apps to the use of artificial intelligence and the robotic and sensor mechanisms which are being used. Here the speech analysis, facial expression analysis, from there we go on. In this graph it is seen that the chatbots are used. Even we are using the various robotic and sensory methods where the facial expressions, they are being picked up, and we can have a digital details of all the history. Psychiatry history, it's usually 25 years, 30 years or 40 years, the patient is suffering from so many disorders. We can have a systematic analysis of all the disturbances, and prognosis can be easily made out of it. The various technologies now, I had already discussed in my last slide about this digital intervention, combining the traditional and current methods, the chatbots and the VR and AR technologies, which are very much helpful in the anxiety disorder as in desensitizing the various issues. Now again, supposedly I talk about American Well. There have been a lot of chatbots and the digital ways, apps available for diagnosing the mental health, preventing and also managing this. Now talking about the telepsychiatry, it is a kind of a video conferencing which have been well established in US, Australia, Canada, and Europe. This is a kind of a conferencing which is easily done through with a consultant and a patient, especially in remote and underserved areas. But again, we can talk about, we are dependent upon internet facilities for using this facility again. So, and even the person who is using the video conferencing or using the telepsychiatry must be master in using the digital interventions and interface. It's not that easy. A person can be easily the benefits. Benefits is a broad spectrum. A certified psychiatrist anywhere can be available. You are not supposed to take a work off from your place and need to go. It can easily fit into your normal schedule. And even the young patients, they are more comfortable using this telepsychiatry app. So Telemanus is a very important app, which is a national tele-mental health program, which is being launched in India with a toll-free number. And the last digits are 14416, very important, through which it's like an automated call generated through IVRS, and it connects to the counselor. As we do the triage in the emergency, similarly, the patient who is reporting the severity of mental illness or the issues according to which the counselor will divide it, will make the patient to know that he or she needs a mental health specialist. Then further, the patient will be registered on eSanjeevani app, and further through the PHC, CHC or other institute, the patient can take the help of a psychiatrist. eSanjeevani, it's the way how we have to cover the universal health coverage is needed, and it's a quick and easy access through the smartphone. We do a registration through a smartphone. There is a login, SMS is given. As we get an OTP, we register, we do a waiting room is as per the availability of the consultant, and then the consultation is done. My second part of this presentation is the neurostimulation therapies. In this, it's a kind of a stimulation we provide to the various brain organs, invasive and non-invasive, to get rid of various mental health issues, in which there is a repetitive transmagnetic stimulation, deep brain stimulation, vagus nerve stimulation, modified ECT, and video EEG. So my first is a biofeedback mechanism. It's a kind of it's a technique how it controls the various physiological processes in which we measure the heart rate, muscle tension, skin temperature, and the brainwave activity. Now this is a way how this is performed. There is a patient in front of a visual screening where there is an audio and visual signaling is given to the patient, and a loop is formed between a patient and a screen which is provided in front of it. And the various measurement of the heart rate, skin temperature, and the brainwave is done, and the patient gets information about his or her physiological symptom and asked to do some kind of relaxation exercises, so that a loop is found and a biofeedback technique is used. It's basically approved for all these things: stress and anxiety, mood disorder, attention deficit disorder, pain management, migraine, headache, sleep disorder, and PTSD. Second is deep brain stimulation. This is an invasive procedure, and there is an implantation of a device or electrode, and there is a pulse generator which is under the subcutaneous in the chest. So this is being, the different organs of the different parts of the brain are being targeted according to the disorder. So deep brain stimulation is used in various kind of addictions: anorexia nervosa, cluster headache, Alzheimer's, Tourette disorder, Parkinsonism, obesity, chronic pain, dystonia, obsessive compulsive disorder. So for example, it has been approved for the first three: Parkinson's disease, essential tremors, and dystonia. The target organ is subthalamic nuclei, thalamus, and globus pallidus. Now, where it is available? It is available in AIIMS Delhi, NIMHANS Bangalore, and NIMS in Hyderabad. So the cost factor, it ranges from 10 to 15 lakh in total. Modified ECT, the important part is already the ECT is being again used with the name of a psychiatrist. Ek word pagal or ek bijli lagana, though words most commonly used hote hai. So modified ECT is a way when there is a use of a sedation or anesthesia along with the giving the electrical currents to the brain, and which will generate a epileptic episode. I think everyone is more, there is a two types: direct and modified. Direct is without anesthesia and modified is with anesthesia. So Then comes the video EEG. It's the recording of the brain waves, what is happening when the patient is having a seizure in 24 hours. So the various brain activities is recorded through the EEG wave, alpha, beta, gamma, delta and theta. They have the different frequencies and they have the different properties from where we can come to know what is the patient is having. The purpose of video EEG is to find out the type of the seizure, the exact brain area which is involved in the epilepsy. Third is the repetitive transcranial magnetic stimulation. This technique is, the coil is in the form of 8, is placed near the brain. So it will generate a magnetic field. This will generate an evoked induced electrical current. This will generate an evoked potential, further stimulating the nerve impulse and the target organs. Now this condition, this was first in 1800, it was realized that the nerve cells, they carry electrical activity. Gradually in 1985, it was first time the RTMS idea concept came into light. In 2003, the Canada approved the RTMS for the depression. 2008, US FDA approved it for the depression, and further in 2020 also, it is not only for the depression, it is also approved for the OCD. Clinically approved for depression and obsessive compulsive disorder and few addiction in smoking. But the proof is, there is a widespread used only for depression and OCD and addiction, but for others, still it needs the approval, and the under trial is going on for various other psychiatric disorders. It's available in all these centers, PGI Chandigarh also, AIIMS Delhi, NIMHANS Bangalore, because many of the times the patient asks from us where these procedures are being done and what will be the cost. I think this is also very much important. Everybody must know where these procedures, invasive procedures, are being carried on. Then comes the vagus nerve stimulation. Again, it's a parasympathetic system. Vagus nerve is known for the rest and digest. As adrenaline system is for the flight and fight, this is parasympathetic is rest and digest. So it will be more helpful in the patients who are suffering from anxiety and depression. As well as this is have been approved treatment for the treatment-resistant depression and epilepsy. The treatment-resistant depression itself means that the patient, let me tell you first how this device is being implanted, and it is implanted in the left vagus nerve, not the right vagus nerve, because it innervates the SA node, right one, and it leads to the cardiac arrhythmia. So left vagal nerve is targeted, and the coil is being encircled around the left vagus nerve, and there is a pulse generator. Now the important part for me as a psychiatrist is the brain activity. As it is a parasympathetic, it helps in the resting and decreasing the muscle tension and anxiety symptoms, so more useful in depression and anxiety part. So I had already told it is useful in epilepsy and treatment-resistant depression. Resistant means already you have given a trial of 2 to 3 different classes of antidepressant for an adequate time period with the adequate dose. But if a patient is not showing improvement, then the patient can be taken as an indication for the vagus nerve stimulation. Again, available in AIIMS Delhi, NIMHANS Bangalore, and the cost ranges from 2.5 to 5 lakh per this procedure. Artificial intelligence, again, very much useful. In my first third slide, I had reported that it helps in the mental health, recognizing, diagnosing the various mental health disorder by speech pattern, facial expressions, and other behavioral clues. So it analyzes the vast amount of data depending upon the new patterns, and the long history can be analyzed easily. From monitoring to treatment, predictions, and diagnosis and deep learning of the brain, the artificial intelligence is very much helpful in the psychiatry. So it gives a better personalized care, shorter waiter period, removes the barrier of the treatment, and boosts the efficacy. Now the third part of my presentation is detoxification. I will be talking about more of the opioid, because in this already the patients, they are put on buprenorphine treatment. And here I will be talking about the 3 parts: conventional way of, traditional way of treating the opioid withdrawal, rapid detoxification, and ultra rapid detoxification. Ultra rapid detoxification can be done within 1 day. Rapid detoxification, it needs 2 to 5 days. And traditional method, it can go from 3 weeks to 1 month, 4 months, or 5 months. It's a long period. So the difference among all the three is the traditional method with the use of an opioid agonist, it may take months together, years together for a patient to get detoxified. But if I talk about the ultra rapid, in this the opioid antagonist IV, in an IV form, it is given under the anesthesia, general anesthesia, and the withdrawal is created. So what exactly happens? The opioid, when the patient is continuously taking an opioid, it becomes sensitized to that substance. We have to desensitize the brain. So it is done within a day under the anesthesia. It's an ultra rapid way of doing the a single large dose of opioid antagonist is given when the patient is unconscious during a withdrawal state. So it helps in, and with the anesthesia, we can achieve the ultra rapid detoxification. So there is also the risk factors which are being attached with this, because the patient can possibly can have a problem of pulmonary edema, can get into delirium, there can be electrolyte imbalance also, there can be excessive catecholamine release also, and altered cardiopulmonary functioning issues can also be there. This is already I had discussed the traditional way of opioid detoxification and the rapid way of opioid detoxification. Now my fourth part of this presentation is the genetics and the biomarkers. Again, if we go through the precision psychiatry, to give a, if I talk about, if I want to give a tailored treatment plan to any of the person, I must know the genetic formation of a person, genetic makeover of the patient, along with the use of the neuroimaging. So in this genetic and biomarker research will be helping from the diagnosing, monitoring, and also giving to the prognosis and the treatment part. All these are included in the precision psychiatry. The sixth part of my presentation is psychedelic assisted therapy, which is very commonly right now these days being used. Even the ketamine and S-ketamine infusions being used in the patients to induce the attention-free state of a patient. So psilocybin and MDMA, ketamine, S-ketamine in conjugation with the psychotherapy gives a promising results in the post-traumatic stress disorder, depression, and anxiety. So in this, what exactly happens is it increases the neuroplasticity, dendritic and spine formation growth, axonal branching, and synapse formation. It helps in decreasing the anxiety, depression, and PTSD episodes. This is the magic mushroom. So LSD and mescaline, and these are being agonist, having an agonist action at 5-HT2A receptor, which directly releases the serotonin and the norepinephrine content, and which is helpful in treating the anxiety and depressive disorder. So MDMA, it's 3,4-methylene dioxymethamphetamine, again a stimulant which is given. It's known as empathogens, which is helpful in attachment, trust, empathy, and interpersonal connectedness. So psychological responses will be euphoria and increase in energy. Physical dependence will be there. Again, it's a sympathetic, so it will be having a cardiogenic effect also. It will also raise the blood pressure. It will lead to hyperthermia, dehydration. So these are the physical symptoms which are associated. So ketamine and S-ketamine, ketamine is non-selective, non-competitive antagonist of NMDA receptor, which prevents the brain from excessive excitatory glutamatergic neurotoxicity. So, but on the other hand, it also helps in the reducing the severe depressive episodes within few hours. So the way how we give it, intravenous, intranasal, intramuscular, and oral dosage. This is how the absorption takes place. Intravenous 100% absorption is there, and it only takes 2 to 3 hours to give the best results in the severe refractory depressive patients. Newer clinical drugs, there are a lot of advancement has been seen in the psychopharmacology. Now, previously I discussed the neurostimulation therapies. Now I am talking about the psychopharmacological therapies which are available with more effectiveness and less side effect profile. But there have been a lot of clinical trials have been going on, and few of them have been FDA approved for the treatment of the various disorders. It's a long list. I will be passing on. and will be sharing my slides, can go through various the ways how the receptor activity and all those cognitive enhancers are also there. Now the mainstay with the non-pharmacological concluding slides will be the therapy, the behavioral therapy, which is most commonly, traditionally, conventionally also used, was the CBT. It's a cognitive behavior therapy. The core is, it is very much focused treatment for the present day challenges the person is suffering from. Now, last slides are future directions in psychiatry. It's like the psychiatry in the next decade and beyond will be the primarily a consultative specialty, both for the other physicians and allied. No doubt the licensed psychiatry is working a lot, because each and every day we get so many calls from ICU, from the each and every department, almost 10 to 15 calls from the different departments we get because of having delirium part, depression, anxiety, because the prevalence rate is also increasing. So with the use of a neuromodulation and advancement in the psychopharmacological focus, advanced practice providers will be there through the apps. Digital mental health, already I had discussed, will be helpful. AI integration will be more helpful for predicting, modeling to inform the treatment plans. Multidisciplinary teams, it's very important. It's not only the psychiatrists, sometimes neurologists, neurosurgeons, they have to collaborate together to focus and to work on the, sometimes the person is suffering from Parkinsonism, but along with that, the person is also having a depressive symptoms. So in together, because dopamine decrease in the dopamine level can lead to Parkinson's symptoms, along with that, it can also lead to the depressive symptoms. So collaborative team is required. Virtual care, the AR and VR, augmented reality and virtual reality is very much important in desensitizing the programs. Integrated services are important, which includes the psychology, neuroimaging, neuromodulation, and surgical interventions. That is the deep brain stimulation. Crisis care, the suicide as it is becoming very highly increasing day by day, and the patients, the people are getting targeted because of this suicide, high suicide rate. So crisis care must be for that, new units must be taken in consideration to take care of all these patients. Summary is, there must be an integration of digital tools, which includes the mobile apps, AI-driven chatbots, VR technologies. Genetic profiling, the biomarkers must be taken in consideration so that we can focus and give a personalized care to the patient. FDA approved digital therapeutic apps, as well as the neurostimulation therapies, which I had discussed, must be taken in consideration for various treatment of the various mental health issues. No doubt we all are working on all these things, but we cannot forget that there is still shortage of mental health professionals to provide the proper treatment to the patients. Thank you all for your patience listening. Any questions anybody wants to discuss, or we can have an open house discussion also, if anybody wants to talk. Actually, sir, it was a huge elaborated. I had to reduce it down.
What we can make out of it is, ketamine is a drug we commonly use in
Anesthesia.
Yeah, so what kind of dosage are you
So,
using for this purpose?
yes, so there are different dosage. Usually it is used for the anesthesia only. Sub-therapeutic dose is given for inducing the delirious state. We have to, but not in a complete anesthesia, because in that state, we have to decrease the heightened sense of anxiety level or depressive level, the thought. We have to disconnect the patient, whatever the patient, any thoughts which are provoking the anxiety in the patient, in depressive thoughts also. We have to break down that chain of thought, basically. So sub-threshold value is given. Along with the anesthesia team, in the OT only, we provide this therapy. And the dose is we have to titrate according to the body weight, 0.5 milligram per kg body weight. And that is given IV also, and slow according to the clinical profile of a patient. So, thank you, sir. Thank you, sir.
Thank you, ma'am. With this, we come to an end of second day's scientific program. So we had very diverse lectures. We started with diabetic foot and ended with recent advances in psychiatry. So we included the topics related to oral health, the chest diseases, skin issues, diabetes problems, and psychiatry.